And when everything is upside down, when you're yelling but you make no sound, life is gonna spin you round. Whoa, and get a little bit stranger. When everything is upside down, a tremor in the underground, the nights are gonna take this town. Whoa, and get a little bit stranger, stranger. Push the kinetics, a troubled spirit breaking through, a bitter debt to repay now. But don't you dread it, a friend would never lie to you, helping you get through the pain now. And when everything is upside down, when you're yelling but you make no sound, life is gonna spin you round. Whoa, and get a little bit stranger. When everything is upside down, a tremor in the underground, the nights are gonna take this town. Whoa, and get a little bit stranger, stranger. Lost in the space set behind, hold out a hand in your mind, don't have to face it alone. It's in the spaces behind, never watching you. It's in your sight when you're blind. And when everything is upside down, when you're yelling but you make no sound, life is gonna spin you round. Whoa, get a little bit stranger. When everything is upside down, a tremor in the underground, the nights are gonna take this down. Whoa, get a little bit stranger, stranger. Lost in the space set behind, hold out a hand in your mind, don't have to face it alone. Lost in the space set behind, hold out a hand in your mind, don't have to face it alone.
Welcome to the Biohacking Village at DEF CON. This is our 6th year. I am Nina Ali. I am the executive director. This is my 5th year of running the village. Thank you for coming. I want to let you know that this year has been quite an adventure. It's been very similar to one of those choose your adventure books where it's just so many options and you're working through everything, trying to make it all work. I decided last year that I was going to do the keynote, but I knew that I didn't want to do it myself. So what I have done is accumulated folks that I know, folks that I trust, and people that have very strong expertise in their fields. And I talked to them. And I want you to know that I did not prep them for these interviews. I did not give them questions beforehand. Everything you see is raw emotion, raw gut reactions. And I think the information is really important, especially right now and for the future of where we are going to go with healthcare and how we can secure it and make patient safety a priority. Thanks for watching. Hey,
Hey,
how are you?
I'm getting you.
I'm okay. So I brought you here because I want the biohacking community to see the people that I talk to, see who I engage with, see where my brain thoughts lie, and who I talk to at 3 a.m. Eastern time when my brain isn't stopping. So quick origin story on you is
I met you 3 years ago. Jason Street gave us the introduction of Black Hat, and yes, I do remember everything. Good brain. And then my talk got accepted, point to own my own pacemaker at Biohacking Village. We kind of just fell into a friendship, I think. It was just instantaneous, like I knew you my whole life. I remember, like, with my first talk, we shared tequila. I really needed it. And yeah, 3 years later, we're still kicking ass, taking names, and planning big things.
we became instant friends, and we have continuous dialogues at 3 a.m. Eastern, depending on times here, between like 8 and 9 a.m. your time. What are you working on right now?
Working on standardizing and defining shit. I'm slightly tired of us, having this cookie cutter approach to medical security and healthcare security. Because let's face it, this is not a Windows 10 machine or the standard endpoint we're dealing with. Right? Each one has a different way. So why are we making it harder on ourselves by not defining and standardizing? So that's my pet project, is just to get the shit right, define it out, and let's understand what we're dealing with. Let's listen to the devices. Let's not do all the talking. Let the data speak.
What's your call to action to the community?
I think the biggest thing I've realized is, as a community, we can't work together, can't listen to diverse, objective stories. So just because someone disagrees with you doesn't mean they're wrong or you're wrong. I think the community as a whole, we should approach this not just about finding problems, we should be finding the solutions. So we should be the builders, the breakers, and the pioneers going forward. But it takes a village, pun intended, right? Yeah, I did it. I did a mom joke.
Seamless plug.
Yeah. We need to do better. Shameless plug. Hey, don't always see someone that's 5'0". I have an opinion. I have a voice. It's not refined. It's not pretty, right? I'm going to call it as I see it, but don't always take offense. It comes from a good place. And if you want someone to do log analysis, it is what I eat for breakfast, lunch, and supper. I love logs. I love data. Because I believe we can't wait for something to happen and ask, where's the data or where's the evidence? I want to build this shit in now. Because come 10 years, I can turn around and say, hey, you claim you hacked this device? Well, motherfucker, you did not.
Who do you want to collaborate with?
Everyone. But I see it as a trifactor, right? It's this triangle. Engineering is awesome, and I'm geeking out on it because recently I got exposed to an MDM, and I got to see the engineering pipeline, which led me to build parsers in Python I never thought I'd do, because I was convinced the internet would blow up if I designed something. And I realized that we have a regulatory body, we have an MDM, and we have researchers. And that's what's going to make the future better, is these three elements working together to strengthen healthcare and medical security. But we shouldn't be imposing things that break healthcare or medical devices further. Because people like me, this one sitting here, I need this device. And if we make it so hard that manufacturers stop doing it, people like me won't have a second chance.
So I think you know me well enough that I'm going to throw random things at you.
Oh, I can see your brain going. I've been expecting it, so bring it on.
What's your controversial opinion?
My controversial opinion is this, that imposing SBOMs into healthcare and expecting them to take on the manufacturer role is going to lead to it breaking. And the reason being is the manufacturer has the responsibility, the ownership to maintain their shit, build them better, and keep them safe. But here's the thing, we're expecting hospitals to do this. COVID-19 came in worldwide, globally, swept it, broke it, and this is something they built to do. They're supposed to deal with viruses and pandemics. So if we make cybersecurity of medical devices their responsibility, we're expecting them to thrive in something they're not built to do, and they're not ready to do. So yes, SBOM for manufacturers, hell yes, bring it on. They should be doing this shit. It's manufacturing. This is not a hospital function.
As a biohacker that works in technology, how do you want to better integrate with regulatory folks, with political entities, with hospitals, etc.?
I just want to be given the opportunity to be heard, and I want to listen. I want to listen what they need to have done, what help they need, right? This is not a me against them. This is saying, let's put our brains together, right? Like, one collective brain is not enough. We need this diverse group. And this is why us talking is so awesome, because I never knew that patient records was as important as it is until we had the discussion and we had an argument, right? We had that, we disagree. But the fact is, you showed the data, you brought the data, and you changed my mind. And the thing is, we shouldn't be scared to be wrong. We should be acknowledging that, hey, this is not going to work, or hey, we made a mistake. Because it takes a stronger entity to do that than trying to hide it. And that counts for MDM, hackers, anyone. I have big enough balls to tell you if I was wrong. Because that's the person that I am. I own my shit.
How do you want to leave this? What's your message after this?
That together, we can change the world of healthcare and medical device security. Because we're dealing with a legacy of devices, an ocean full of them. 600,000 new implanted devices a year. They last 10 years at a minimum, right? That is a legacy that I don't want to see increase yearly. The time for change is now. Not yesterday, not tomorrow, now. Because otherwise we face legacy. It's going to come back and bite us in the ass. And patients like me won't have access to these devices. Because their first and foremost function is to keep us alive and give us clinical and healthcare related support. They're not there to be secure. I mean, for fuck's sakes, if I have to tell the doctor, hold on, you need my username and password, or you need my cryptographic keys, I'll be dead. I saw that. It's in a split second. So let's get this shit right. Let's do it now before legacy comes back and bites us in the ass. I want your controversial opinion on recording as well, seeing as you fucking throwing us all under the bus. What's your controversial?
Well played. My controversial opinion. Electronic medical records are not looked at by anyone, and it's exhausting. You and I had this conversation. It's everybody looks at medical devices because they're tangible. They're something you can hold on to and you can pick up off of eBay and, find a thing. But electronic medical records are hoarded so intensely, and they're not in a lot of legislature. They're not really defined. They are not medical devices. And because they're not medical devices, we, the group, don't necessarily treat them well. But when you look at it, I can have a medical device that does one thing. It holds one source of information, right? Like your heart pacemaker holds your heart information, where the electronic medical record holds all of the information. So when you look for that wealth of data, and I'm going to find this one thing that's very specific, or I can find all of it. And that's what I've done. I've did it for so long that when people say, like, this is the most important thing, I'm like, yeah, but you're getting that information how? There's so many links into this one small piece and just no regard to it.
Yeah, but I think the problem is because we're not defining the shit, right? Because that is like the ultimate gold mine. It's not necessarily a device, but it's a container that holds everything, right? If those are the keys to the kingdom, it's the ultimate
Exactly. How did
IP.
diabetes happen? You can have the one thing, you can have the pacemaker, but you need all of the other things to make an educated system. There's educated decision. There's clinical decision support built into this thing that will say, this, you're going to give this person a defibrillator of some sort. Oh, BT dubs, did you know that this person, you can't give him this one because of whatever reason this is? It's a support system. It's a container. It does all the things. Now you've got me riled up. Thank you.
It's a treasure trove. That's what it is.
I've done talks about this. I can own your pacemaker and like, oh, I got a thing. Ooh, it's worth how much? 50?
No.
500? I can own a hospital because that's essentially what you're doing once you get the EMR. Because you get into the EMR, you get into everything else because it's all connected, because of the APIs, because whatever is going on, and it's just gone. And that's exactly mind-blowing to me.
But I mean, the purpose of cybercrime, right, is about money. So what can I sell and what can I keep on selling? And how can I get, have persistence? Exactly. I mean, it's the product that, forever paying, because everyone's going to want to have that.
Oh, and while we're here, because now I'm upset about life, they're not even connected. So like New York does not connect to DC, which doesn't connect to Seattle, which doesn't connect to anything. So me as a human, I now have to regurgitate my whole life history of all the things that are right and wrong with me, because you don't know. I can make all of the things up. I can negate so much information.
Did you know that 18% of healthcare workers indicated that for the right price, they would sell their data?
Yeah, insider threat, right? We overlook it. And there's a print mechanism on these things. You just boop. You're good.
How do you feel about zero trust, Nina? Tell us how you really feel.
We currently work on least privilege, right? Least privilege is still an indication of trust. It's trust but verify in a way, not in healthcare. We shouldn't have that. This is sanctified information. This is literally you in data form. And we're just like, here, it's fine, go get it. We're cool, we trust you. You trust me because I work here, but you don't know who I am as a person. You know that I have a certain skill set, but zero trust needs to be better incorporated. It needs to be incorporated better in technology and industry generally, but healthcare needs it more because of the sensitivity and the specificity of the information. You roll somebody up on their labs and they're off by whatever number this is. You can overdose them. You cannot do a thing. You can treat them. You can give them the wrong blood. There's so many different options. You need to know that everything is in their place. You need to know that you can get into things and you can't get into things, and this is why the hierarchy is as such, and we're not doing that. And
exactly,
medical is it's very flawed, but it's also one of the last technologies to go live with any sort of tech and any sort of security, because we've had that cloak of, we're cool, we're good because we are the doctors and we know the things. And if I tell you that this is wrong and this is the medication you need, you're going to trust me because you don't have that information. And you're going to trust me because I'm giving you that information. It's the same thing. And we did that I am the Cavalry did that Hippocratic oath of medical device manufacturers should have taken that Hippocratic oath. If you read down the article, I go further. I said the hospitals need to also take that Hippocratic oath, because that is your information. That is them holding you in digital format. What is the difference?
There is none. There is absolutely none.
I like how you think about me. You're sly.
You knew this was going to happen.
No, I didn't think this was going to. I thought this was going to be like,
well, baby, you do not know me.
Oh my God, I should turn this, you asshole. I should be like, this is everybody grilling me about shit.
No, it's not. It's us having a conversation, and this is how this goes. But I like the fact that, we verify but never trust. I like that about zero trust, because for long we've done trust but verify. But I mean, Do you think, I'm going to throw this out, that an APT is above attaching a medical device or implanting it into a COVID operative and sending them into a hospital?
Absolutely not. Absolutely not.
So yeah, we shouldn't be trusting bring your own medical device. It should not be a thing.
I always love our chats. I just want to
So do I.
So, Yusuf Enriquez, 2 sentences about you. What's your origin story?
Okay, origin story. Prior FDA, worked in medical devices and medical countermeasure for the FDA, and currently working with chemical bio threat reduction agency.
Okay. So, all those things that you just said, what's the most interesting thing that you're working on right now?
Most interesting I'm working on is using quantum dots to test for COVID antibodies. Just started working with the Aberdeen folks at the Chem Bio Center up there in Aberdeen. And hopefully we could start using quantum dots to test for other infectious disease and maybe explosives.
Okay. If you were going to rip the guts out of healthcare, what would that entail?
The data set.
Expand.
I think over the last 50 years, it's been 95% European white males. So I don't understand the term precision medicine, given the fact that we've been doing race-based therapy for the last 60 years.
Okay. How are you going to do that? How are you going to rip this up? How are you going to change the paradigm?
Well, I thought about calling Dr. Collins and NIH and tell him to stop funding all white male scientists, but that might be a little bit above his pay grade. But I truly believe that we're going to have to start building data sets from the ground up, scratch what's already there, because I think it's complete bullshit.
So is your call to action that all white male clinical studies be ended and then bring other folks in? Because traditionally there's been historic issues with people of color not being particularly keen on signing the paper of a clinical trial. So what is the best way to get those folks involved?
Well, the first thing is take the bias out of the folks that's reviewing the clinical trial R01s.
Okay, so how are you going to take the bias out? Because that's ingrained, no?
Yeah, that's where, Dr. Collins is going to have to do a better job of hiring more African Americans, minorities, and women at the NIH, because it starts there. I mean, the socioeconomic bias that's already implanted once they look at the application, anything that refers to lack of diversity or diversity gets thrown in the trash.
Is that going to solve the problem in its entirety?
That'll begin some of the solving the problem. And then I think, what you'll start to see is that trust will come back. Minorities will trust other minorities to do study. I raised clinical trial enrollment at the Bronx VA just because I was African American. I was able to increase trials because they saw one African American guy in the entire psychiatry department at the Bronx VA their entire time. They had veterans there that had been going to that VA for 30 years, said they've never seen an African American or minority scientist that asking them for their blood or asking them to do a sign up for a trial.
So from conversations with you, you have a lot of opinions about the EUAs. So what's an EUA? What's your controversial opinion?
I think I'm getting a little concerned. I think we're over about 25.
I feel like from our conversations, you're a little more than a little concerned.
Well, yeah, all right. Let's ratchet it up a little bit. I think we're in the red as far as these EUAs being approved because the confidence interval that's required is 95%. We now have EUAs, which is emergency use authorization for COVID testing, as low as 65%. So, I mean, you don't have to be a mathematician to see that's a D on your report card. It's not even at a C level yet. And so these are tests that's being administered and given a report thinking that individuals doesn't have COVID when there's almost a 40% chance that they do.
So what's the workaround for it? So they get their 65, they get their D. Do they get extra credit? What's the workflow?
I mean, honestly, I think they all should be taken off if they're not above 80%. I think we're about 3 months.
Then who does that leave? We're in a crisis right now.
again, that's where I think America has kind of took their eye off the ball the last century or so, right? We outsourced everything to China. That's the reason why we have slowness in testing now, right? We don't have enough swabs. We can't manufacture a stick with a piece of cotton on it, right? And so now what we've done is we've rushed out and have all these device companies make these EUAs that are charging $100. You take what 20, almost 3 to 4 days to get a result back, and oh, oops, it's might be 65% accurate. So you're fucked either way.
So what's your shameless plug?
I mean, again, I think understandably, there's only three that's met the 95%. I think they should go ahead and ramp up. The rest should be scratched unless they have significant data.
But how are they going to ramp up? The production line is not here. The supply chain is not here.
Get out. We're America.
That's not a viable answer when the whole world is in crisis.
Well, we're not responsible for the whole world. We're responsible for
Correct.
America.
True.
And therefore, I think, what has happened is America is focused on bullshit. And, now we can't even supply our own medical supplies. We can't supply our own API for pharmaceutical because we've outsourced 93% is in China and the drug manufacturing is in India. So somebody's going to have to take a hit on the chin for it, but it needs to start being American-made products.
So if it's American-made products, this also indicates that there's other things in the supply chain in that just workflow in its entirety that need to be changed. If we have sent so many things off to China, they have different environmental protection laws, which means we would have to change them here. So this whole system needs to be recalibrated. How long does that take? What's the effort? What's the funding? Who needs to get involved?
I don't think it needs to be calibrated. I think it needs to be detonated. It needs to be start from scratch because it's just not,
So that's right. We have the problem. So you're bringing this up. So what's the solution?
Solution is, I mean, again, we got to get back to manufacturing. That's the solution. I mean, we've spent more money on Pokemon Go's and other bullshit, and we've not been able to shore up our supply chain. Right now, if we shut the borders down, we are dead. We don't produce enough insulin. We don't produce anything that is of necessity to us. However, we've spent so much money on other shit. I just don't see how we can sustain. We are not able to sustain ourselves right now if we closed all our borders.
So Lilly makes insulin in Puerto Rico, and that pushes over here, but we're still not addressing what I just said. So you can detonate, and that's fine, but you are still not creating a chain of, you've destroyed this, what now?
I mean, again, we have
How do we rebuild that trust? How do we rebuild the facilities and get the stuff to make this cotton swab? How do we get from a 4-day waiting period to a 4-hour, a 24-hour turnaround?
Yeah, we got to shift the money. I mean, the money's being shifted to big corporation.
We have to shift the mindset though first, right? I don't necessarily think the money is always the problem. Cash rules everything around me, correct? But you have to change the mindset of those manufacturers, of the people that are in that chain to make the difference before the funding is even considered.
Yeah, but again, going back to the individuals that's running those companies, they're not diverse. There's no inclusion, and so they get to make these decisions that are not relevant to the diverse population that they say their medical devices to serve.
No, we're still talking about COVID. We're still talking about the manufacturing.
Yeah, that's what we're talking about. The manufacturing. I mean, again, name an African American that runs a large pharmaceutical company.
I'm not well versed in the pharmaceutical companies, to be honest. I'm better with the device.
Name an African American that owns a medical device company, a large.
Valid. No, completely valid.
Again, that's when you talk about the mindset. You have individuals that's running these particular industry that pretty much only have their interest in their group, right? And so that's where you see with the pharma. Nobody thought that it was alarming that it's 95% European white males.
I think everybody did.
No, but the ones that go.
No, absolutely, yes. Not everybody. Not everybody.
Not everybody.
People that weren't involved and were like, why can't I have that med? I saw it on TV.
There you go.
So what's your shameless plug for you? What's your shameless plug?
I mean, again, like I said, I think for me is it needs to be understood that this is a systemic racial issue from the beginning. I don't know how to Band-Aid fix it. So the plug would be to re-engineer the way science is being done, how the scientists are being hired at the agency, because until you have diversity and inclusion, you're going to end up with another 50 years of white, 95% European males in the drug trials trying to treat, which is not going to be the majority anymore in the next, what, 5, 10 years. So what are we doing?
Your shameless plug is about you, not fixing the system.
Oh, my shameless plug. I mean, I don't have a shameless plug. I just want to do good science and individuals that, I think my big concern is there's a lot of innovation going on that's not being acknowledged because of who's behind it. And I think what I've seen over my career is that we need to change that because, again, I think all you're seeing is these Me Too products. There's no innovation being done at the large companies. Money has been spent on R&D for absolutely nothing at all because I haven't seen any value add to a lot of these products, given the fact that it's being done in a bubble by white males and white institutions.
Okay, thank you. We met in Abu Dhabi on a plane and had extensive conversations about medicine because, happen chance, you are a physician. What's your origin story?
So the work on what eventually became telehealth really began with a Facebook page. I, back in like 2008, thought that the residents could benefit from having a professional Facebook page, and that it was a good way to share information and can be used in a little different way than kind of just the sharing pictures and family and friends aspect of it. But the professional societies hadn't really come around to it. So really my career changed with a slide from Queen Elizabeth. Because when I showed Queen Elizabeth's Facebook page and that we were not, adopting to new technology, even at the speed of Queen Elizabeth, I really do think that was persuasive. So I think while I have been given a fair amount of credit for kind of ushering ACOG into social media, a lot of it was Queen Elizabeth's influence. And so the work on social media began really with a legislative interest to kind of share stories and new legislative items that were coming up and to kind of get awareness in a way that was a little more fun and socially engaging. That pretty quickly transitioned from social media to anything that engaged with apps on your phone. And while they are very different, it's different to have an app on your phone that, say, is a step counter from having a social media profile. There was enough of a connection through the mobile devices that social media and mobile media, overlapped. And I was doing my health policy training at the University of Pennsylvania, where they very astutely had formed the Social Media and Health Innovation Lab. So I joined them, and that was really the professional intersection of studying the big data and the new types of metrics we could get from things like Twitter, like tracking flu season by tweets and those kinds of studies. And from there, it really has been just kind of a series of progressions where you go from tracking health information via Twitter to health information via a wearable device, which has at least the commonality of connecting through apps. And ultimately kind of landed where we are now, which is a version of telehealth that is very different from social media profiles, but it relies on things that engage through wearable devices, patient-generated data, app connections, and then like what we're doing here, which has become routine in COVID era, which is the virtual visits. And obviously it's exploding right now. So that's kind of a brief synopsis of how I went from talking about Queen Elizabeth's Facebook page to doing virtual visits around the clock.
So you gave an acronym, and I'm not sure if people know what it is. So what's ACOG?
Yeah, ACOG is the American College of Obstetricians and Gynecologists.
I want to dive into that because that's the kind of physician you are, correct? You deliver babies, you take care of moms.
Right, so I'm a board certified OBGYN and the chair of telehealth for the professional society ACOG.
Perfect. So I think a lot of people, when they think of going to the hospital now because of COVID, they're going in for tests and they're going in because they have COVID. But the one surgical suite that stayed open the whole time, or at least generality stayed open the whole time, was yours. So can you talk about what happened, what changed during the COVID? Just get into that.
As with everything, it has been a series of moving targets and adaptions, and then adapting to maybe an overreaction. So a lot of it has changed, but the overall essence of it was the obvious necessity for still having inpatient care. So the recommendation has always been to come and receive your maternal care in a hospital, whether it's a delivery or a triage evaluation, management of blood pressure. In other words, not recommending going outside the hospital. Mm-hmm. And to make that as safe as possible, there were a number of new protocols, some just limited who could be in the hospital. So a lot of it was keeping it to being just the patient and maybe one support person, which would often be, say, a spouse or a family member. Whereas the intention before COVID would have been to have multiple support people, either multiple family members or a doula or someone like that. So that initially changed, and there were some unfortunately kind of rigid policies that did change the birth experience and definitely changed the postpartum experience. As we've gotten better at rapid testing and symptom screening and mask wearing and PPE, those have become a little more lenient, but there still is an emphasis on getting patients in and out of the hospital as quickly as possible. So going home on day 1 after a vaginal delivery or day 2 after a C-section would be accelerated in normal situations, but it has kind of become routine right now. And then there's the whole testing element, where if you test positive, there is a whole other kind of precautionary protocol that gets put into place. And it does mean wearing more masks than you're probably used to for the patient. Definitely means more PPE for the providers. So it looks like a much more kind of medicalized version of the delivery, which it's the safest thing we have right now.
So you talked about social media and the way that it's working into better patient care. Are you familiar that the FDA is working on something like that they're bringing in all of that? Can you speak to that a little bit?
So
part of that?
So yeah, I can speak. I'm not part of that personally.
So is that a call to action that you want to express? I may be expressing that for you.
Yeah, it's definitely a call to action in that we need these kind of bi-directional flow of information. We need patients who can more directly interact with decision makers and with people who are making the health policies. It's a little bit different, I think, than the initiative you're talking about, but one of the most effective waivers during this COVID era was the allowance of different devices so that everybody can access virtual health, even if they don't have, say, some of the infrastructure that's not available in all communities. And the examples of that would be like Skype, FaceTime. Most communities now, whatever the resource setting is, do have access to cell phones and enough either Bluetooth or internet that they could do a FaceTime visit or a Skype visit.
So what kind of interactions have you had with the security researcher community, and are you getting into that realm? Are you in that realm?
We're wading in. We're probably about knee deep right now. So there's definitely an adult swim deep into this that we have not gone into. But even in the shallow waters, it's been very enlightening, because what we want to see happen with this telehealth revolution is the best kind of transition from optimizing the benefits without falling prey to the pitfalls. And we know with any new technology that those pitfalls are there, often unintended. So, kind of a classic example would be any scientific discovery that at an extreme became very dangerous. Nuclear fission comes to mind. And when it comes to Facebook and social media, I think the extreme of that in the negative is pretty obvious right now, with all of the misinformation and all of the ways that social media can negatively influence public perception of pseudoscience or influence elections. And what we want to do is harness the power of these things, because social media has also enabled Black Lives Matter and the Me Too movement. We want to maximize the good and minimize the bad. And we're learning right now what are the, to switch analogies for a second in vehicle safety, what are the anti-lock brakes and seat belts and air traffic control of telehealth. And for example, in the kind of entry-level interaction I've had with the cybersecurity community, we don't have much training on the physician side. So when a doctor is talking about a device that might be beneficial to a patient, say like a remote blood pressure device, they probably, genuinely just don't have a lot of training or information about the nuts and bolts of how that works and how safe the data is. They know to ask about it, they know to be concerned about it, but they don't have like the deeper level understanding. That's just one example of how data privacy is totally intimately intertwined with this, and doctors do get questions about it.
So I have two things for you. This year at the Biohacking Village, Andrea Downing is talking about disinformation on social media, and you should also have a conversation with Dr. Christian Demeth and listen to his panel on Do No Harm. I can send you those links after. And the last thing I want from you is, how can we as a community, the hacker community, cybersecurity community, help you in whatever next step it takes to get mid-thigh into that water?
Yeah, well, exactly what you just proposed. I think we need a lot of these cross-disciplinary conferences. I think we need to be going to each other's lectures and learning each other's worlds a little bit first, and then finding out all the intersections. I do think ultimately there's going to be a role for a lot of these conversations to take place outside the patient-doctor encounter. It's already such a short time we have to talk to patients about the things that we're trained in extensively, the immediate health of the patient right in front of us, to then dive into really complex topics about cybersecurity and patient-generated data and where that data sits and how protected it is. Not only is it maybe beyond the scope of our time limits, it might be beyond the scope of our expertise. So I think finding a way that we can get patients the answers to those questions and get a well-informed citizenry of doctors to feel comfortable enough that they can confidently recommend the devices without having to get into all the deep weeds or deep into the pool about exactly how it works. Finding the trusted sources to say, I don't know exactly how it works, but these guys do, and we trust them, and so here's your kind of safety measures.
Yet another plug. Meg Dewar is working on a cybersecurity informed consent project that would help patients and help you folks get that information to them. So this is the last question. What is your shameless plug for this conversation?
My shameless plug is to have a post-COVID world that looks a lot like the current waivers and adaptations. So it doesn't mean that we have to continue all visits via Skype or FaceTime, for example. Even among the adopters, most have moved away from that already. They use things that are HIPAA compliant. It's a nice backup to have. So, but that's not the waiver that we're looking for, but we do need a lot of these other waivers to continue. We need doctors to be able to see patients without, for example, a prior existing patient-doctor relationship. We can establish that for the first time virtually. We really need the cross-state lines flexibility. In fact, a totally shameless plug would be to have something akin to a national medical license, where if you're licensed in one state, you can practice anywhere, the same way that you can prescribe anywhere in the United States with a DEA number, or you can drive anywhere in the United States with a driver's license. We need payers to continue to fund this. They've been doing a admirable job adapting to the current climate. We need that to continue, and we need the we need the people using it right now to be open to still some reining in of all the new technology. In other words, we know that things like virtual visits and online care are still prone to overuse and fraud and all the things that in-person care is prone to. So while I'm calling for many of the waivers to stay in place and not be reenacted, we will need some new things that come in, and we need to be open to those so we can continue to use it safely.
Thank you so much.
Thank you.
Hey girl, hey.
Hey girl, hey, hey, hey.
This is Najla Lindsay. She is on the board with us. She helps us do the things and accomplish all the things that you're about to experience. I have questions.
I may have some answers, Nina. I may have some answers for you.
Are you ready? Gonna get into it. So,
Okay.
what's your origin story? 2-3 sentences.
Forensic scientist lover, wine lover, and I am here to share how forensic science and information security is hand in hand. That's the bottom line. They are lifetime lovers and part-time friends right now, and I need them to be full-time friends as well as the lifetime lovers. So that's it in a nutshell.
I was gonna ask about your shameless plug, but you clearly already got this because that was the title of your talk for last year. So hashtag go to YouTube.
It's all in there. All in there,
So,
girl.
you're up and coming as a researcher. You're doing all the things. What do you need from our community to help you get to that next level? Because if anybody follows you on the Twitters, you just, it's all the time, every day doing the things. How can we help you?
How can we help? How can you help me? Share, the resources that I share things that I'm doing with the community, and reach out to me. I'm always open to have a discussion. I'm always open to learn something new. I don't know everything, and I think that the community is full of experts and people that know so much that there needs to be a bridge to, career transitioners like myself, and recent graduates, and the people that have been in the industry for years. So I'm always willing to have a conversation, talk to you, share my resources, and just be genuine in your reach as well, because it's no sense in being fake with me. I'm not fake with anybody. Just be genuine in your reach and reach out to me, talk to me, and teach me something new. Learn something new every day.
You talked about your forensic science work. How do you see the overlap of DFIR, science, security, technology, healthcare?
It's all intertwined. And I like to tell people that, a lot of people that are currently studying the digital forensics, they don't know that that's actually a branch and a discipline in forensic science. And once people learn and actually take into their work that this is from a scientific discipline, what you do in digital forensics can go to court. Like, you can testify based on what evidence you have processed, what evidence you have found, what story you're telling. And that could be a make or break for someone. You can wind up putting someone in jail, or you can wind up freeing someone and exonerating them from a crime that they've probably been in jail for years. And so I always like to remind people that they are together, whether you like it or not. And I think that people forget that you have to take the scientific approach to a lot of things. That scientific method, we didn't learn that just to learn it. We learned it because it actually applies. You have an hypothesis and you have to test it out, not just once, not twice, various times, and with various people, because what I get when I do it will be a different result, and can be a different result from what you get. And it doesn't hurt to share the information. You're not going to lose anything by sharing what you learn. And I think that it's will forever be intertwined as digital forensics gets more popular, because that's also taking a turn and being the talk of the town of cybersecurity, information security. I think it's important that people remember or know, just even learn that this is a part of forensic science. This is a science discipline. And the more you think methodically about it, the better you will be as a practitioner in the field. And that's either as a researcher or if you're working full time as well.
So not a lot of people consider digital forensics in healthcare because there are no laws surrounding it. It's something goes wrong, you re-image it, you keep moving, you keep going. How do you see the transition happening? Is it happening? Is it going to happen? What do you see the future?
So with healthcare, like, I find that they're always at least 5 to 10 years behind on making the transition to updated technology. Just in general, like just switching to have Windows 10 on all of their computer systems in the hospital can sometimes take much longer than, private organizations or government organizations. And so I think that the healthcare industry is still catching up, right? You know, healthcare, you know, a lot of people didn't think about, oh, I have to worry about securing this device and making sure someone don't try and trip it and increase, you know, if let's say you take insulin, you have an insulin pump and increase my insulin pump, or, you know, mess with the anesthesiologist, who is very important during surgery because one wrong dose can kill somebody. So your hospital go down and your anesthesiology equipment is on a network and somebody decides to play with it, you're just completely out of luck. So I think that as more people are aware of, you know, the Biohacking Village, as more people are aware of, you know, healthcare and medical device security and how important that it is to think about security at the beginning and not the after effect, I think that people will start to realize, oh crap, we actually have to take care of this. And I think if manufacturers, there's a couple manufacturers that I know that they started implementing on their websites where you can learn about stuff that has issues. And so they want to make sure that the community is aware so that, you know, they have their methods to build in and make sure that everything works better. I think the more that people actually have conversations, because as much as big and as much as cybersecurity is, they don't talk to each other. Like people within the industry and the organizations don't talk to each other. It's like a hush hush thing. And I just feel like it's actually the same thing in forensic science too. But I think that the more that you talk, the better we can come together and the better we can build these, you know, these instruments and these medical devices, because that's the only way we're going to make healthcare better for everyone. It's not about, oh, you get access to healthcare and you don't. You have to think security at the forefront and not at the end of it, because it actually costs you more when you think about it at the end versus with it in mind as you're doing it. So it's all intertwined, all of it.
So in recent history, you were part of Share the Mic in cybersecurity.
Oh yeah.
So what was that like? What were the outcomes?
That was like one of the best things that I've ever been a part of. And, you know, when I got paired with Rachel Toback of WISP, you know, I had known of Rachel. I hadn't really talked to her as much, but I had known of Rachel because I wind up being able to receive a WISP scholarship last year for DEF CON. So that was very helpful in me attending DEF CON. And on top of that, we just clicked instantly. I learned so much about her. And we put a plan together. We put a plan because you're on Twitter. You're not necessarily doing videos. It's a tweet. And you put together some tweets. We put together some tweets. We put together an action plan and just talked about, you know, what it is that I'm trying to do, what it is that you're looking for, you know, certifications that you're doing and all of the like. And so we put it together. Thursday night, everything was set. And then Friday, I was at work. I still work in my forensic science industry. So I was at work when all of this was going on, but I knew what the tweets were because we talked through them and we worked through them. And I wanted, you know, funding for my certifications. And I wanted to attend the SANS class. And we know, you know, SANS has been looked at as like one of the main industry certifications to achieve and attend that class. And so I was fortunate to be able to receive a full scholarship to attend one of their classes. I was able to get all of my certification costs covered. And then they wind up covering all of the Black cybersecurity professionals certifications and trainings. And to still, you know, make that, you know, hey, I'm gonna still get all of these people, make that the forefront and say, hey, I want these people to progress. I want these people to win. I think that was amazing. It felt amazing. And I was elated all day at work. I was just so elated at work. They couldn't even tell me. They was like, are you okay? I'm like, I'm not sure, but I'm here and I'm gonna get my work done. But it was just so amazing. And then later on in the day, Rachel and I actually went live on Periscope and we had a discussion about, you know, being Black in the industry. And, what it is that people can do to help Black cybersecurity professionals. And so that whole day was just full of adrenaline and full of, happiness and gratitude, and people using their platform to promote other people's voices that don't typically have a voice. So I loved it. And Rachel and I are still building our relationship in the background and learning about each other and things like that. And I think all of the participants are also doing that. So it was amazing. I hope that it continues to grow into something much larger going forward.
How can the Biohacking Village participate or do better with it?
You, as a Biohacking Village, I think that you have to make a conscious effort. And then to some people, it may look like you're being biased because you may focus on underrepresented minorities or things like that. And I think a good way, because normally the Biohacking Village just does an event during DEF CON, right? I think that, during the year, a couple of months later down the line,
Are you secret dropping? You got to cut this out.
No, I'm just telling you what I think. I'm just telling you things that I think that will be helpful. Maybe start a partnership or a mentor program with, some people, get people involved in it and promote it, consistently, especially during Cybersecurity Awareness Month. Everybody participates in that, right? Mm-hmm. Like last year I did that. I was dropping random tips of the day, and doing that. I think that the more that people learn that the Biohacking Village is out there, the more that people will want to participate and know about, healthcare and medical device security. I think that is, keep, tweeting and sharing, information and reaching out and being personable. I think that's all going to do a world of good as we continue to grow, because I'm not going anywhere, Nina. You're stuck with me, just so you know.
I was never letting you go.
Okay, just so we're clear here.
That was never an option.
Okay.
All right. So, what's your controversial opinion?
Whew. Wow. You tripped me up here.
Mm-hmm.
A good one, actually. My controversial opinion is that I see people being performative on making sure that Black people get heard in the industry, but it means nothing because you're not actually doing anything. And I can see right through you pretending to do anything. And I think that, even with Share the Mic and Cyber, I feel like it'll be a moment in time for some people and for a lot of people, because you have the same type of people at the top of the industry and they have a lot of say, and the industry follows a lot of what those top people say. So I think sometimes, doing all of this and making sure that, people get heard. Let's check back around wintertime and see what's been happening, because I know, or I feel that stuff's not going to look the same.
So, controversial opinion, what's your call to arms?
My call to arms is don't talk about it, be about it. Go make for the next, listen, we're in Rona. It's Rona. It's coronavirus. Most states, most countries are locked down. Reach out to somebody in the industry, not a white person, not a white person, not a white male, not a white female. Somebody that does not look like you, that you've never actually talked to either, because you can tend to have a bias against the people that you've already known. And you just choose that because that's your comfort zone. No. We want you out of your comfort zone. We want you to be held accountable for your thoughts, your feelings, and your words, and your actions. Reach out to somebody, a Black person, a Latino person, an Asian person, somebody not related to you in any way, fashion, form that you've never talked to, and get to know them genuinely, and don't expect anything in return. Nothing. I mean, not an ounce of nothing. And see what happens to yourself as you choose to develop a relationship with someone with no transactional expectations. See what happens to yourself, not for them, for you. Because I can guarantee you, when you start to do stuff without expecting anything in return, you feel good, and you realize that the stuff and the values and the beliefs that you have now, they can change. They don't have to be there for the rest of your life. And your life's not going to end because you've changed a value or a belief. It's not going to end. It's only going to get better. And if it don't get better, I'm sorry, you're not growing, and you're going to be stuck. So choose somebody you've never talked to. Go on LinkedIn. LinkedIn is the place of people I feel like they just Google and just reach out to people. Go on LinkedIn. Check Twitter. Check hashtags. Go on there. Go talk to someone. Build a genuine relationship. Find out about them. Reach out. And take it from there. Commit to it for the next 6 months. I'll make it easy. I won't even say a year. For the next 6 months. Into the new year. Actually, it's 5. Let's make it into January 2020. And see what happens. And reach out to me on Twitter and tell me what happened when you did this, because I would like to know.
I love that.
That's it.
I love the passion you bring to pretty much every single conversation we have.
Let's do it.
Thank you. For real.
You are very welcome.
So fun fact about this quarantine is Cannibal and I started cooking together on the weekends, 3-hour time difference. He's Mexican, I'm Puerto Rican. We started making dishes from each other's cultures. It opened up our eyes. We're like super homies now. It's amazing. It is probably one of the best friendships I have ever cultivated. And thank you for being on here. So quick, just to get to know you question. 2 lines, 1 minute. What's your origin story?
All right, origin story. It's going to be a little bit more than 2 lines.
Okay.
But I started out in the medical industry. This was 12-ish years ago for a medical device manufacturer. And it's kind of how I got into medical and how I got into security, where I was brought in actually more of a support role. And I noticed that, hey, these devices aren't being patched. Nobody's really taking a lead on this. So I just started doing it on top of my other stuff. And that was kind of it. At one point, it started rolling up into oh, hey, hospitals are starting to get hit with ransomware. This is kind of a big deal. And I'm like, yeah, I've been doing this for years because you guys didn't care about it.
Right. Perfect segue. So you've been around the industry for a super long time. So you've seen it go from healthcare instantiation with technology and security to where we are now. What are the biggest differences you see, and how much do we still have to go?
There is still so much work that needs to be done. So much work. I think people are more aware. I'm talking about a populist standpoint, not so much the medical industry, but people are more aware of their data, the sensitivity of things, and that security is important, especially on devices that are connected to people, or those people are relying on those devices for their safety and their well-being. Things were a mess. They're still a mess, but not as much of a mess. I think a lot of it has to do with one of the things is the regulations, HIPAA. There's not enough there. Their heart's in the right place, but they have no way of enforcing it. The claws have no teeth. The claws have no teeth. That's kind of funny because it sounds like it's a cat.
The healthcare cat.
Right.
So I'm gonna bend you on that.
Okay.
So what would give healthcare policymakers, regulators more teeth? How do they and just an extension of that. So then how do they engage more with the sec community hackers to make this better? How would you like to be engaged by these people?
Yes. So that's kind of there's no quick, easy answer to it, unfortunately, but this isn't a new issue. We've known about this for a really long time. It's one of those things where if something were just started now, in 5-6 years from now, we could look back and say, oh yeah, we still don't have a great plan, but there's something. There's at least this momentum that we can build off of. Getting some sort of enforcement policy in place, and that usually comes with auditors or someone that would like basically go to each hospital. Some sort of government funding would be helpful, because a lot of the hospitals, a lot of people think that hospitals are making money hand over fist because of how much they cost, but they're trying to break even. A lot of hospitals are running in the red. And they really don't have the money. A lot of them don't even have IT staff. A lot of them outsource their IT, and it's one of those things where the doctor will call up and say, "Hey, I want to be able to check my X-rays or whatever from home. Punch this hole through the firewall so I can get access to my machines." Having some sort of standardized IT policy for hospitals that the government can say, "Hey, here's a framework. You can either use this or use your own, but you got to use something." That would be a huge step forward. Just having some sort of basic guideline so that the hospitals aren't fumbling around in the dark trying to figure this out. Newer hospitals tend to be better, but there's so many old hospitals that are just kind of like cobbling things on as they go. Most hospitals.
Devices.
What's that?
Working with those legacy devices that they have to continue to integrate and continue to protect with the other things that are coming in.
Right. A lot of hospitals, especially on the East Coast, have been around since before computers were even a thing. So yeah, right. It's crazy. Technology. A lot of them are like, how do I use this fax machine?
I almost took that personal. I was like, what do you mean about, are you talking about New York specifically?
Yeah, especially New York.
No, it's actually true, right? So you're not in healthcare anymore, right?
No, I am no longer in healthcare. I've been out for maybe 3 or 4 years.
So I don't know if you want to talk about the industry you're in, but how can that industry that you're currently in influence what healthcare is doing? So
I'm a threat hunter red team for local government, and just having, so my issue with that type of work is the hospitals just need the basics. It's great that these devices on the user side have or MFA, usually 3 forms of authentication in order to like be able to pull meds or change access to a patient's record. But on the admin side of things, a lot of those don't have multi-factor authentication. It's single auth. So it's great that the users have to do this, but the admins don't. The technical side of things is just like, it's just oftentimes a reused password across the vendor. And I mean, pick your vendor, pretty much all of them have it.
So what's your call to action for healthcare or the hacker community, whoever?
So many things. There's so many things. Like one of them is just like education. Get educated on what hospital you're going to. What standards do they have? What equipment do they use? Ask them, how is my information going to be used?
I mean, as a patient, this is what you're talking about.
As a patient.
Mm-hmm.
As a hospital, it'd be one of those things of like, yeah, holding your vendor a little bit more accountable as to what equipment they're putting on your network. So many of them basically say, hey, we're on your network. It's up to you to protect this equipment, not we're going to harden this stuff because we don't know what's there.
Right.
And every hospital is different. There's no standardized network for hospitals. I keep kind of going back to the whole standardized policy thing of this is a basic framework. You're welcome to modify this as much as you want. But these are the basics. You need to, be able to segment off some of this equipment or have a standardized 2FA or MFA policy for your internal staff and admins. And if you're not going to have your on-site IT, these are the rules they have to play by.
So what if it's a baseline where people just have to meet this very small criteria to meet? And then from there they can build up, but they cannot go below.
Right.
Who would be the organizing body to lead that, or who would be involved in that?
That would seem like it'd be kind of fall onto the FDA. And they have some stuff, but it doesn't really call out a basic framework or some sort of structure that hospitals can fall back on if they have these questions that are going unanswered.
So we're almost out of time.
Okay.
So what's your shameless plug?
I don't have one. Just get angry, get informed, and like realize how poorly everything has been. None of this is new. We've been talking about this for 10 years and very little has been done. One thing I will plug is if you look up the HHS breach report, whenever there's a breach, it has to be notified.
Right.
It has to be reported. And you can go and you can read these reports and you can see is like, oh, look, 10,000 records just got breached, or this other, CVS got breached. There was one recently, I think within the last week for CVS in one specific area. And it's one of those things where it's like, I feel like nobody's really looking at this.
Think about how CVS is networked, right? You can go to any CVS and pick up your meds.
Mhm.
So it's not just a singular one area that got hit. It's
Right. If you go to Google and you just search for the HHS breach report, that's Hotel Sierra breach report. It'll take you to a page and you scroll down and you look for breaches greater than 500 or less than 500. I don't know if there's a way to display them both it's a .gov site. So at least you're getting something. So the one I was just talking about is the CVS pharmacy. And that's 21,000 records, or not even records, but individuals. The next one down is 25,000. The one below that for University of Utah is 10,000. 78,000 for the NCP healthcare management company. These are all within the last, 7 to 10 days.
Mhm.
This is a lot. And it just scrolls every day or every few days. There's just another one and another one and another one. And I feel like not enough people are looking at the breach report. And if you get enough people, you get enough eyes on this report, it kind of paints a picture of this is a really big issue. And if we just followed some basic practices, it could really prevent this. It also shows you the location and the type of breach, hacking IT incident, unauthorized access or disclosure. Those are the ones that you see the most. The one at the very top for Walgreens is theft, but and the one below it is loss as well. But I mean, those are all preventable things. These are easy things that can be mitigated. A basic framework, just a very basic framework of how to handle passwords. 2FA has to be required for not just the medical staff, like the RNs getting the meds out of the machine, but the techs servicing the machines and the vendor companies that are putting this equipment in the hospital should have some degree of accountability for what they're introducing to the network.
So we're going to see each other later because it's Friday for us and it's cooking day. So here for later.
Oh. Thanks. Right on.
Right. Later.
All right, bye.
So Shri, hi, how are you?
Good, thank you. How are you?
So I'm good. So tell us about yourself, where do you work, and a little bit about your origin story.
Sure, yes. I've been working on controlling pandemics since the Ebola epidemic. I got pulled into that by almost by accident. I was at a conference, TED-Med, that looking at all kinds of medical topics, but just a few days before that, the Ebola crisis was escalating, and the CDC director had a press conference saying this is at that time it was Tom Frieden, saying this is the worst epidemic of his career since the AIDS epidemic. And then so it was like, oh, wow, if the CDC doesn't have things under control, then things must be pretty bad. So although we were, we're having drinks at City Hall in San Francisco at the conference, it was very hard to relax because we were thinking about, well, what's happening with Ebola, as the whole rest of the world was worried about. So I happened to meet a gentleman who became my co-author. He was a Harvard Public Health School professor, and it turns out I just happened to randomly meet him there, and he told me he had a lot of experience with Ebola public health in West Africa and East Africa and India and a whole bunch of places. So I said, wow, so you must know all about what's going on there. And so I just asked him questions. And we just kept talking and kept in touch. And then realizing that there may be some ways to solve this problem in a kind of a cool-headed way, as opposed to all the panic that was being. If you look at the literature at the time, there were people who were openly panicking, and it was kind of a strange time. And so we wrote some things down on paper, just started emailing a bunch of people and saying, hey, could you try this and do that? And ultimately, about a month later, that paper got written into a sort of an article format, and we submitted it, and it got published in the Lancet. And then the president of Guinea saw that and invited my co-author to come advise him on how to control Ebola in his country. And he was supposed to be there for 2 weeks. He ended up there for 6 months, unexpectedly. And I was there on the phone with him almost every day. We're working through the details of how you create a national Ebola response. So that's how I got plunged into this pandemics field, just by completely a bunch of random events.
So now we're in COVID.
Yeah.
And you had the experience with Ebola. So how is that medical data being taken in? How is it being allocated? Where is it going?
Okay, so that's great. So the data is still not where it needs to be. I think that there's a lot of, as we know, there's these big problems with the CDC and the federal government trying to gather the data from all over the country, and our testing is far behind what it needs to be. But we're probably seeing a very small percentage of the cases that are actually people are having. This is a disease that has asymptomatic infection as well as pre-symptomatic spread. So we're basically only seeing a fraction of the picture. And this is a reflected way we know this is that if you, so in other words, I think the data that we have is only a small fraction of what really is out there. And I think that's the point I'm trying to make, is that whatever data we have is a tiny reflection of the ocean.
So how is the data that we have going to influence COVID care? And then beyond that, once we get past COVID, how is this data going to influence change within healthcare as a whole?
This data is already influencing, I think, in a very big way. I think, for example, like take the state of California. There's a metric called the positivity rate, which is the percentage of tests that get returned that are tested positive. So if you do 100 tests, how many come back positive? On average, it's 7% in the state of California. But in parts of the state, it's actually 12 or 20%, close to 10, 14 to 17, 20%. Like that's in Central California right now. Whereas in the San Francisco Bay Area, it's closer to 2 to 4%. So the average is not really reflecting the whole state. It's really highly variable. So that people are using that data, that percentage, to allocate resources. So the governor allocated $52 million of extra effort, to do contact tracing and a whole bunch of things for Central California based on that data, based on that positivity rate. So that's one way in which the data is really important. It gives us insight into where the problems are.
So actually, I want to do current state versus future state. So current state with COVID, how is that data influencing changes in healthcare? And for future state of healthcare, what are we learning that we need to start changing in how hospitals operate, how patient care is done?
Learning a lot. I think there's probably a number of different topics we could talk about in that area. So I could just pick one maybe. And I think one is, and the other thing about this is that it's so fast. I mean, this is happening like at light speed, faster than anybody can even keep up with. So that's the other part about this. The data, there's obviously a lot of clinical data in terms of treatment of patients that people are learning about treatments on real time. which works, which doesn't. And there's I think one of the examples that people point to is there's by the UK National Health Service, where they conducted a whole bunch of, they constructed a clinical trial for a large number of drugs, and they came up with dexamethasone as one that has effectiveness for treating COVID patients. And so that's an example how by properly constructing the trial, they can draw accurate conclusions and come up with solutions.
So from all the information, so I think you've been involved in the data couriership of COVID since it started. Is that correct?
Data what?
The data couriership and gathering since the beginning of COVID?
Yeah, not so much the data and more the epidemic modeling.
Okay.
Modeling of the how you can control the epidemic.
Oh, perfect. Perfect segue, because that was the next question. So what is the data showing you on how to control this? What should the American society understand about how the data should influence how we're going to control this?
Okay, great question. I think one of the things that we can do, so the testing is something that we have tried to do and we are doing and continuing to improve at some rate. And it's now in full swing, and people are trying to increase testing all over the country and make it better, cheaper, faster, which is all good. It's certainly not been enough. And so that doesn't mean that, we want to stop testing. We want to keep going. And that will help us find cases and reduce the burden. But we need something else to control the spread and combination. And I think we talked about this on our
On the
podcast about how combining it with masks or social protections of some kind will, and that could include social distancing or anything, would be able to bring the transmission rate below 1, the R0 below 1, in order to stop the spread of the epidemic. And since we talked at the time, one thing that's become clear is that people are finding that the virus transmits not only through droplets, which are greater than 5 microns in size, but also in aerosols, which are smaller, less than 5 microns, even less than 1 micron. And the properties of these droplets are that they pass right through the cloth or cotton masks that people are wearing. So although the cotton masks will filter a certain percentage of the virus that's exhaled by the breath or incoming, in the environment, these aerosols linger for many hours, and they can pass right through this cloth. And so we're only getting partial protection. And so one of the things we can do, we discovered, I think this has all happened last 30, 40 days, is that using, it's kind of like these cloth masks are like socks.
Yeah.
And we need shoes. We need something that's going to be much better if we want to keep walking in the streets. And so the one example of that is, of course, in healthcare settings, people use N95 masks. And these N95 masks are designed to stop the aerosols, to give, the shoes of the industry, except that they've been reserved for healthcare workers because they need them. But the problem is that the more the virus spreads in the community, the more cases they're going to be showing up at the hospital. So you're actually not really solving any problem by if more and more people getting infected, more and more people showing up at the hospital, and even more people dying. So there are actually industrial masks that are not used by the hospital system. This is an example. This is one example. It's a NIOSH-approved N95 mask, and it could be used by essential workers or healthcare workers, non-healthcare workers, to protect themselves. And because these people who are exposed on a daily basis to the public and to other workers that are keeping the economy running, they're finding that those are the people ending up in the hospital. And so, people staying at home who can isolate, they're much less likely to get the virus than the people who are obviously exposed and that obviously makes logical sense. So these types of masks, another mask is this mask here. It's from Canada. It's it has an N95 filter in it. And it has the third. Let me get the other one that I have here. It's like this is a little bit more very industrial looking, but it's a elastomeric mask. You put it on like this and strap it around. And these are N95 filters. But the thing is, these are just like a seatbelt. They're dummy proof. They're very easy to use. They don't require this big, careful fitting and healthcare training and all that. They're stretchy, and the word elastomeric means stretchy. So that's what we can do, is by wearing these kinds of off-the-shelf, pre-approved masks, we can and putting them in the hands of essential workers. I think we can make a big difference.
So, last question.
Yeah.
What's your call to arms from the security research community, from healthcare, from the American population?
My call to arms. I think right now, I think I already sort of discussed it a little bit more, is I think essential workers need these masks, these N95 capable masks. Without that, until this, I think that's really the number one thing we need to get done right now, is protect the essential workers so that they don't, spread the disease and get sick and bring it home to their families. And I think that would be the number one thing that would, yeah.
Thank you, Sri, from
Thank you.
patientknowhow.com. So go check that out for more information on everything that he's just talked about. Thank you so much.
Thank you.
So for everyone that doesn't know, this is Josh.
Hi.
Our recording producer for this year's virtual conference. And he literally just got told that he is the next interview for this keynote. So let's all welcome John.
Hi.
And just to be clear, he does not work in the cybers. But the reason I wanted you here is literally that reason. You've recorded, I think there's one more talk left. You've recorded 95% of the talks that we've had so far. How's your brain?
It is really full because I did not have any understanding of this field before, and I just watched like 28 lectures or seminars or whatever we call them. And I'm just the type of personality that if I'm watching something, I'm really paying attention to it and trying to figure it out. So it's kind of bursting at the moment.
So from all the talks you've heard, wherein lie your concerns for healthcare?
Oh, well, the massive lack of any type of cybersecurity at many HDOs is pretty bad. Personally, I'm going to be working at a small mental health clinic in a few weeks, and I'm sure that I'll be asking them a lot of questions about what their cybersecurity is, especially since we're delivering all of our services over telehealth. So what are the concerns for that? But I also really enjoyed Yusuf's talk about representation in medical studies, and I think that's super important in research, coming from, because I'm, again, studying social work. So coming from that background, that's also really important now, especially now when we see such, dramatic demographic distribution of COVID cases.
What are your takeaways? What should we be working on as a security community? What's your greatest concern that you think we should get to straight away?
Well, I thought Sri's takeaway on getting masks to essential workers seems like the most urgent takeaway from any of the talks now, just because that specifically saves lives. But I don't think that's really cybersecurity, so I don't know if that really answers.
Not. It's part of the maker space, part of it. So then if we're going to go back into the security side, being that you've heard 28 intense talks, and I'm not sorry for that, and you're going to go into social work and you have an understanding, you very likely have a better understanding of how healthcare works now and the security around it, more so than a lot of other patients out there. This is a patient, as someone going into the hospital, what's your takeaway? What's your greatest need now as a patient walking in?
Well, I'd never liked to go to the hospital, and I sure don't now. But if I did, I think I would just make sure that either myself or a companion who was with me double checked that whoever was treating me or administering medication or other treatments has my correct record, and that the information is correct, that my blood type is correct, things like that. I would just double check things, which I always cross-examine a doctor when I talk to them anyway. And I think that being an informed patient is really important. So I think that the potential for accidental mishaps is probably the thing that would concern me the most.
Okay. How do you think our community can engage more? You know what? Not even our community. How can your community engage more?
What's my community?
What is your community?
My community right now is my son, my wife, and my dog, and me.
Okay. So how can your community engage more in the healthcare security side of the house?
Wow. I'm not sure I have an answer to that.
Okay.
I mean, I'll be talking to people at the clinic and so forth, and people that I, study with in social work school, and professors for all my classes moving forward now for the next couple of years, because I have attended this conference as the video producer. So I think it'll probably be in the form of conversations with people, in the social work field from my perspective.
Okay. What questions do you have for the security folks, the biohackers?
I think I did have a question. Societal change, changing social policy. One thing I do know from studies is, and from just a career in journalism, is that changing social policy in the United States, even when we're at a World War II level event like we're having right now with the coronavirus, is still tremendously slow. I think that, and this kind of goes back to the other question about outreach, I think that maybe people in the community need to be doing more outreach through people that they know, whether it's on, probably on social media, just to sort of raise questions and try to stimulate some dialogue about what regular people should be prioritizing in this situation. And, it's going to come down to who people vote for in November, but it also comes down to, like, how are you going to spend your time online and on social media? Whether it's, are you going to be sharing memes or maybe having a substantial conversation with somebody in the community who might actually have some suggestions for how to improve the situation. I know a few people, just by virtue of living where I do, it's a very IT heavy, neighborhood. And we have people who've been building respirators or ventilators in their rooms, or designing software for it, or, building masks and things like that. So I think that kind of community outreach is really important. I think that, that is maybe the type of thing we should be using social media more for these days than spreading bad information.
So I wanted to make sure people knew who you were, because thank you so much for being part of the Village this year. There's so many people that are involved that don't get the accolades that they need. So thank you, everyone that I interviewed. Thank you for trusting me enough to come in cold. I want to thank the organizers for this year. It was a work of love, and thank you to Bo, Sydney, Andrea, Bill, Najla, the volunteers, the sponsors, the device folks that are working with us. We appreciate you attendees so much. Watch this space. Enjoy the show.
I'm Mohammed Ali from Boehringer Ingelheim. I lead the digital development group over there under ClinOps, and I'm here now today to have a fireside chat with Dr. Amy Abernathy, the Deputy Chief Commissioner for the FDA and the CIO. So looking forward to a discussion with her. I'm sure she has wonderful insights, and we would love to get her perspective on many things here regarding biosecurity, medical devices, and the overall digital health space. Dr. Abernathy?
Hi, it's great to meet you, and it's great to be here with you and talk about a pretty important topic from my perspective.
Fantastic, fantastic. So now, with the midst of this pandemic kind of ravaging within the United States and pretty much many parts of the world, there has been a huge bits of pressure on enhancing the digital tools and landscape of the ability of types of data that we're collecting on patients and population in real world. And with increased investments in digital health so far this year, so far hitting $9 billion just in the first half, which has been a record so far to date, where do you see the role of real-world evidence playing in really understanding what to learn about patients and the FDA's perspective around using real-world evidence for this reason?
So, first of all, as I think about the pandemic, if I imagine where we are right now and where we're going to need to be in managing this virus and the health of our population, we need to rapidly answer a huge swath of questions right now, which means that while the best way to answer critical questions is through thoughtful experimental designs like randomized controlled trials, we don't have enough clinical trial capacity or enough time to use clinical trials for every question sitting in front of us. And so we're going to need to leverage all the data sources currently available, including data sources that are classically called real-world data sources. These are electronic health records and claims data, but also include information from social media feeds or from a fitness watch. So many different data sources that describe a person's health, their activities, what they've experienced, potential adverse effects of interventions or treatments. And we're going to not only need to learn how to use this information and put it to use for critical questions in COVID-19, we're going to need to understand when we can rely on it, when is it adequate and credible, and when do we need to now really direct our clinical trial resources to answer those questions where real world data can't help us.
That's very helpful. Now, you mentioned social media. So what would be some of the steps or examples the FDA has taken to kind of discern what would be a real, I guess, data source on social media that will be verified versus that of, let's say, a bot posting? That may lead to some understanding which is not true or lead to an incidence for patients which could cause potential harm.
So before I go to how we might deal with social media and bots, maybe what I'll do is back up a couple of steps to think about what we're learning about where real world data might be put to task. And that will then help us sort of start to address the questions that you've brought up around social media. So at FDA, we have been participating in a number of projects inside the agency and outside the agency to utilize real world data to address our critical questions. And as we've been doing that, we've been learning really where we can rely on it, where do we need to do additional work in order to allow real world evidence to be credible, and where can't we rely on it. And examples are questions such as what's the natural history of COVID-19? What are the patterns of treatments patients are receiving and how have those patterns changed over time? What are new problems we're dealing with, such as the emergence of clotting disorders or the challenges of late effects to the heart? And then how does that inform, for example, what treatments may have differing impacts, both on the safety side as well as the effectiveness of treatments, and how can we think about the role of diagnostics and differing performance of diagnostics? So those are some of the kinds of questions that real world data is being used for. Now, you asked specifically about social media feeds and how do we think about that? Mm-hmm. Well, practically speaking, you can imagine that we need to take a series of developmental steps and do this quickly. So first learning how to use electronic health record data more confidently, claims data, et cetera, and then starting to layer in new information. And an example is we have been watching some pretty interesting work happening with Twitter feeds and how Twitter can help to understand signals that people are communicating about that may deserve additional deep dive attention. So for example, one of the areas that really received a lot of attention was around clotting events. And doctors were noticing clotting events, patients were describing challenges that sounded like clotting events, which then led to increased understanding that maybe clotting was a challenge in the context of COVID-19. And so we can use, for example, social media to help to pick up signals and then use other data sets to verify those signals. And that's something we're just starting to think about. I wouldn't call this FDA specific work, but rather work FDA is paying close attention to. The third part of your question was around where might this go awry? So for example, how do we need to think about the role of bots and how that may create misinformation that may also be one of the signals. And, you know, first of all, be attentive, right? So recognize that information may be misinformation and may or may not be nefarious in how it has occurred. Secondly, to do the experimentation to understand what does inadequate information, misinformation, nefarious information look like, and be able to identify that quickly. So oftentimes bots have particular patterns that can be identified. And then also be transparent. I mean, one of the challenges with all of these new types of data sources is that perhaps you're saying, well, we're interested in learning more about how social media data can help. And the really quick retort is, oh, but that's not reliable because ... one of which is bots. And by being transparent that we are curious about some of these new data sources, but we're also attentive to the potential risks and downsides, allows people to know we're paying attention to all the different aspects. So this is something that's high in our mind as we start to think about these new types of data.
That's fantastic to know. You mentioned risks when it comes to these platforms, et cetera. Now, with the rise of digital health and many of these tech giants really taking a foray into healthcare. Now, having been within the clinical trial space for almost 2 decades now, one of the primary steps to get to clinical trials is really informed consent, because without informed consent, you really can't get anywhere. And the informed consent is always for the intended use of the clinical trial that the patient's participating for the data they want to collect for in that trial. Now, with these tech giants, when you have wearables and devices, even your smartphone with the 11 to 15 sensors that are embedded within the actual phone itself, you're continuously capturing data to understand not just overall demographic information, but you understand behavioral patterns, you understand behavioral impulse control, geographic location, etc. What is the FDA's perspective in terms, or even Amy's perspective, really in this understanding, what is the patient's rights in being able to access this data to get a better understanding of themselves and how it's being used to really create either new services for them that they may not even want, or something they can overall contribute to in the future?
Well, so you're bringing up a really important point and focus that's near and dear to my heart, which is that as we have all of these new data sources, all of these new capabilities, we also have new challenges as it relates to privacy, a person's rights. How do we know that information is being used in the way that we intended? In the context of a clinical trial, I'm an old clinical trialist myself, it was quite explicit up front. Here's what's going to happen. Here's how my information is going to be used. And those controls are already, put in place in a very explicit way. Within the context of the real world data space, when it's around health, we have clear laws as it relates to, for example, HIPAA. However, as you start to talk about the consumer space, right? As we start to now think about products, you mentioned the smartphone that has many different sensors and where information may be used in many different ways that are sort of outside of the traditional contexts of health information for HIPAA. We now are in a privacy space and a data utilization space that's very different than that which we envisioned 20 years ago, to be honest. And I think we're at a place where the EULA, the agreements you sort of nonchalantly sign off on as you use different software solutions, is probably becoming less and less adequate for making sure that people are fully informed about how their information is going to be used. So you asked, what's FDA doing? So FDA doesn't really hold, or under rare circumstances do we hold identifiable patient health information. And really, we work under the context of the law, as you can imagine, and that's really not our focus. So we work in that way. But we are also, though, and I am very much a part of a social conversation that's really, asking what does this look like now and into the future. And I think that as we see these different uses of information, as we also see the different challenges of how it can be misused, it's forcing us as a society to ask what is and is not okay. Right now, it's largely in the hands of tech companies that where sort of all these stories are playing out, but it likely needs to be in the hands of all the different people who really are the core to not only the conversation, but the data.
Exactly. No, that's a really good point. Thank you for that. Now, staying with the tech space and in terms of cybersecurity, now you have, with the advent of the smartphone since 2007, many of the different applications of how we live and interact in daily life are now onto this little rectangular device that we have in our hands, right? And that would also include, from a health perspective, insulin pumps and even glucose monitors, right? That we can now see the actual overall results of what's happening inside our bodies on our phones. Now, with many different news articles in the last year really coming out that these devices could be hacked into, from a cybersecurity perspective, what has the FDA done to take safety steps and precautions to ensure that these devices meet the minimum criteria to ensure patient safety and this would not happen again in the future, or at least minimize it to some degree?
So as FDA, this is a huge area of concern for us, and certainly has been a core focus of our devices center, CDRH. And I commend them, but I also commend the entire community for focusing on this. And that's been done both through public-private partnerships as well as specifically through work done at FDA, where we worry about really the development of more secure devices going forward, but also the challenge of legacy devices that still exist. For example, the insulin pump that was around since many years ago that may now have a security challenge because those have not been fully patched. And as FDA, one of the things that we've done is build partnerships, and an example of those partnerships is with actually DEF CON and the biohacking community. And when I arrived at FDA about 18 months ago, I was, I was pleasantly surprised to learn that not only were we excited attendees of DEF CON, that we also participated in the biohacking community and had been doing so since 2014, I believe. And that in 2019, we even developed the We Heart Hackers initiative, really as a part of our partnership with the white hacking community. And the interesting thing to me about this work that I've at least learned about is that there have been a number of companies participating, I think over 40 different devices that have been attempted to be hacked into and otherwise patched, and really has actually led to a community-based effort to start to resolve problems that could otherwise hurt patients if they don't get resolved. And so to me, this is an example of how the FDA's tried to be forward-leaning into this space, and instead of just writing guidances and saying thou shall or thou shalt, but actually trying to figure out how we will fix together this particular space.
That's amazing. That's really good to hear. That really brings us, to the end of our discussion today. Maybe some last, parting words from you, Amy, if you want to share with the audience today in terms of what you would tell the hacking community and the attendees of this overall conference, and what to do and how best to contribute data so they can, better not just devices, but really the overall experience for those that use those devices.
Yeah, I've been thinking a lot about the realities of real-world data, how important I think it's going to be for COVID-19, and how I think that this sets a template for how we may also use real-world data and real-world evidence in the future. And then that quickly ports me over to the questions around cybersecurity and hacking. And why do these two come together? Because if our data sets and our real-world data sets are important for health in the way that helps us understand not only natural history disease, but also what treatments are working or downstream safety events of treatments or vaccines, then those data and the safety of the data themselves and our ability to have confidence that they haven't been tampered with, that the devices that are generating those data haven't been tampered with, right, is also a critical task. And so to the white hat hacking community, I ask us to think about how do we continue to keep our real world data sources safe? Because those data sources are going to be important for actually our overall public health and safety in the future. And I think that that's going to be an important area of inquiry and questioning that really hasn't gotten enough attention yet.
Thank you for that. No, that's really helpful. And it's nice to know that this partnership is going to continue and only probably blossom in the future to get even more insights that you can possibly get to, from now on. With that brings us to the end of this fireside chat session. So thank you so much for attending, and have a great conference, everyone.
Thank you.
Dr. Rorschach. I am coming from the University of Washington from the Paul G. Allen School of Computer Science and Engineering with the Molecular Information Systems Lab, where we are really interested in doing interesting things with storing information in DNA and different types of sensing that kind of appeals to the DIY audience a little bit. So the project that I'm going to talk about today is called Porcupine, which is doing rapid and robust tagging of physical objects using DNA with highly separable nanopore signatures. Or in a little bit more accessible terms, we tag stuff with DNA and we use nanopores to read it. That's really all we're talking about here. So when we're talking about molecular tags, we are using DNA to identify physical objects. This is kind of could be in the same world as QR codes and RFID tags. But essentially, we want to be able to tag an object with DNA, ship it or store it somewhere, and then be able to read it back on the other side and say, is this the same object? What's the information in the tag, or is it completely wrong? And some applications of this include tracking and provenance. So you might have a high value item that you want to be able to make sure is the same at the beginning and end of the transaction. Secret exchange and counterfeit detection. So maybe you've got a set of pills and you only want to be able to sample a few of them at a time. You could do that with a system like this. And we ended up using the nanopore MinION device to detect these molecular tags. Some of our system requirements were that we wanted this to be DIY end-to-end by non-experts and not require a full biolab. I myself am a computer scientist, and this is something that I can do with maybe a little bit of supervision, so it's not too challenging. And we wanted to be able to generate arbitrary tags on demand without having to do more DNA synthesis. This is one of the most expensive parts of encoding information when using DNA. And so if we can do that ahead of time and just be able to copy it instead of having to generate new DNA for every piece of new information, that can save a lot of cost. We wanted to be able to decode quickly and accurately, and also use minimal special equipment. So the nanopore really fits pretty well with this kind of application. One challenge for typical sequencers is that they're often inaccessible to pretty much everybody except for very, very well-funded labs. These cost anywhere from tens to hundreds of thousands of dollars, which doesn't necessarily mean that they're bad, but it's just not very useful for DIY. And they're pretty large. They sit on a big bench top. I'm sure many of you have seen them before. But it's really hard to compare to this candy bar sized device that can just be plugged into your laptop. And here's a picture of it plugged into a laptop. All the things that you need to run this are very small, like pipettes, a small centrifuge, so it doesn't require the whole lab. And just to briefly run over how this works, I took this diagram from a Nature article. Basically, there is this thin membrane that is present with little nanoscale pores, and there's an ionic current that is being run across this thing, and the current is being measured over time. And then the DNA is prepared such that there is an enzyme that will unwind the DNA for you, and it will flow through this pore. As the DNA gets unwound and is flying through, the current changes a little bit, and so you can go back and tell what DNA was in the pore based on what the current looks like. There's this little diagram in this corner here that shows basically different ionic current traces for each base. Now, typically these will all be concatenated together and won't go back up to this open channel state, but it's really just a time series of ionic current measurements instead of actually directly reading the bases. So when we are creating a molecular tag within Porcupine, what we start out with is just like any other digital tag, any RFID tag or QR code or anything, is basically just digital information, a bunch of bits and ones and zeros. And each different bit is assigned a different type of DNA. So what will happen is you've got physically a little vial of this particular set of molecular bits that we call them. So when you have a bit that is 1, you'll pipette that bit into the molecular tag mixture, and if it's 0, you completely leave it out. So we're really encoding information via presence or absence of these different types of DNA. Then we will apply this tag mixture to an object when dehydrated, ship it or store it somewhere, and then rehydrate the molecular tag using a buffer solution. We'll then load it into the MinION and read it out using some software that we created. When we are actually creating these molecular tags, we're not just encoding the information directly, we've kind of got a step in there that is adding some error correction. So we have a digital tag that's a little bit shorter, code word that's longer that has some additional bits in order to add some error correction, which I'll talk about more later. But then we are going to the molecular bits and the molecular tag. And a single molecule is made of a unique sequence and a specific length. So this is the part that lets us create more bits without having to sequence to create more DNA. So we have our barcode sequence at the very beginning of the strand, then a spacer, and then another barcode sequence and a sequencing adapter. And typically when encoding information in DNA, the information is recorded throughout the entire strand. And so I often get asked, why wouldn't you take advantage of the incredible density of DNA to make this happen? And really this comes down to creating more bits without having to synthesize more DNA. We start out with our nice little well plate of 96 sequences. And if we just add 2 different lengths, we have 192 mole bits without ever having to go back to ask IDT for more short strands for us. And then the second part of it is that having this unique identifiable region means that we can avoid base calling. So when we turn this complicated nanopore signal into bases, it takes a very, very long time and is very complex. And that is the largest source of the error in the pipeline for working with nanopore data, where we actually have a much simpler problem. We're not trying to identify any DNA, just the DNA that we know is already there. So we can turn this into a classification problem instead of a decoding problem. That saves a lot of time and increases our accuracy pretty dramatically. And we design molecular bits to have distinct nanopore signals. We do this using a tool called Scrappy that is produced by Oxford Nanopore itself. So we can give it a signal or a sequence. It will produce a theoretical signal. And then this is the actual nanopore signal. And we didn't really cherry pick one of these. They kind of all look similar, maybe a little bit stretched or narrower, but this allows us to really be able to design these sequences to look different, which makes our problem a lot easier. When we are designing these sequences, we're using an evolutionary process. We're starting out with an initial batch of them. We throw our 96, like in our virtual well plate, simulate what they look like, and then compute how different they are. And we will then start an evolutionary process where we shuffle them, mutate them, and then make sure that we're actually improving things. So it's kind of like a guess and check method that will make these look visually different. And basically the lighter colors here are more similar, so they look like the similar squiggles, and then you can see they, like this guy looks very different from this after this full process here. I don't want to pretend like this is the first time anybody has come up with anything that is working with raw nanopore data. There's in particular a group that is working with demultiplexing. And for anybody unfamiliar, multiplexing is a tool that is used to add barcodes on to a sample so that any reads that you get back out on the other side can be associated with a particular sample. And then at the end, you can go separate things out and make it so that you are only working on your one sample at a time. And what they've done in this case is taken the barcodes that Oxford Nanopore has produced for multiplexing. They found a subset of them and then can identify those using the raw nanopore signal. One challenge that they have is that they didn't have the ability to design them specifically to identify them later, meaning that they are working with a much more challenging problem than we are. But it's a pretty cool tool, and it's been very useful for folks. And then another one, it's currently you can't just go buy multiplexing barcodes for RNA. And so there's a group that developed 4 barcodes that they could then identify, which is really similar to what we're doing. We kind of developed it independently, but it is a similar process. However, and the way that all of these work is kind of classifying them similarly. We're trying to just identify what little barcode is present in the individual reads. Our training data, we label the squiggles using sequencing data and then spread all the bits across a bunch of different runs. Then test data with half of the bits And we ended up using a 5-layer CNN with a fully connected layer and softmax. And this is all stuff that I'm happy to answer more questions about in greater detail later if desired. Our classification accuracy is very high, and the only reason that I actually say this is to show you that identifying mole bits is a totally a non-issue. Our training accuracy is like 99.9 something, validation 97.7. It's kind of to the point where it's not really an issue for us to be able to identify the mole bits. However, identifying what the tag is based on the mole bits can be a little bit more challenging. Now that we have our sandbox, we've got our molecular bits and we have a way to read them. The question is, what should we encode and how should we encode it? We have our 96 bits and we have kind of our framework where we might want to expand our digital tag, but we have to think about how we might want to do that. The most naive encoding scheme, of course, is mapping one digital bit to one molecular bit. And this is, of course, not ideal because 1 bit error means that you completely get the entire tag wrong. And so we want to add some error correction, as alluded to previously. What we'll do is we'll reserve some bits for the tag and then use the rest of them to correct errors. And in our case, we picked a 32-bit message and then multiplied by a 32 by 96 random generator matrix to produce a code word, which then gets put in the molecular tag. And this allows us to get up to 18 bits wrong, which is an enormous amount, without ever worrying about whether we're going to get the tag wrong. This is something that can also be chosen depending on the application. It's just an example that we have for basically our paper that we wrote. But if you wanted to take these 96 bits and use them in another way, there's nothing that would stop anybody from doing that. So just to briefly walk through encoding an actual message here, because it's a little bit hard to kind of to connect the two. We'll start out with our digital tag here. We had to encode our molecular information systems lab, of course. And then we added the bits for the code word. Then we'll go through the process of actually encoding and sequencing and doing all the wet lab stuff. And then what we'll get back out of the sequencing machine is a set of read counts. So how many times did we observe that particular molecular bit? And then we have to decide, like, at what point do we want to set it to 1? At what point do we want to set it to 0? So we have a threshold here where anything that is above this line will set to 1 and below it is 0. And then we get a few incorrect bits. This is okay. We have fewer than our 18, so we'll still decode correctly. But we also realized that there's kind of a large variation in read counts here. And we found that this was reproducible. Still cannot figure out why. I'm more than happy to talk to people about why this might be happening because we've tried a million things. But it's reproducible, so we were able to rescale the counts. And essentially what happens is that we get no bit errors after doing that. And we recover our final decoded message here. So our final results, we are talking about how long does it take to actually decode a message? Do you need to run this for hours, overnight, seconds, minutes? And so what we have here is on the x-axis, we've got our sequencing runtime in seconds in the log scale. And then we've got our code word distance over here. So you can imagine that in reality, you could possibly get all 96 bits wrong. However, because we have used error correcting codes, the maximum or the minimum distance between all of them is 18 bits. So if you get 19 bits wrong, in some cases, you'll actually get a totally different code word. So in this context with the error correction, the maximum number of bits can be anywhere from like 18 to 20-ish. What we have here is, as expected, as your sequencing runtime goes down, or as your sequencing runtime increases, the chance of you getting the message wrong goes down because you've observed enough reads to be really confident. Each X here is an incorrect decoding, and then our dashed line is guaranteed correct decoding with the error correction. And we are able to decode with only about 10 seconds of data, which is really nice because with nanopore sequencing, you can just stop at any point. You don't have to keep running this for hours and hours because the process doesn't require you to do that. It's just physical strands flowing through this membrane. And what this means is that we can do pretty close to real-time reading. Another cool thing is that we've made the molecular tags shelf stable. This is really important for basically any kind of application you can think of where you want to tag something for more than a few minutes. You want to be able to ship or store your object, but then afterwards we can rehydrate it and then read it. And that has been a crucial part of this. So we'll prepare this tag for sequencing immediately after assembling the tag. This is a step that takes about 1 to 2 hours. So we are front loading all of the lab work on the writing side, meaning when you go to read it, you don't have to spend hardly any time at all. It's like seconds. We also sent a tag in the mail and just through regular mail like USPS to California, and we could recover everything after about 4 weeks. I'm not sure what the upper bound is on how long these things will last, but we basically got the same sample back that we sent. So I think there's a lot of work to be done on figuring out like what are the bounds on what kinds of like surfaces these things can be attached to and how long they will last. But initial results are kind of promising for these being actually stable. And then because we're attaching the sequencing adapter ahead of time, the part that's actually doing the unwinding of the DNA, you can't get any contamination. It's just not possible to happen after that process is completed because you have to have that adapter in order for it to be read. And so putting it on a surface means that you could have someone's like environmental DNA or anything, and it will still mostly read out fine. Another big question that I get is like, okay, cool, but what can we actually use this for? And we haven't really explored the extent of what kinds of surfaces or anything that this could be used on, but we can think of things that are traditionally difficult to tag with QR codes and RFID codes and such. This might include things like liquids, maybe food with some safety testing. We make no claims about it actually being safe for food without testing. And paper and commodities. So maybe you have a supply chain where you want to tag everything and then only read back a few of them. You can really amortize the cost because reading is going to be the highest cost in this process. And there's some prior work that demonstrates some DNA encapsulation methods. These methods add some time and effort to the process, but they could be used to further extend the life past what this would normally live on its own for. So in summary, we have our molecular tagging system that uses our DNA to tag physical objects. The design uses an evolutionary model for nanopore orthogonal sequences, making them look visually as different as possible and essentially trying to make our classification problem easier. And then we classify using a CNN. We will encode and decode using our random generator matrix, but again, agnostic to any type of encoding that you want to use. And we can get readout with less than 10 seconds of data. Future work might be like using a generative model to design these instead of an evolutionary model that's a guess and check. And also considering these different kinds of encoding and decoding methods that might be able to take advantage of different parts of the known error in the system, which we haven't really done at all. Another thing to consider, especially because this is a security-minded conference, is what kind of security this actually provides. And one nice thing is that DNA is invisible. However, security by obfuscation is not always the right kind of security. It can be good in some circumstances, but you're never going to fool anybody who is really dedicated to getting access to this just by making it invisible. And so there are applications where this would be useful and maybe not. And I'm really curious if anybody has thoughts on maybe this sparked some kind of interesting application that we haven't thought of yet. I also just wanted to give a really quick plug for the other things that our lab is doing because I think it's really cool and I only work on a very small segment of this. Our lab works primarily on something called DNA data storage, where we're trying to store information in DNA and read it back later, but not in terms of like presence or absence, but actually encoding information in the bases of the DNA. And this has been pretty far developed, but still reading or like the writing aspect is very expensive the cheapest I've ever seen DNA for is like 7 cents per base, which is astronomical when you consider large volumes of DNA. And that's been a pretty large barrier, but it's part of our, I think what's a really cool idea. DNA security. So this is part of our lab called biosecurity. One paper that came out recently was talking about the GenBank system and some of the security implications. We also have microfluidic automation. So how do you abstract away some of the tedious parts of working in the lab, and then DNA circuits. And of course, the nanopore sensing is what I personally work on. And with that, I will wrap up, and I'm happy to take any questions in the live Q&A after the session. Thank you.
Okay, so we are live. So if you do have a question for Katie, please go ahead and ask it in chat. We are monitoring the Twitch and YouTube as well as the Discord. Whenever you have a question, go ahead and ask it. But with that, Phoenix, go ahead and ask the first question. Oh, well, I was muted. I didn't even realize it. Okay, I'll repeat what I just said. We are live now, so if you do have any questions, please go ahead and ask them in chat. We are keeping track of what's being said on YouTube and Twitch, as well as the Discord. So go ahead and ask at any time. But with that, Phoenix, please go ahead and ask the first question.
Hi, a question came in while you were speaking. They said, the name is Hokermon. I'm the head of archives for a web archival nonprofit working with DNA storage for preservation of cultural heritage data. We follow MISL's work. How do you envision Porcupine working with a large-scale SynBio-based data deposition system? Or rather, what sort of logistical context do you imagine Porcupine being best suited for?
Oh geez, I'm muted, sorry. Awesome question. I'm excited that you follow our work, and probably what you have seen before is the archival data storage, which is kind of like the flagship work for our lab. And the analogy that I would give is that this DNA data storage of that scale is most similar to a hard drive, whereas the Porcupine system would be more similar to like a QR code or barcode, or things where you don't really have a ton of information to store, but you want to be able to read it really quickly. So in terms of like data deposition, this Porcupine system probably isn't the right fit, but if you want to tag a large number of objects and then be able to read them later, that's kind of more the scale that we're working on. And yeah, the same issues at work that are present for DNA data storage for large scale synthetic biology applications, the limitation is still synthesis. And so although this application isn't the same, like the chunk of Porcupine that we're trying to help improve that that synthesis cost is just working on small bits of data. I don't know if that answers your question, but thank you.
Perfect. The next question comes from Mike. The initial DNA synthesis is expensive. However, once they are generated, they can be copied quite cheaply. Have you considered creating a library of DNA sequences for front-end users to purchase?
Yes, we have. We actually filed a patent for this kind of application because we know that there are companies that are kind of working in the DNA tagging space. But the idea is that hopefully you could just purchase the set of 96 sequences and then you can mix and match. Now, pipetting 96 things is not necessarily a fun thing. On average, you'll be putting half of them in, plus or minus a few, depending on what your code is. But this plus maybe some kind of like robotic application where you could just automatically pipette things to mix your tag for you would be kind of a cool commercial application as well.
Great. Gabo asks if you can share the link to biosecurity.
Yes, I can do that after. I will probably fail to do so if I try now, but I will send that.
All right. That seems to be most of it. It looks like we just had something come in on Discord. There's not really a question, but more of a comment that they said, I can see using porcupine to contaminate precursor materials that may end up in the hands of terrorists or drug cartels, perhaps marking weapons and such also.
Yeah, so I think that there's pretty big applications in this sphere, like especially if you want to take where something came from and where something ended up. I think similarly along those lines, if I'm understanding what you're getting at properly, like let's say you want to measure deforestation. I don't know what kind of scale would be required in order to apply this in that kind of environment, but if you, let's say you tagged a bunch of trees or like something that you know is going to go in bad hands, you can test later where that came from, and maybe the people that have it currently shouldn't, and that could be used as kind of a measure of like an invisible layer of security to be able to track these things. And of course, security, as I mentioned, security by obfuscation is not good security, but if it could be just one piece of the puzzle in order to be able to identify these things later.
All right, I think that is all the questions we have right now.
Awesome, thank you.
Thank
All
you.
right. Well, thank you so much, Katie. If people do have any other questions, we do have a link to her Twitter just on screen, so you can reach out to her directly there. But with that, our next talk will be in about 4 minutes, so we'll see you then.
Okay, thank you so much.
Today we're going to be talking about redefining patient safety in the digital era. My name is Dina Mendelson. I'm Director of Health Policy and Data Governance at Electra Labs.
And I'm Jen Goldsack. I'm the Executive Director of the Digital Medicine Society.
When Diane Diller, a woman featured in a 2019 Washington Post news article, downloaded the pregnancy tracking app Ovia, she used it for much the same reason as the app's 10 million other viewers, to track her pregnancy and the health of her baby. She did not intend for that information to be shared with her employer, but that's exactly what happened. Think about what's involved with making a baby. Think about how you'd feel if your boss got the details. It's not just embarrassing for women, it puts them at risk for pregnancy discrimination and adverse effects in the workplace. But first, some level setting. Jen will walk you through exactly what we're talking about when we talk about biometric monitoring technologies. She'll also explain why, despite a whole DEF CON talk designed to point out the safety risks of these products, we still believe that these technologies are critical for patient care and clinical research. Jen will also cover our biometric ethics portion before tossing it to me to discuss the shaky ground for data rights in the United States. After that, we'll get to the fun stuff, if you consider serious safety violations to be fun.
Fantastic. Thanks, Dina. So let's dive in and think about why healthcare is different in the digital age and why digital health at all. If we look at the financial information, we see huge possibilities, huge promise, and a lot of noise in Silicon Valley about the value, the financial value of this new and emerging industry. And in fact, even throughout the course of the pandemic, the first half of 2020 yielded some of the greatest investments in digital health. So is it all about the money? Absolutely not. I think that the financial investments that we've seen are a product of and perhaps an indicator for, but certainly aren't the reason that we're passionately pursuing the safe, effective, ethical, and equitable use of digital health technologies. Let's think about the healthcare environment that we've been in for the last few decades. Let's think about some of the persistent and pervasive problems that as a community, as and not just as an industry, as a whole population that we faced as a result of these challenges in healthcare. So in 2018, US household spending topped $1 trillion. Now we know that healthcare spending writ large here in the US is over $3 trillion, but kitchen table conversations, what folks were individually being asked to write a check for to preserve their own health was over $1 trillion. Let's put that into context. $3 trillion total healthcare spending here in the US. It's more than the GDP of France. This is an enormous industry and we are paying a price for it that we cannot afford. And despite all of this investment, our workforce here in the US is dying at higher rates than any other developed country. We're paying out of the nose for healthcare and we are not getting high quality in return. In fact, the number one reason that most Americans file for bankruptcy is healthcare costs. And the other week I learned it's the number 2 reason cited these days in divorce proceedings. It's the stress and the strain and the financial implications of a healthcare system that is absolutely unsustainable. And despite all of this, we still have these catastrophic diseases and illnesses that we are in no place to try and treat. There is not a single disease modifying treatment available for Alzheimer's, and there's certainly no cure. Interestingly, for folks who don't know, the gold standard that we use in evaluating Alzheimer's, whether it's a loved one that you're helping get treatment for, or whether it's in a clinical trial setting, is a document called the ADAS-COG. It's a 30-something page paper document that physicians fill out. It's a blunt instrument that's helping us preserve the status quo. And in the absence of technology, we're really going to struggle to make progress. And the challenge is, even when we do have terrific interventions and treatments for chronic diseases such as diabetes, 1 in 4 diabetics in the US ration their insulin because they can't afford to pay for it. This is an unsustainable status quo that we're in today. We have our warfighters coming home from service and due to PTSD that we cannot treat when they're in rural areas, there's a really sort of terrible maldistribution of folks who can help them and the patients in need. Our American heroes are dying for preventable reasons. And finally, even the clinicians who are at the front lines have suicide rates at the highest possible level. This is a system that is broken for absolutely everyone involved. And so I would say to you that we're not here to talk about technology today because it's cool. We're not here to talk about technology because there's a ton of money in it. We are passionate about the use of these technologies to try and solve these problems. They're not going to be a silver bullet, but we believe that they can make a difference. But what we want to discuss today with this idea of a new definition of patient safety is for all of the promise that these technologies have, there are new risks that we need to be eyes wide open to make sure that we aren't creating a new laundry list of difficulties in the digital era of healthcare. So let's actually talk about for a hot second what we mean when we talk about digital health. As I said, the industry is enormous. At some point, we envisage, digital health being a bit like computers in business. They're going to be ubiquitous. So if we're talking about a $3 trillion industry, where are we putting the different digital components? So we would offer up a definition that the use of digital in the support of improved lives or improved health all fits into the bucket of digital health. And that includes things like communications technologies, record keeping systems, so on and so forth. Within that, there's a more specific category of digital medicine products, which both measure and intervene in the service of health. So that may be sensor technologies, that may be algorithms, that may be different tools and solutions that support the administration of active molecules and traditional devices. And then there's a very specific subset of the field that we would describe as digital therapeutics, where the software itself is the intervention. That's a new and rapidly growing field, and I think an important component for us to keep in mind. For the purposes of mine and Dina's talk today, we are going to focus on biometric monitoring technologies, or biomeds. And we define those specifically as connected digital medicine tools, and ones that rely upon a sensor for data capture, and a single or a suite of algorithms for processing that information to give us measures of a person's health status. And why are we so interested in these biomeds? This is a great visual that I like to show. If we think about how we deliver healthcare in current state, if we think about how we do clinical research, we're relying on these really isolated data snapshots that you see at the top of the graph. The possibility created by these biometric monitoring technologies is that we can have a much greater, a much more holistic look at a patient's lived experience with and without disease, with and without a given treatment. And that's why we're so keen to focus on this, because we see this as sort of the tip of the spear in really addressing some of those really pressing healthcare challenges that I shared with you earlier. And this is a bit of a silly cartoon, but because it's important to have some levity, but I wanted to talk about how decision-making actually works in healthcare today. Oftentimes we think about a risk-benefit analysis. It's wrong to say that we don't tolerate risk. It's wrong to say that we don't tolerate safety issues. And I think chemotherapy might be a really good example. For anyone who has battled cancer themselves or has sort of been on the journey with a loved one, we all know that the side effects of chemotherapy is often awful, from hair loss to devastating sort of sickness to weight loss, so on and so forth. That there is a risk-benefit calculation that goes into the approval and prescription of those drugs. If we are in a fight to save your life, we are going to tolerate some safety issues, some quality of life issues, because there's a lot at stake. Now, we would never apply that same risk-benefit to a treatment for a common cold, for example. We can't treat a common cold, which we could. We might be having more luck for coronavirus, but there are certainly some drugs out there that can help you with the symptoms of a snotty nose, of a sore throat. We would not tolerate any safety issues from those sorts of drugs. Why? Because the risk of the cold is low. Few people are going to have any more serious issues than some pretty unpleasant symptoms for a few days. So it all comes down to that risk benefit. The benefit of a chemotherapy is we can save your life. So we tolerate higher risks. The benefit of a common cold drug is a little more comfort for a few days. We aren't going to expose you to any additional safety risks. And so I thought that might be a really good way just to sort of ground our conversation of decision-making in healthcare and why and how we might tolerate safety risks to an individual. And so Dina and I are going to be handing off to each other. I'm going to talk briefly before I hand back to Dina about sort of biomedical ethics. This is a huge topic, an emerging and important topic. And certainly I'm not an expert, but there are some themes that we should all be aware of. And there is some groundwork that we should have a common understanding of before we think about how digital affects healthcare. So for a healthcare practice to be considered ethical, it has to sort of reflect 4 principles. The first is autonomy, where individuals have autonomy of thought and intention when they're making decisions. And a really good example of this is in the informed consent process. So if you're entering into research, you need to know all of the risks and potential benefits. You need to truly understand them, and then you're asked to provide a written consent. This is also the same for anyone who's had surgery, for example. You always have an informed consent before you go into surgery. You need to know the risks, and you need to knowingly opt in to participating in healthcare. Justice, I think, is really important. It helps us think about the burdens and benefits being distributed equally. So let's think about that in the context of digital. Let's think about if we start to implement the use of these biometric monitoring technologies, are we ensuring justice for folks who don't have access to broadband? Are we ensuring justice for folks who can't purchase them out of their own pocket? And then how about, when we start to do research using these things, if we find great outcomes using digital technologies, can those be broadly applied to the full population if we aren't able to get everyone access to these tools? Beneficence, which is a word I often stumble over, so I nailed it today. That's like a sort of net good, and a bit of a sore point for me right now, the intent of doing good for the individuals and populations involved. So for example, wear your mask during COVID. That is a nice move there. It's a pretty sensible no-brainer, in my opinion at least. And then the last one, crikey, another one I often stumble over, non-maleficence. Doesn't harm the individual or others in society. And this goes back to that really important principle of harm in the context of benefit. This is never a black and white decision, and we always have to think about context. Again, there are some examples from COVID, I'm sure, sort of come quickly to mind for folks. And the way this is codified in the training of physicians, at least, is the Hippocratic Oath. So all graduating physicians swear the Hippocratic Oath when they finally get done with and declare victory on their passage through medical school. What's important to note about the Hippocratic Oath is it never actually says, but first do no harm. That is not present in the Hippocratic Oath. And I think I'm going to probably bore everyone, but it's really important. It comes back to this idea of risk benefit, and that's codified in the Hippocratic Oath. It's much closer to the ethical principles than it is first do no harm. And something we follow at the Digital Medicine Society, and something I know that Dina and I talk about often, is the great work done by Ian McCavalry. Members of this community have really thought carefully about the new risks associated with security when we're starting to use connected devices, either for monitoring or for healthcare intervention. And what we'll talk a little bit about today is if this community has extrapolated a vision for harm and a risk-benefit analysis to include security considerations, what are the other considerations that we need to be thinking about as we move into this digital era of healthcare? And with that, Dina, I'll hand it back to you.
Thanks, Jen. I'm going to dive right into Health Policy 101, where we're going to start first by explaining the difference between privacy and data rights, so we don't lose anybody from the top. What we've always thought about as privacy tended to be something as a yes or no. Can you have this information? Yes, you can have it. No, you can't have it. But as we get further into data rights and data governance, we start to realize that the question isn't as much yes or no, but it's more about context and who. So when we talk about data rights as opposed to privacy, the choice to share or not to share our data is context specific and varies by the individual. A woman may feel comfortable having her reproductive health app share information with her partner or her healthcare provider. She probably won't feel comfortable having that information shared with her boss, or maybe she will. Maybe that's something that should be up to her. And so that's why we're moving the conversation from one that uses the word privacy to one that's talking about data rights. As it is, our healthcare system has strong protections for patient biospecimens like blood or glucose data, but protections are murkier when it comes to digital specimens. The same can be said of data created by health apps, fitness trackers, and all the other kinds of biomeds that we're talking about today. Now, as Jen said a bunch of times, and I'll reiterate, wearables, health apps, and in-home sensors offer great promise for affordable, accessible, equitable, high-quality care. But in the modern era, data rights have become a safety issue that extends beyond the body. The digital health information that folks generate may threaten both their health and their financial welfare. And that's why we think it's so important that we're talking about it today. In the United States, legal protections are limited for data rights. US laws do not have explicit regulations that give consumers full control over how their data is collected, used, or shared. There also really aren't rules about when we have to delete that information and what exactly that means. Instead, data rights are limited to a patchwork of protections, which is basically a combination of the HIPAA privacy rule, which was never intended to be a comprehensive health privacy law, the FTC Act Section 5, which was drafted a long time before biomeds came around, and state laws, which are effectively the ultimate patchwork protection for consumers, because you really don't know what protections you have unless you're a legal expert or an extremely well-informed consumer. So now we're moving on to redefining safety in the digital era. And first, I'm going to give a kind of broad description of all the different safety issues that Jen and I are concerned about. We've seen enough headlines to know that there's a problem with how our data is being collected, used, and shared. When we see headlines like these, for many of us, it feels wrong. It feels gross. Jen and I want to explore that feeling and have more technologists, clinicians, lawmakers, and the public talking about why this feels wrong. The answer is that it feels wrong because it's not safe. Women's jobs are not safe when their employer has access to their pregnancy information or plans to become pregnant. We're not safe when our insurer makes life or death decisions about our access to care based on data that may not even be right. In this section of the talk, Jen and I will walk you through a handful of data risks and related harms, not to say that technology is bad or should be avoided, but to start the conversation around data rights as an issue of patient safety. Connected health technologies have the power to do more than embarrass. The data it creates can impact how individuals experience day-to-day living and the world around them. When you share information, either passively or actively, you create information about yourself. One key way that data is used is by data brokers or data aggregators. Certainly not all data manipulation accomplished by data aggregators is harmful. However, data packaged as a sort of health score can affect individuals' access to insurance, while the algorithms behind those scores are hidden and could include inaccurate information. Now, some of you may be thinking in your head that the Affordable Care Act means that these scores don't affect our access to insurance, but that's really only limited to health insurance. When you think about all the different ways that a person might want to financially protect themselves or their family, that includes life insurance, disability insurance, and long-term care insurance, to name a few. And all of those are allowed to use information created by these data aggregators. For decades, we've allowed insurers to determine our access to insurance based on genuine medical information. Now, assumptions based on unconsented data from opaque algorithms are changing how traditional underwriting is done, making it challenging for some to purchase insurance at a price that they can afford, or even being denied insurance at all. Aggregated data can also impact lending and housing decisions. Studies from the American University Center for Digital Democracy and the National Bureau of Economic Research both report that consumer health data can be combined by data aggregators and used to profile and discriminate in the context of employment, education, insurance, social services, criminal justice, and finance. Clinicians and researchers may not be aware of how digital data can result in discrimination in these areas. Neither may you. But the type of data manipulation this type of data manipulation can be done as a proxy to circumvent the US Equal Credit Opportunities Act. And it's not something that's going to be done transparently. However, it happens. And that's a serious safety risk that we should all be aware of and consider. Additionally, geolocation information can be used for surveillance. Wearables that measure physical activity use technology that identify an individual's precise movements. While this data is rich information for legitimate use, it can also be used for surveillance. And this is particularly problematic for people of color who are disproportionately the subject of undisclosed surveillance, data collection, and monitoring. There's other ways, of course, that even well-intended technology can cause tangible harm to users. Have you ever had that trouble falling asleep, trying to relax into rest, and all you can think about is the fact that you can't fall asleep? You keep checking the clock and you're still awake? Now imagine an insomniac using a sleep sensor to address sleep issues who, instead of getting helpful data and perhaps better rest, instead spends the night anxious and losing sleep over sleep data and ending up worse than they started. There's actually a term for this kind of harm. It's called orthosomnia, and I'm pretty excited I just pronounced it right. Technology can also cause clinical harm, known as iatrogenic harm. This type of injury can occur when errors in the data collection by biomeds goes unnoticed. And finally, I'll point out that the use of technology in a trial can inadvertently skew results. How participants are recruited over technology can be deeply problematic, as can be technology used as an incentive to participate in a trial. Similarly, deploying technology that cannot measure all participants with equal accuracy will skew data results, even if it appears as if there's an appropriate sample miss. And finally here, some people, including former president candidate Andrew Yang, think that solutions to tech companies profiting off of individual data and collecting and sharing it freely is to make that data cost something and give individuals a cut of the money. While that does play into the idea of data rights and giving individual control, this practice, which is commonly called this idea, which is commonly called digital dividends, for data rights advocates like me, this amounts to pay for privacy. Survey after survey shows that consumers want more control over their private information, and they don't want their information monetized. Yet, ideas like this keep coming up. When digital dividends was on the docket in Oregon in 2019, and I was serving as Senior Policy Counsel for Consumer Reports, I wrote to lawmakers on behalf of Consumer Reports to explain why we opposed such a bill. In essence, data dividend turned the basic right of privacy into a luxury out of reach for lower income individuals. Further, those who sell their data would receive compensation for something that can't realistically be appraised or is lost fully reimbursed. Now I'm going to turn it to Jen, who can help us think more about the safety risks with data rights.
Fantastic, thanks Dina. And I think in terms of recognizing the broad swath of risks associated with sort of data rights and safety, I always turn to you as the expert on this, so appreciate you taking the lead there. I want to talk about some of the other principles that we touched on too. And I think a lot about equity and access. And I've got two graphs up here on the screen. They're a little small, so let me explain them to you. The one on the left is from the Dartmouth Atlas of Health. And this is an example of a specific health outcome. So red is good. In this case, that means that individuals with diabetes are actually getting the necessary vision screening to make sure that their diabetes doesn't actually lead to vision impairment and ultimately blindness. So we can see Up there in New England, they're doing a great job, and in certain areas of the Midwest. Green is where it's a dark green color is where that kind of screening is not happening at all. Individuals with diabetes are not getting high quality care. On the right-hand side, you can see a map of households without internet. And there it's the red color that's showing that there is not great internet access, and blue that there is. So let's think about, there's a really interesting new product on the market called the IDXDR, which is a tool that doesn't require a physician. It's a simple camera. It takes a picture of your retina and it looks to see whether diabetes patients are struggling with imminent risk to their vision. If we're relying on the internet to administer that, we can see that in New England already, they have great outcomes, and that's the place with some of the best internet. Yet, if you look at Texas, they're suffering with some really poor health outcomes, and most of those households don't have internet. So I come back to this idea of, are we going to use these digital tools to ameliorate some of the disparities in access to care, some of the disparities in health outcomes, or are we going to, unfortunately, widen that gap between the healthy and the sick, between the rich and the poor? That's something that we have to keep front of mind, and I would argue is a safety issue. We also intentionally, because otherwise I think it gets overwhelming very quickly, focused on biometrics. But I do want to draw attention to the fact that this digital era of health goes well beyond those remote monitoring technologies that rely on those either fixed point or wearable sensors. There's been instances of using sort of care decision tools that were actually incorporating bias into care outreach. There have been other instances where we're actually defining whole new tracks of data as being important to health. And I'll give you an example. There was this phenomenal study that was done by some researchers at Microsoft. 15% of pancreatic cancer patients can be identified by nothing more than their web searches. Dina summarized the pretty loose and pretty narrow privacy regulations. Certainly nothing extends to your browser history. Let's think about how this plays out. This is phenomenal if we think about your only hope in beating pancreatic cancer being an early diagnosis. If we can harness that information, this is a huge win. It's great for saving lives. But let's think back to some of the examples that Dina shared with us. What if instead of this information going to your doctor or someone who would reach out to you to say, hey, I think you're at risk and I think we can save your life if we act now? What if instead it goes to an employment agency? What if instead it goes to a life insurance company? What if instead it goes to a mortgage lender? There is the possibility here of phenomenal improvements in the way that we care for humans and the cost at which we do it. There is also really quite terrifying risk about how we use this information and the harms that individuals could suffer. And I have a bit of a flair for the dramatic, and I'm very willing to cop to that one. But I don't think it's an overstatement to think about these biometrics and, in fact, sort of digital health writ large. Are we going to weaponize it, or are we going to use it as a tool? Are we going to use it as a way to do low-cost outreach, to deliver personalized medicine, to be as inclusive as we ever have been in the history of healthcare, and hopefully better? Or are we going to use it to double down on the surveillance economy? Are we going to use it to increase the disparities in care across different races, across different socioeconomic status? And, I think that means, in order to address this, we, one, have to be very intentional, and two, as we discussed, we really do need to think about a new definition for patient safety in the digital era. And the definition of patient safety that the World Health Organization has proposed is up here on your screen. It's a lot of text, but what you can see is we're thinking mostly about the absence of preventable harm, reducing risk wherever possible, and collective notions given current knowledge, resources available, and the context of care. So, in fact, when we talk about redefining patient safety, I think this definition holds up quite well. What we really need to do, and what was done very well by the Hippocratic Oath, the connected medical devices, and I Am the Cavalry, is thinking about what is given current knowledge, what are our resources available, and what is the context of care. As we move from data in a manila folder in a file cabinet, delivered in a healthcare environment, to the use of these biometrics, the use of search histories, the dependence on the internet to get information and to administer cures, how do we use our current knowledge about the risks? How do we use the resources available? And how do we think about the context of care being now 24/7 because it's tracking your Google searches, because it's tracking your smartwatch? It's not necessarily that this definition needs to change, but we need to think about how we advance what we know in this community about harms due to connectivity to the internet. And we'd love to learn from you guys during the Q&A about your thoughts, your ideas, and any feedback on anything we've missed, and how we can advance this agenda to sort of saving lives, to reducing preventable harms as we move into this digital era of health. Thank you so much. And Dina, thank you for being such a wonderful co-presenter. I look forward to some great discussion.
Yeah, thank you. This has been great.
Okay, so we are live. We have both Dina and Jen on the call. So if you do have any questions, please go ahead and ask them in chat. Once again, we are keeping track of what is being said on Twitch, Discord, and YouTube. Phoenix, who was on the call, once again will aggregate those questions and ask it to our speakers.
So actually, nope, nothing has come in yet. We'll give it a couple of minutes, see if anybody has any question. I have to say, personally, I love the idea of changing the definition of patient safety, since that drives so many other decisions from the healthcare delivery organization perspective and the medical device manufacturing perspective.
Phoenix, it's so good to hear you say that. I think, we thought a lot about how to get better traction for some of the issues and concerns that we raised during the course of our conversation today, and honing in on the issue of safety, because one, we truly believe these are all safety issues, but also recognizing that our clinical colleagues are very attuned to safety concerns. And I think if we can frame them in that way, we'll not just have sort of more success in communicating the issues, but also hopefully in the sort of impact and rapid uptake in that change of thinking. Dina, curious to hear your thoughts on that.
Yeah, I think a lot of times people think of it as a either or kind of thing. And so you either want to be able to share all your information, but they don't really think about it in different contexts. And I think even when we talk in the healthcare sector, providers and clinicians are very well versed in doing the risk-benefit analysis for traditional medicine. But now that we integrate new technology in there, we need to keep evolving how we're thinking about that risk-benefit analysis.
We did get a question in. It's from Andy. What government regulator is responsible for data rights? Is it the FDA, something else? This feels like it's a gap right now. Is it Health and Human Services, FTC, FCC? Where's the regulatory body?
Yeah, that's a great question and a really confusing answer because we don't really know. The quick version is it depends. And so it depends on whether the technology is being used by the healthcare provider and given to a patient to use in the context of care, in which case HIPAA might apply. But a lot of times the technology, it really is not covered by HIPAA or HHS because it is not information created by a healthcare provider, a health insurance company, or a health data clearinghouse. So what we're really looking at is the FTC covering it under Section 5, and that just looking at whether basically we let the technology create their own laws and their privacy policies. And then we say, did you follow what you said you were going to do? And if they don't, then the FTC might be able to step in. But if they create their own privacy policies that really aren't protective of individual data rights, or their privacy preferences, then they're allowed to do that as long as they say that's what they're going to do.
Okay. Any thoughts on differential privacy? Is it promising, overhyped? Are there specific tools or vendors that are ahead of the game?
Jen, do you want to take that one?
I was actually thinking that you should.
I'm not sure what the question was asked, but I'm not following. I don't know what differential privacy, what we're talking about. We're just talking about giving people data governance so that they can have control over it, or yeah, a little more information.
I'll let you know if they type anything else. The other question that we had come in is, what are your thoughts about safety and security responsibility of various parties across the delivery chain, from device to communication channels to cloud service providers to healthcare delivery organizations?
It's a great question, and I think that really lies at the heart of why we founded the Digital Medicine Society. The purpose of our organization is to bring together experts who represent not just all of those organizations, but all of those communities. So, I think separating vendors out from the cloud providers from the more traditional care organizations is only going to get us so far. I think we really have to acknowledge that, this era of digital health is incredibly collaborative, it's incredibly interdisciplinary, and we really need to have a sort of shared ethical framework and a shared culture around how we respect and how we protect sort of digital health data. And on the sort of the theme of our talk today around sort of redefining patient safety, I think it's probably the right time to challenge our thinking around what is health data. It's no longer the exclusive data that's captured within a healthcare system by your doctor. Even in some of the examples we shared in the talk, it's not just sensor data now. Something as simple as your browser history can be used to infer health status. So I think we really have to think about shared responsibility. And when I say shared responsibility, I don't mean just assume someone else is doing it, but that we all take responsibility for ensuring the safety and security of this data.
Do you see this patient safety definition being something that will be globally applicable, or is it mainly limited to developed geographies?
Well, I think you have to think of it a few different ways. So, of course, we want to have the same the idea of patient safety globally, and we want to make sure that we're recognizing what all the different risks are and what the benefits are. But the way that the calculating needs to be done is probably going to differ based on what the underlying laws and regulations are in each jurisdiction. And so a lot of the safety issues that we brought up today are really created by the lack of comprehensive privacy protections in the United States. And there are other countries that have much better protections for people. And in those places, the risks are not going to be as high as they are here, where we just don't have a baseline level of protection for individuals.
Dina, I think that's a really great answer, and I think speaks to why we selected the World Health Organization definition of patient safety, for example. That really talks about sort of the different relative risks, the different considerations, and we have to apply it not just in the context of local laws, but also local cultures. And that might not even be at the national level, it might be within different communities. And so really thinking about a definition of patient safety that is cognizant of all of the different sort of risks and benefits, but also the specific desires and the specific values of the patient population for whom we're capturing and aggregating data.
And again, that comes back to the earlier conversation about the difference between privacy as a yes/no versus data rights.
With the increased push towards health data integration in the 21st Century Care Act and modification of HIPAA for researchers, what controls are in place to monitor compliance, if any?
I don't know the answer to that question. Dina, are you familiar?
To my understanding, we don't have that many great controls making sure that people are being compliant. I think the person might be thinking in particular about the recent interoperability rule and the fact that providers are required to provide information through API to essentially wherever an individual would want. And at this point, individuals don't really have the information they need to know if they're having their data transferred to a good, for lack of a better word right now, a good service or maybe a more malevolent one. And in those cases, it's really up to the consumer to try to figure out for themselves whether they're having the information ported to the right place. And again, the FTC is the one that's going to be able to enforce there. But I don't think that this is the level of protection that most people would expect to have for their data rights.
And just building on that, that's a great answer, Dina. Something that I've been working on, and actually I've been very proud to have Dina's support on, is, you know, in addition to the existing Cures Act, Cures 2.0 is on deck. There's a draft working paper going around, and it's moving quickly in the context of the COVID crisis. Something I've been advocating for is including more robust protections to try and build trust in the data ecosystem, and not through some kind of PR machine, but actually earning the public's trust in this. And specifically by looking at some of the activities of data brokers and trying to make sure that the sort of latent data that exists about people aren't compiled and used to infer health status for harm. So, you know, we're definitely trying to be sort of proactive in this, and I welcome thoughts from anyone on the line about, you know, other things we can do to try and sort of advance a shared understanding and as well bring some teeth to a new definition of patient safety.
How should the industry address data rights in a world where many, if not most people, are not data literate?
Dina, you want to grab this one and I'll follow you?
You know, individual companies are able to distinguish themselves in the marketplace by having privacy-forward policies, and they should really take that to heart and know that there are a lot of people who, whether they understand the technicalities between how their data is being used and shared, I think that companies will stand out if they make a point of not only saying that they have great privacy practices, but actually following through on having great privacy practices. I think it also, at some point, we have to agree that we do need federal comprehensive privacy legislation that creates a standard framework that everybody has to follow, because then again, companies will be able to compete based on the merits of their technology as opposed to additional things that may be going on with their data. And also, once we do have this baseline of privacy protections that are enshrined in law and apply equally across the entire country, then people, like Jen was saying, will have more trust in the system, will have more trust in the technology. And I think we'll see that we'll become more comfortable sharing our information when we know what's happening with it.
And Dina, I really like how you sort of teed that up, which is there's so much value that we can derive from digital health data. I think if we can safely aggregate it and use it to inform better decision making, whether it's when a pandemic hits our shores or whether it's, you know, trying to improve care pathways from sort of cancers all the way through to chronic conditions like diabetes, you know, there's huge value in this, but how can we do it in a way where we're able to protect the individual? You know, that's the goal here. And I think Dina did a really nice job in the talk of sort of saying, you know, privacy isn't black and white. You know, you can keep something very private if you just sort of lock it in a drawer. That's not going to help either the individual or sort of health at the societal level. So it's incumbent upon us to figure out how to do it safely. And I do keep intentionally using the word safely because, you know, it's not just in a secure fashion. It's not just with adequate privacy controls. It's that sort of very holistic idea of safety for the whole person.
I think jumping from that, Jen, I really like how we're talking about with more trust, people are going to use technology more. And so a perfect example is COVID right now, where it would be great if people would use these COVID monitoring apps and these COVID monitoring tools. But the fact is, a lot of people feel really uncomfortable with it, and they don't know why they feel uncomfortable, but they do. And people who feel uncomfortable and know why know it's because there really aren't that many great privacy protections that can be applied here. And there's concern about what does it mean if you flag yourself of having COVID or possibly having COVID? What could that mean for future ability to get life or disability insurance? What could it mean for employment? And so once we can all get on the same page about what the right thing is the wrong thing to do with data, then again, when we have a public health epidemic like we do today, we'll have more tools available to us. Unfortunately, that's not the case right now. And I do think that that's some of the hesitation behind a lot of people taking up this technology.
Great. Go. Sorry, were you?
Yeah, I think all of these things are sort of tools, I think, to build towards increased trust. How can we use the definition of patient safety? How can we use the expertise? How can we use thoughtful legislation? How can we change a culture? All of things building towards improved trust in a health data ecosystem so we can use it to improve lives.
All right. So I have two comments more than questions. This one that came in said, I think we need to think hard about how we do not leave people behind between the digital divide that you identified around internet access and socioeconomic effects, especially in at-risk groups or regions. So
Yes, thank you for echoing that. I totally agree.
I agree completely. I think that, it's not only that that's the right thing to do, but digital offers such a potential to actually overcome those challenges. If we move forward with this field without sort of seeking for ways to sort of bring the whole population with us, that's a sort of shame on us. So like Dina, I'm really grateful that you emphasized that in your comment. Thank you.
And the person who asked the differential privacy question provided some FYI information on what it is. It's a mathematical approach to obfuscate data elements for things like medical research. And I can go ahead and provide some more information that they did for later.
Great, thank you.
The form of obfuscation.
See, I knew we were going to learn something today, even virtually.
Yeah.
That's brilliant. I'll definitely look into it. And just with that little nudge, I do know that, and Dina, you can't kick me under the table, but just interrupt me if I'm misspeaking. It goes back to what you were saying, I think, about sort of privacy not being black and white. And you may perhaps be willing to consent for certain elements of your data being shared to sort of certain users, perhaps researchers, for example. You may opt to share perhaps clinical data, but not genetic data. I think the idea of that kind of sophisticated consent that can also take place over time and doesn't have to be a static one-time decision. Technology actually allows us to do that, so we should embrace it. Dina, I'm curious on your thoughts and correct me if I butchered anything there.
I'm not great at doing quick responses. I think that I'm still learning because I'm still thinking through it. So I do hope that I can get that information sent to me, and I'd love to learn more about it and also talk to the person who raised it. So thank you for letting us know.
Great, and it looks like that those are all of our questions. Thank you for taking this time to talk about such an important issue.
Yeah, thank you so much. If you do want to reach out to either of our speakers, their Twitter is available just below the box there, so you can reach out to Jen at GoldSackJen and Dina at HealthEDina. But with that, thank you so much for joining us. Our next talk will be in about 12 minutes, so we'll see you then.
Bye, thank you.
Today I'm going to talk about Russian cyber threats in the pandemic era, how actually Russia seized upon the global COVID-19 pandemic as an opportunity to launch its multifaceted, multi-directional information warfare strategy against its prospective enemies, how they used their APT groups, criminal groups, to attack healthcare organizations, research institutes, and hospitals in the United States and in European countries. So before I talk about the hacking and actual disruption, I would like to give you a kind of an overview how Russia sees information warfare strategy, which kind of agencies are in charge, and actually what is their doctrine of information warfare, and how actually they're using APT groups and criminal syndicates to achieve their mission. Let me just give you a kind of an overview how Russian information warfare doctrine works. It is kind of an integrated system that works together. Everything is under one umbrella, whether it is an intelligence, counterintelligence, masking something, attacking enemies' computer networks and software application. So now, kind of a few years ago, 2018, artificial intelligence elements was added to its information warfare doctrine. It actually contains two elements, using artificial intelligence technology in military field and in non-military field. For example, using AI technology to advance their military capabilities, and using AI technology to advance their capability in the medical field, biotechnology field, manufacturing, and energy field. So they actually see artificial intelligence as an emerging tool to secure their strategic interests inside the country and outside the country. Some historical background, how actually information warfare doctrine was formed. I'm going to give you a short overview. The doctrinal and strategic thinking actually is rooted in the teaching of the of the Marshal of the Soviet Union, Nikolai Ogarkov, in what he referred to as the military technical revolution. A brief restatement of his thesis is that computers with accuracy and miniaturization were about to transform the modern battlefield, and that Americans are ahead in this respect, and we really have to do something about it because we're falling behind. So another also events affected the formation of the Russian information warfare doctrine and its subset of cyber warfare. They declared the First and Second Gulf War as a war on military technical revolution. But then fast forward, there was the Eltsin's year, and in this year's theories actually developed theories rather than building machines, writing softwares, and running operations. And fast forward, there were a couple of other events, but a couple of years ago, Chief of the General Staff, current Chief of the General Staff, Valery Gerasimov, published an article in one of the military newspapers that actually was dubbed as a military, as the Gerasimov doctrine in the Western press. But actually he's saying that in a matter of months, perfectly thriving states can be turned into a web of chaos. So they see information warfare and its subset of cyber warfare to achieve their objective in a various direction, whether it's a political direction or the in the military direction or in any other field. So let me just give you a couple of kind of example how which are major players in this respect, which organizations are having having the upper hands actually in information warfare and in subset of cyber warfare. I'm going to give you a small historical overview about this. After in 2003, when since Putin came to power in a couple of years, he actually disbanded the FAPSI, Federal Agency for Government Communication and Information. This agency was in charge of the military intelligence code cracking, cryptographic security, technical intelligence, counterintelligence. And once it was disbanded, so some of its functions went to those organizations: Federal Protective Service, FSO, Federal Security Service, FSB, MVDK, there is Ministry of Internal Affairs of Russia, SVR Foreign Intelligence, and GRU, Russian Military Intelligence. What is also very important here is a large portion of the FAFSI that was left after the organization was renamed the Special Communication and Information Service, and was folded into the FSB. So all of those organizations have their part in information warfare doctrine. What is also very important here, that's the leading role in this respect has the Russian military, GRU, and the Russian Federal Security Service, FSB. So here is a kind of a structure, GRU's research, how actually GRU's research institutes and units are participating in an information warfare, cyber warfare efforts. Let me just give you kind of an overview about those MOD Central Research Institutes and units. So Defense Ministry's 45th Center, Central Research Institute, it's a military unit 54726. Those units actually are in charge of the finding intelligence about the military potentials of the foreign countries. Another unit here is center is the MOD Centers, Ministry of Defense Center for Special Studies. Those center, they are hiring students from engineering schools. They are in charge of the analyzing, exploiting, finding vulnerabilities in a computer system. By the way, what is also very important, as Evgeny Serebryakov, who was actually was expelled from Netherlands in 2018, because he was trying to hack into the OPCW. OPCW is Organization for Prohibition of Chemical Weapons. It's a UN chemical watchdog organization. We were about to craft a report about the poisoning substance that was used against double agent Sergei Skripal and her daughter Yulia, as well as we're about to craft a report on the substance, chemical substance that was used in Duomo, Syria. So we actually wanted to find out what this report was about before its release. Another also major player is MOD's division, 12B division, that is in charge of the cyber operation and psychological operation. Let me just talk a little bit about the 18 Central Research Institute and its unit 11135. Those folks are in charge of the signals intelligence. They are also in charge of development of wireless devices, SCADA system, or electromagnetic protection system. And what is also very important, that's 85 Central Research Institute, it's Unit 26165, Main Center for Special Technology, and it's Unit 7445. Those two units are the major, biggest repository of hacker talents. And those units together, all of them together, actually form the APT28. This is the Advanced Persistent Threat Group. There is also known as a FANCI-BR and has also other names, and they are using, of course, the hacker resolve forces to for their hacking activities. I'm going to talk a little bit later about the GUNID and the Technopolis era, what kind of laboratories they have, including the biotech labs, and what kind of projects actually they are implementing. So another also kind of the development that's happened in the Russian military is that's in 2017, they officially announced about the formation of the military scientific units, also called information warfare troops. And what is also important, that's the Ministry of Shoigu, Minister of Defense of Russia officially made a statement about the formation of these units, and he made openly said that those units not only will be in charge of the securing command and control and communication of the Russian military, or building, developing software for the National Defense Control Center. There is the high supreme body that's responsible for the defense ministry's supervision and management, but those guys also will be in charge of the psychological operation. That once again illustrates how actually Russia sees its information warfare doctrine. The concept of the security, a concept of the compartmentalization, and the idea of the cyber as a separate domain, I mean, doesn't exist in the Russian concept. What is also very important, that's so new warriors of these military scientific units, about the 1,000 personnel are incorporated those units. So they are the engineers, they are cryptographers, they are signalers, they are linguists, they are doctors, they are scientists. So let me just move a little bit and just talk about the Technopolis era. Technopolis era was opened in 2018, and according to the official sources, they want to make it fully operational by the end of 2020. ERA stands as the elite of Russian armies, and they are planning actually to move these military scientific units, the 12th of those units that was created in 2018, all on the permanent basis at Technopolis era. It is also believed that those military scientific units are the arms of the GRU, Russian military intelligence. So 8 major directions that we are working: information telecommunication, supercomputers, information and cybersecurity, technical visions, energy technology, nanotechnologies, nanomaterials. But what is also very important, they're putting a lot of efforts, financial resources and human resources into the field of bioengineering, biosynthetic, biosensor technologies. What is also one of the major mission of the Technopolis era is actually find information about other countries, what other countries are doing in this respect, in this aid field, in this direction. Let me just talk a little bit about the kind of who is coordinating the Technopolis era. I mean, officially it is coordinated by GUNIT. This is the General Directorate for Research and Development and Technological Support of Advanced Technologies. They are cooperating with defense-related enterprises and over 200 scientific organizations, universities, Russian Academy of Science, have agreement with the Technopolis era. Some of those, and many, actually not some, quite over 40, 45 scientific organization and defense related enterprises, they have permanent representation at the Technopolis era. Let me just talk about a little bit about the labs. They have 18 labs there, and they're working actually about, I'm going to talk about the projects in tech, in terms of the field of biotech. They are working in a 3D bioprinting, lab-growing living tissues and bone tissues. They are working on the machine learning technologies in the healthcare for the diagnosing and treatment of illness, telesurgeries, working on the medical robotics and multimedia image communication. In silico clinical trials and drug testing is one of their major direction, using computer models and simulation to develop and assess drugs and devices. What is also very important that they are putting a lot of efforts on a portable biological reconnaissance device. This is they're working a lot of efforts about a biosensor device designed to detect pathogens of dangerous infections, diseases, and viruses. And one of the major direction of the Technopolis era is the biological intelligence. They are developing devices, biosensor devices, and they are also putting a lot of efforts about biological intelligence. Actually, they are concerned about the research activities conducted by foreign research institutions because they kind of feel the needs on appropriate reconnaissance in this respect, according to the statement of various government officials in Russia. The kind of the hallmark, stealing the intellectual properties from that was the signature of the Chinese APD groups. Now we'll see that this will be incorporated by the Russian APD groups, and we see already some signs actually in this respect. So kind of interesting information. It's kind of a breaking news. Just recently, a few days ago, the Russian Ministry of Defense actually made a statement where it's also, very important to underline here is that together with the Gamaleya Scientific Research Institute of Epidemiology and Microbiology, they said that they successfully completed the trial of the COVID-19 vaccine. And by the way, the first minister of the deputy minister of the defense made a statement about this, that vaccine is actually ready and ready for distribution. Interesting information. Let me just talk a little bit about the FSB's role in this respect in the field of the information warfare and its subset of the cyber warfare. There are a lot of scientific and technical centers here and units, but I'm gonna, talk about two major units that are in charge of the cyber operation. So one is the unit of 711-330 and 764-829. They are under 2nd Directorate and 16th Directorate. So those two centers are in charge. These units are in charge of the cyber. They have a very high cyber intelligence capabilities, and they're in charge of offensive information operation outside of Russia. So and inside of Russia. So unit 18th Information Center, also in charge of the SWORM system. Let me just give you kind of a overview about the SWORM system. SWORM is a system of operative investigative measures, the kind of a surveillance system that's now all the ISPs are required legally to install this system. This is a very sophisticated system that captures all the digital and mobile communication. It captures online communication, full recording of conversation, as well as the content of email, text, and the communication. So for online communication, for example, it taps to the network of the internet service providers through a rerouting devices called black boxes and high-speed communication lines. And by the way, it has a real-time monitoring capabilities. So here is a couple of example of what kind of the project they are implementing, on which I'm going to talk on my next slides. They're also actually in charge of the hacker reserve forces. Imagine having reserve forces that you don't pay anything, you don't train, they train themselves, they pay themselves, and they do business for the intelligence services in Russia. And of course, they form a PD-29 group, also hacking group, nation-sponsored group. There is has also different names, Kozituk and Miniduk, etc., etc. Let me just talk about this project that's that's the Siloviki, the people of power, Russian intelligence services are in charge. For example, this the contracting organizations that were outsourced by the security services in Russia were hacked a couple of years ago and last year as well. And all of those projects actually they're revealed on the net. One is a Nautilus project that was about to collect information on social media about users. Another is a Nautilus S that was about the de-anonymizing Tor traffic using rogue Tor servers. By the way, a couple of years ago, I mean, 1 or 2 years ago, 25 those kind of rogue servers was identified, and 18 of which actually were located in Russia. They are also using the so-called scientific institute think tanks for their project. One of the think tank, pretty well-known think tank in Russia is called Quantis FSB think tank, and they are also were in charge of the developing software to detect protest mode among the population. Just a year ago, there was another leak that hackers exposed. That's FSB IoT botnet project called the Fronton, and so leak document actually showed that the procurement order actually was placed by the FSB Unit 64829. And let me just give you kind of a quick overview about the growing complexity of outsourcing and why Russia use very sophisticated outsourcing strategy, because it's confound attribution, and it's also very cost effective for them. And so let me just give you the whole scenario how it works. The idea actually comes from the government, and then the government actually is in charge from the beginning of the whole command and control process. Then the project manager is assigned, and project management does the compartmentalization process. So tasks are broken into pieces, and so then people in the middle, they are also outsourcing hackers from other countries and subcontracting those hackers from Ukraine, from United States, from China, and from other countries. So people here, third parties, they actually don't know from there the original order actually comes. Then my money changes hands, and this is how the whole operation does. So if you want to just find out who is behind this or that project, it's very, very hard to just solve the attribution problem actually in this respect. So what we saw during this pandemic time, the Kremlin information warfare was used with full its capacity. They used the cyber elements, they used the disinformation elements, and they use all the components of the information warfare. So they spread the malicious content, malicious information. They used conventional media outlets. They used their scientists. They used trolls. They used the channels, non-conventional channels, for example, to spread this information. Not only in English and in Russian, but in various languages. And by the way, when I just did research about this, the views and shares of those information, it was into hundreds of thousands and into millions. But it's nothing new. So this kind of spreading false narratives, I mean, it's all tactics that's Russian military and not only Russian military, FSB in general intelligence organizations were using in the past. For example, in the 1950s, the Soviet military intelligence and then created this rogue fake reports that the US used biological weapons in Korea, supposedly dropping bombs filled with insects and rats infected with cholera and plague. As well as, for example, in the late 1980s, Soviet spies spread false narratives that AIDS epidemic started from an experiment at a secret military biological lab in the US. They're also spreading the false narratives about scientific institutes and labs in other countries. Supposedly, they are creating biological weapons or something like this. So in March and April, there was a couple of reports published in this respect, how Russians were using APT groups, cyber criminal syndicates to hack into the research facilities, hospitals, and what kind of strategies, methodologies, and TTPs were they using. Now, just recently was published UK's National Cybersecurity Advisory that they openly said that APT29 group that is associated with the FSB, Russian Federal Security Service, that's this APTs actually are attempting to, APT29 is attempting to steal information on coronavirus research targeting pharmaceutical companies, healthcare, academic research centers. So all aspects actually of information warfare elements was used. As I mentioned, that they use the conventional media, anonymous outlets, the cyber components. They tried to, they created a fake coronavirus tracking webs, fake coronavirus application, ransomware targeting the healthcare system, on which I'm going to talk in detail in my next slides, targeting the VPN system, remote working tools, and softwares. So here is actually a couple of examples, what kind of fake bogus emails they are crafting, mimicking. That's the legit organizations such as the World Health Organization, CDC, and other government agencies, and the government agencies as well. For example, cyber criminals in UK also use the SMS phishing strategy. Here is a screen. They're sending to the UK resident that UK government has issued the payment of over £400 to a resident, and you have to just click to this link. And once you click to this link, it's actually asked you the national registration number as well as other information, banking information. The fake Android application also was created, was removed from the Google Play. So what actually, I'm going to talk about the fake life map that resembles Johns Hopkins University tracking coronavirus infographic map. I'm going to talk about this in more detail in my next slides. So what we also saw during this period, that's over the 1.2 million newly registered domains were created, and over 85,000 domains were classified as risky or malicious. Okay, here is the one of the criminal group called Sadin-Akibi, as well as Ravil. This group has have a very heavy presence on XSS forum. This group launches actually competition for developing exploits for 0 days, writing crypto algorithms, and there are other kind of a task that they post on this website, and they pay money. For example, the one of the competition was about 15,000 dollars. This what is also very important, that they are also someone in February we are already discussing the methods or to deliver malware where an email attachment then later was embedded into the COVID-19 Johns Hopkins infographic map. They also were selling the variants of malwares that later was embedded into the fake map. And for example, if you just opened it, it downloaded malicious code into your system. It collected information from the infected computer and sent this information to the command and control server. By the way, this group is a human-operated ransomware group. What actually does it mean? That's the attack doesn't happen in an automated fashion, but instead they are compromising internet-facing devices in order to establish presence in a vulnerable system and later then execute attack, steal information, and encrypt information on the victims' data. They were exploiting vulnerabilities in remote desktop protocols, vulnerabilities in the operating patch operating system, misconfigured servers, as well as the electronic health record software. What is also important that for their operation, they use the Mimicots. Mimicots is a leading exploitation tools that actually dumps the passwords from memory. This organization, this criminal organization, actually also attacked one of the biotech company that is based in California. And what is also very important here, that they're not only interested in stealing the intellectual properties from the biotech companies in the United States or in European countries, but also they were trying to gain some financial, they were launching cyber attacks for this financial gain, pure financial gains. For example, they attacked the New York law firm, and this is the one of the prominent, very well-known law firm that has a very high level clientele, and asked for ransom. So I already said that Russian deep web forum, dark web forum, hacker forum were very busy during this time period. A lot of discussions were going on those forums, even selling the variants of malwares, discussing the methodologies about how to embed malicious code into the email, and some other, and the COVID-19 issue was very highly discussed, and all of these TTPs and methodologies on those forums. As I mentioned, that's already in one of those forums, we were offering malware for sale that's later was inserted into email attachment, resembling the fake COVID-19 map. So those dark web forum are also there are a lot of other dark and hacker forums actually that's are on the root domains and the subdomains. If you don't know what is a subdomain, it's old Soviet Union domain. It's actually has over 120,000 registered domains there. So yeah, a lot of interesting information could have been one can gather from those forums, and it gives you kind of a good understanding what they are up to, what they are planning, what kind of strategies they are discussing for future attacks. So another also group that was very active during this period was a Hades group. This group is associated with the Russian military. Russian military GRU with APT-28 group, also called the Fancy BSN or Voodoo Bear Talibot, and it has also some other names as well. So they were using the phishing email campaign mimicking World Health Organization and the Ministry of Health of Ukraine. They were sending, here's a example what kind of emails they were sending to the organizations in Ukraine, and not only in Ukraine, where most of this group was active in European countries, in particular heavily active in Ukraine. And once you open this file, it's downloaded malicious macro code to perform the remote control. Another also group that's was very active during this time was a Gamma Radon. This is the FSB group. They also targeted the organization. They targeted scientific research centers, hospitals all over the Western countries. This group is associated with FSB 16th and 18th centers. There's the under 2nd and 16th Directorate of FSB, active since 2013, attacking Ukraine since 2014. Once you actually open the document, it started a template injection techniques for loading the document templates from the internet. And once the document was downloaded, it executed that malicious macro code, which executed VBS scripts. So here is actually IP addresses are from the Russian hosting companies. Those IP addresses that this group is used for network destination or template injection, and network destination for VBS script. So another also organization that was a cyber criminal group that was very active during this time, but that was Russian ransomware group called Maze. This group used a variety of techniques by exploiting known vulnerabilities that haven't been patched, remote desktop connection with a weak password. They used malicious emails with links. They attacked not only the research institutes, scientific centers, but as well as they also attacked for example, IT service providers company that provides this kind of services for the healthcare industries and manufacturing. And in March, they attacked the Hammersmith Medicines Research Center in UK. So this center was before involved with an Ebola solution and working with the COVID-19 vaccine. So what is also very important about this ransomware group, that this group is not kind of typical data encrypting ransomware. So it's not doesn't infect and encrypt computers in every computer that is in its path, but also it is extracting information and data to the attacker's servers. Let me just talk a little bit about the Brewick. This is another Russian hacking group. This hacking group also attacked hospitals and in Europe and the United States. For example, they attacked the second largest hospital in Czech Republic in Brno. Before the pandemic, they actually attacked the hospitals in Alabama, and they asked for the big ransom to decrypt them and unlock medical data. This ransomware is typically the attack, how they actually already get into the compromised system. For example, they used, in this respect, the Emotal and TrickBot. The Emotal is a malware that originally actually was created for the banking Trojan, designed to steal information. And once the system was infected, then their Ryuk payload was dropped into the system and executed, and it's actually a encryption process actually started, and they were asking the ransom for to decrypt the data back. So for attack vectors, they are trying to find vulnerabilities into the system, remote desktop protocol, and poorly secure RDP ports. They use the phishing email, sending a malicious bogus email to trick legit organizations to download these emails open and download documents on from this organization, tricking actually legitimate organizations. And this is actually what I wanted to talk, how actually Russians use their information warfare strategy, its elements of cyber warfare during this pandemic time. Of course, I just would like to talk to you a little bit about the mitigation strategy, and we also talk a lot of countermeasures. Our community, how actually what kind of steps should be taken in order to secure system, to diminish risk, to decrease risk in this respect. Of course, the important factor is that to assess the supply chain. That's supply chain contamination is a big problem in this respect. Unpatched system was exploited by those hackers. Of course, it's very important having them to implement multi-factor authentication methods, as well as train the staff in this respect. But what is also very important here, and in most cases nobody talks about putting the threat intelligence into the mitigation strategy. For example, before the pandemic, all of those Russian forums were discussed, all of those methodologies and selling the malwares on those forums. I think that's observing what's going on a dark web, deep web, Russian hacking forums. It must be included in a mitigation strategy because it gives you a pretty good understanding what we are up to and what we are planning in the future. So thank you very much. I hope you'll find this presentation very interesting, and I'm looking forward to a Q&A section. Thank you.
Okay, so we are live. Thank you so much again, Katrina. That was a fantastic talk. We have a few questions that are coming in right now, a few coming in from Discord. So this individual has a two-part question. First question is, Russia only has one BSL-4 lab, which I believe goes by the name of Vector. Is there any indication that the Technopolis complex will get a BSL-4 lab as well?
Technopolis area actually has 18 labs. I talked during my presentation today. But 3 of those labs are in the biotech field. So I already mentioned that we are implementing a couple of projects. They are implementing 3D lab. They have a 3D lab there. They are working on medical robotics, telesurgery. They are working on nanomedicines and nano-delivery systems. And one of the also important elements of the Technopolis area and their labs in this respect is also developing the reconnaissance devices, for example. Another one also, or their major direction is collecting intelligence about biotech field. So in other words, what does it mean? That's collecting information, what other countries are doing in this respect. By the way, previously, I mean, it was not the hallmark of the Russian APT operation. Stealing the intellectual properties was a hallmark of the Chinese APT groups, but now what we see that's way will be concentrating their attention what other countries are doing in this respect. So biological intelligence is one of the major actually mission of the of the Russian military. So it's also very important that what actually happened with the Technopolis era, that this actually they work in 8 major directions. So one is the cyber and information warfare, and biotech and medical field. Now it's becoming the major component and major mission for the Russian military. By the way, during the talk, I kind of made a statement about that Russian Ministry of Defense with the Gamaleya Research Institute of Epidemiology and Microbiology and other military hospitals are actually and announced that we are working about the COVID-19 vaccine. It's kind of, and the first major statement about this, and they actually made the statement that the vaccine is ready for distribution. So they actually accomplish all of those trial pretty successfully. But the first kind of statement about this was made by the first deputy minister of defense. So this once again indicates that Russian military now are having a heavy hands in in this field, in the medical field, in the field of biotech, and now I mean they are heavily involved into a vaccine against COVID-19.
So you partially mentioned this, but the user had a follow-up question to it, which was so cyber threats are being dematerialized, but biothreats rather are not. For example, they need labs. Could biothreats APTs realistically stay concealed, like APT 28 and APT 29?
So if I understood correctly, that's if you know those APT groups' mission is to kind of um, search information about this. I mean, according to the various report in this respect, and various intelligence organizations report, including the United States and Canada and UK, now actually they are those groups are heavily involved into stealing information about the COVID-19 from research from other companies, research and scientific institutions. I yeah, I mean, we also have to take into account a couple of facts. ABD Group's mission is actually to do computer network operation, to conduct computer, to steal information from various organizations, hacking activities. But inside, for example, the Technopolis area, that's these 12 military scientific units, so-called information warfare troops that they have, those troops partly, I mean, those 12 units, some of those units are in charge of the cyber warfare operation, but most of those units actually, they are on the paper military personnel, but in fact, they are heavily trained by leading academicians, professors, and they are in charge of the scientific activities in the various directions.
So we have a few questions coming in from YouTube. One user has a three-part question, but we'll start with the first one since it's related to APT 28 and 29. Are APT 28 and 29 using their usual methods, and how can the healthcare and research groups prepare to be proactive about keeping proprietary information out of their hands?
So I actually put my last slide was about the mitigation strategy. What kind of a mitigation strategy we have to take into consideration? For example, the one of the component is we have to assess the supply chain. We have to vet third parties, and at the same time, all of those things, patching vulnerabilities. And what is also very, very important thing is that we have to train our personnel. We need a computer hygiene training, as well as I think that's a most important thing. One of the most important thing is to include threat intelligence in the mitigation strategy. I mentioned during my presentation that a couple of methodologies, methodologies were discussed on those hacker forums somewhere in February and beginning of March. So if we just observe what's going on those forums, so we can get some important information, what they are up to, and what kind of strategies they are building, hacking strategies actually they are building for future. So I think that threat intelligence should be, must be actually included into the mitigation strategy.
So the same user had a follow-up question. Maybe we'll start with the second one that they asked. How much are they working with the Chinese and Iranian threat and disinformation groups?
There is also, I actually observed during this pandemic time that Russian information warfare with all of its components, by the disinformation component, deception components, and even the cyber components, kind of was mimicked completely by Chinese and Iranian, I mean, to a lesser extent, Iranian hackers. In case of the, for example, disinformation campaign, that they were spreading the same false narratives that Russia was spreading. Actually, they had the same statements, same false narrative, same fake kind of information. It's something that was, it looked like that it was a kind of a coordinated efforts in this respect. So I don't know whether we were coordinating or not, but I mean, the similarity was very, very, it was so close and so, it looked like that it was a coordinated effort. So I can't say complete, I mean, for sure, but it looked like it was mimicked to a full extent.
So we have a user from Twitch that is asking, from a psychiatric profile perspective, I heard you say patriotism and financial self-interest are some of the drivers used to motivate the APT groups. To what extent is fear or punishment used to keep staff in line?
So if I understood you correctly, that's so the mission of you have to just understood how actually Russia works. For example, the APT groups, I actually mentioned during my presentation that they are using the Hacker Reserve Forces. So Hacker Reserve Forces work is a kind of a part of the APT group. They actually form together with this research institutes and centers for special studies and units that's inside them, for example, inside the GRU or FSB Rs. But at the same time, for example, they conduct they work for the government for special missions, and they also do their activities for the financial gain. For instance, and they have a clout from the government. You do work for me, and you can do your criminal activities as long, I mean, but you shouldn't attack the government agencies or the proper, in the people who are close, and organizations who are close with the government. And as you know, that Russia doesn't have an extradition treaty, and when law enforcement agencies of other countries want some kind of cooperation in this respect, so we're not getting a cooperation from Russian law enforcement agents. For example, the author of the Zeus virus, Bogachev, is wanted by FBI for many years, but now he lives in Anapa, has very luxurious lifestyle in this resort area. So their mission is they're working for example, implementing the government mission. At the same time, also they are performing their criminal activities for financial gains. So, I mean, this Hacker Reserve Forces is a kind of the very interesting approach. I mean, imagine you have a reserve forces, you don't pay them, you don't train them, and so it's very cost effective. Yes, at the same time, it also confound attribution. So it's kind of it's a very kind of effective strategy that they are using in terms of the attribution and in terms of the money as well.
Okay, we have two more questions. So a user from Discord made a comment and a question. So China steals IP often through scientific collaborations. The user is only aware of one major instance where Russia attempted to establish a large research collaboration. Is this something that Technopolis ERA is doing in the bioscience areas?
So the Technopolis and the first part of your question is that this is kind of a new thing. That Technopolis area actually was launched in 2018. So Russia Russia was not very much involved into the stealing the intellectual property. Mostly, I mean, their mission was some political disruption, stealing information from government organization, and use those information, weaponize those information for the political purpose, as we've seen, previously here in the United States and other countries in the European countries, including in my country where I'm from. So, but now actually the approach kind of changed, and now since they founded this Technopolis era, so now their mission is diverse. So now they are heavily interested in a medical research, in a biotech field, and so now we can see in the future that their approach might change, their strategy might change, for example, in terms of the selling intellectual property, especially from this particular field. And not only, for example, find information what other countries are doing in terms of artificial intelligence or in terms of quantum computing. So all of those elements became now very, very important, and now military has the upper hand. By the way, I always get a question when I speak in the various forums, which are the major player, so FSB or GRU. I must say this probably GRU, taking into consideration the GRU's role now and opening Technopolis era. Of course, FSB also has its share, but more in terms of the research and science. And now the Russian military absolutely has the leading position in this respect. So, you asked about the cooperation with the China. So you have to take the a couple of facts into account. That's now Russia and China are improving their relationship in terms of trade, in terms of military exercise, in terms of the energy field, and in many other directions. So, by the way, a couple of years ago they had the first ever military training, by the way, and even the and then after the training, there was a big economic forum, and Xi himself actually attended this forum. They signed a couple of agreements, and in various fields. So relationship between China and Russia is getting better. But I mean, we have to take into consideration the fact that those two countries are revisionist power. So as long as they are fighting the status quo power, they need each other. Also, another factor that I also wanted to mention, for example, probably most of you heard about the so-called Belt Road Initiative. This is actually the restoring the old Silk Road strategy, and China needs Russia's cooperation in this respect, because Russia is one of the major players in the Eurasian continent. So to boost the trade and influence in this respect, so they actually need each other. So yeah, there are a lot of things are going on in terms of the China-Russia cooperation. I think that should be taken into account, and we have to kind of pay attention to the cooperations and kind of the agreements they have in the various directions.
Okay, well, thank you so much. We are out of time, unfortunately, but that was a fantastic talk. A lot of great positive feedback on the forum. So, really, thank you so much for joining us for this.
Thank you.
Our next talk will be in about 3 minutes, so we'll see everyone then.
so much to the organizers for having me here today, live from home, to talk to you today about some of my work with the All of Us research program. My name is Michelle Holko. I'm currently a Presidential Innovation Fellow detailed to the NIH to work with the program, specifically with digital health technologies. I'm going to talk to you about one of the projects I've been working on there since about December last year. So I'm going to give you first an introduction to the All of Us research program. I'm going to run pretty fast through those slides so that we can get to the digital health technologies portfolio, but more broadly in the program. And then I'm going to spend the most time talking about the Fitbit bring your own device data analysis and participant demographics, which is the area that I'm going to be talking about most today. And then we'll close with some opportunity and considerations for digital health technologies in the All of Us research program. So just again, to give you a kind of an introduction to the program in case you're not familiar with it, the All of Us research program grew out of the Precision Medicine Initiative, which was founded several years ago in the previous administration and has $1.5 billion of congressional dollars to get the program started and to continue running. And the mission really for the program is to accelerate health research and medical breakthroughs to promote individualized prevention, treatment, and care for all of us. There are three core values to the program that are really important to us. The first is to nurture relationships with 1 million or more participant partners from all walks of life for decades. And again, diversity is really critical to the program in that. To deliver the largest, richest biomedical data set ever, as well as making it easy to use to a wide range of researchers. And to catalyze a robust ecosystem of researchers. So the All of Us research program truly is an innovative and ambitious research effort. And here are some reasons why. Really, the diversity at the scale of 1 million people or more, and focusing on capturing the diversity that makes America America. Focusing on participants as partners, so not just taking data from them, but also giving back to them and continuing to engage with them throughout the length of the program. The longitudinal design of the program means that we have the ability to recontact participants, which we've already done in some cases around COVID, and multiple data types. So a diversity in participants, but also diversity in data, including electronic health records data, survey data, baseline physical measurements, biospecimens, genomics, and digital health technologies, which is what I'm going to be talking about today. Creating a national open resource for all, which is broadly accessible to all researchers with open source software and tools, and building in security and privacy safeguards for all participants. So some current progress: we opened the doors nationally on May 6, 2018. So far, we've enrolled over 271,000 participants that have not only completed the first initial enrollment step, but have also completed what we call the full protocol. And this represents individuals from all 50 states. Furthermore, greater than 80% of these participants represent one or more of the underrepresented in biomedical research categories, which includes racial and ethnic minorities, living in a rural region, and there are many more. I'm going to go through those in more detail a little bit later. And greater than 50% of the participants are racial and ethnic minorities. We built a significant infrastructure to support the program with over 100+ academic groups working with us, the VA, the FQHCs, which are the federally qualifying healthcare centers, technology and community partners. We have over 320 clinics enrolling participants, and that number is still expanding. We also have a bilingual website, so the website's available in English and in Spanish, as well as the participant portal, app, and call center. The biobank at the Mayo Clinic supports 24-hour shipping and processing with capacity for 335 million+ vials. And we also have an interactive mobile exhibit that travels the country. The picture's on the bottom right of the screen. Certainly not traveling during right now, but usually it is, and it's actually wonderful because it can reach more rural areas where we don't have partners. So here's just a snapshot of enrollment to date. So you can see enrollment over time in the graph on the right, and then the bubbles kind of tell you where we are right now. So like I said, we have 271,000 that have completed the initial steps of the program, which includes consenting, agreeing to share your EHR data, completing the first 3 surveys, providing physical measurements, and donating at least 1 biospecimen. We have many more than that, 353,000 who have completed some part of the program, but they haven't completed all of those kind of initial steps. This is what the current protocol looks like. The first step is to enroll. to provide your informed consent and to authorize your EHR. It's really important that we, ask for the authorization of EHR upfront at this initial step. Right now, we're only recruiting adults who are 18 years and older. We do have plans to expand to children, but right now we're only recruiting 18 years and older. It's also important to note that at this initial enrollment, we have in-person enrollment and we have digital enrollment capabilities. Of course, right now, the in-person enrollments have all been paused. So in that interim, we've still been able to accept participants joining the program, but only through the digital method. Then you can answer surveys. There are many different surveys that are already available, including the basics, overall health, lifestyle, healthcare access and utilization, family medical history, personal health history. And we also released a survey around the coronavirus pandemic called the COPE survey, which focuses not only on signs and symptoms and exposure to coronavirus, but also, the social and economic aspects of that. The next step, the next two steps actually kind of usually go hand in hand. And so usually if you're coming to us through one of our healthcare provider organizations, you'll provide physical measurements, which are all listed here: blood pressure, heart rate, height, weight, BMI, hip circumference, and waist circumference. At the same time, you'll provide a biosample. Usually blood, that's the biosample of choice. However, if the blood draw is unsuccessful, or if you're coming to us as a direct volunteer digitally, we can send you a kit to give a saliva sample. Very few participants give urine specimens. We are collecting some of those. And then finally, digital health technologies, which is what I'm going to be talking about today. We have a bring your own device program already set up with Fitbit and Apple Health Kit connections. We're also developing integrated apps to track mood and cardiorespiratory fitness, among other things to come. So now shifting from the participant to the researcher, and how are we going to make these data available widely to the research community in a usable way? That sounds very easy, but it's not. So on the left is kind of the traditional model where a researcher would come to the program, apply for the data, and then they would be basically shipped out. It would be basically shipped out to them. But with this model, it certainly discourages sharing of research. It also is a very weak link in terms of security. You have no control over those data once they leave your facility. You also need a high infrastructure to be able to support that, to pay for multiple copies and all of that. So what we've decided to do is to create a cloud-centric approach where we bring researchers to the data. So all of the data are hosted in the cloud, the tools are being built in the cloud, and then researchers are able to get access to it. And in this way, it facilitates collaboration. There are centralized security controls. We can make it accessible to all researchers. And we can even think of ways of making different types of data accessible to different types of researchers depending on the need. So with this cloud-centric model, you can also think of providing the data in tiers. We certainly have a public level of data sharing that's happening. Publicly accessible, no login is needed, shared on the website. I showed you the blurbs of the enrollment over time. That's one of the snapshots. We've also created a registered tier, which requires identity verification, signing a data use agreement, and completing research ethics training. There's also the idea of potentially developing a controlled tier of data, which would give people even more access to the data. So at each step, where the security goes higher, and we are instituting more and more controls because you're getting more and more access to data. So with the registered tier, there are some specific privacy controls that are in place there that would not be in place in the controlled tier. So we would need an additional trust with the users of that data. So here's the Researcher Hub website. You can go to researchallofus.org. I encourage everybody to do that. From there, you can see the data snapshots, the data browser, and the survey explorer. The data browser that's available publicly does not let you drill down to individual level data. To do that, you have to move into what's on the right here, the Researcher Workbench. So this is just how the Researcher Hub components fit together. On the left, you have the data browser, data snapshot, survey explorer. And then in the middle is this kind of data passport model, which is how we are making the data available to researchers. We don't require you to ask or tell us what specific project you're going to be working on. We just verify your identity and kind of build a level of trust with you as a researcher, and then give you access to the data. In the researcher workbench, it includes a data dictionary, concept sets, cohort builder, notebooks, and help desk. And the one exciting piece of news to share is that the All of Us Research Program Researcher Workbench is open for beta testing. So it's a very important moment for us. We want to build this platform together with the research community, but we absolutely need the input of researchers to make it more robust, to learn how well the data, tools, and policies are working. So the current components in terms of data include physical measurements, survey data, some EHR data. Much more is to come here, including genomics and digital health technologies data. The tools that are included include a data set builder, a cohort builder, Jupyter notebooks with R and Python supported, and the help resources are wide and varied, including FAQs, sample notebooks and workspaces, including code snippets, documentation, and help desk. So access and security, just a moment here. Again, All of Us employs a data passport model for access to this researcher tier to grant researchers broad permission to explore the data for a wide range of studies. Beta testing is available to researchers who have an ERA Commons account. This is what we're using for identity verification. So you have to have an ERA Commons account. Most researchers do, and if not, you can look into the process for creating that. And then you also have to have a signed data use agreement with your institution. So the institution that houses the Data Resource Center signs an institution with your institution, and then we verify your identity through the ERA Commons account, and then that's how you're able to get access. So again, to facilitate collaboration, the researcher workbench is hosted in a cloud-based system. Data downloads onto your local machine are not at all allowed. And during the beta testing phase, another really nice perk is that researchers will receive free credits to cover computing and storage costs. So here's just a peek look at what the workspace looks like when you come to the researcher workbench. First, you create a workspace, and this is where everything kind of will be all collected. And then you can create cohorts, concept sets, cohort reviews, and notebooks to run your analyses. This is just a look at what the tools look like in terms of the cohorts, data sets, and concept sets. And then just one more summary about what is included in support. And I have to say the support features are really extensive. So anyone who is not a coder coming to this should be able to even get up and running. So there's a user support hub, researcher workbench, featured workspaces, reusable code snippets, demonstration projects, and then a help desk form that can give you kind of one-on-one help. So just to summarize this section, we are providing a robust data ecosystem with survey data, physical measurements, structured EHR data, with plans to add additional surveys, digital health technologies data, unstructured EHR data, linkages to other data sets, additional assays and biospecimens, and genomics. So moving on to the topic of the day, digital health technologies in the All of Us research program. So what is the vision really for digital health technologies? Well, digital health technologies data from things like fitness trackers, smartwatches, apps, other types of devices can capture health relevant data from individuals outside the hospital or clinic, which can really supplement current medical information. Another feature, especially for fitness trackers and smartwatches, is that the data are longitudinal in nature, and it can really give researchers an unprecedented ability to better understand the impact of lifestyle, environment, and other factors on health outcomes, and eventually and ultimately develop strategies for keeping people healthy in a very precise and individualized way. The program is currently collecting data from participants in a bring your own device model. So we are not distributing devices to participants, although that is something that we are planning for. And we currently have connections to Fitbit and Apple Health Kit. So again, just bring your own device. We are also considering developing pilots of smartphone-based apps in the future. So what is the vision or impact specifically for the Fitbit bring your own device data in the researcher workbench? So I believe that All of Us really truly has a unique opportunity to release one of the largest and most diverse digital health technologies data sets. We currently have data from over 9,000 participants, some beginning in 2009. In addition to current survey, EHR, and physical measurements, future data releases will also include genomics and other data sets. So when you think about the power of combining all of these different data types together, it's truly amazing. And then this can promote research to develop new and improved disease prevention capabilities, remote patient monitoring for connected care, and other opportunities for high-cost diseases. So the approach that we are using for the Fitbit data in the All of Us research program is this minimum viable product, or MVP approach. So first step of this is to obtain the data, and we have all of the data currently through May 2020 that's going to all be curated and released in the next data release. We've also developed scientific research use cases around the Fitbit data just to make sure that the way that we're curating the data is going to make it useful to the research community. We are now assessing the data set for the longitudinal nature, missingness, and trends, or basically doing exploratory data analysis. And then based on 2 and 3, based on the scientific research use cases and the EDA of the data, defining the priority data elements for inclusion in the researcher workbench. And again, the timeline for that is to release it in the next data release, which is slated for late fall 2020, currently anyway. And then to develop and implement a Fitbit curation schema coordinated with the security, privacy team, and other approvals as needed. So this is what currently what the Fitbit MVP looks like. You can see the data elements table over on the right. The data elements that we are currently pulling from Fitbit include heart rate, minute level heart rate summary data, intraday steps, which is also the minute level, daily activity summary, sleep, daily weight, daily fat, food, and water. And it's important to note that daily weight, daily fat, food, and water are all user supplied elements. So just by nature of that, there is much less of those data. The others are derived from parameters that are derived from the device. So what we've decided to do is to provide a series of data tables using BigQuery of parsed data tables including heart rate, summary by zone, heart rate, minute level, activity, daily summary, and activity intraday steps, minute level. So to dig into the data a little bit more, as well as some of the participant demographics, which are important for a number of reasons I'll go into. So these are characteristics of the current Fitbit data set in terms of the data elements. So we have 9,255 Fitbit bring your own device participants. And again, this is until May 2020 timeframe. 8,535 of these have primary and electronic health record consent, with activity measures as early as 2012 and heart rate as early as 2015. So that is quite a lot of data if you think about it. The data elements that we are pulling from the Fitbit API are shown on the right with the device-derived parameters in green, daily activity, intraday activity, heart rate, and sleep. And the user supplied are in blue, daily fat, daily weight, food, and water. So when you look at the data corpus as a whole, and you look just by data element to see which elements have the most data in them, intraday steps and activity summary are the data elements with the most data. Heart rate and sleep summary have about 40% less, and the user supplied daily weight, daily fat, food, and water intake have greater than 90% less data than the intraday steps. So in terms of what is going to be most relevant or useful, for giving to the research community, definitely in my mind, the intraday steps, activity summary, as well as heart rate. So then we wanted to try to assess the completeness of each participant's data. So percent completeness was assessed within each of the 8,535 participants. And the way that we did this was to do a theoretical maximum kind of comparison, where if you have, that's based on the start and end time of donation. So if you have a user that comes to you and they started donating data and then they ended donating data and it was about 100 days, then your theoretical maximum number of data elements for the daily elements would be 100. For the minute level, it would be 100 times the number of minutes in a day, which is 1,440. So then by comparing the number of data elements that you have for each of those data types within a person by the theoretical maximum, you can get this percent completeness. And we're looking at two thresholds, greater than 60% complete and greater than 80% complete. So because intraday steps, daily activity, and heart rate are all, they're all device-derived data types, you would assume that they're all relatively similar, right? Because if the person is wearing the device versus not, you wouldn't get steps and not heart rate, right? Unless the device just didn't have that capability. So it's actually kind of a good control to see that these numbers are very similar. So For intraday step daily activity and heart rate, we have about 77 to 79% of the participants that are donating data have more than 60% of the data compared to the theoretical maximum amount, which is pretty good. This is a pretty complete set, which is what that means. When you look at 80%, it's slightly lower, but it's still very good. Around 62 to 65% of the participants have more than 80% of the maximum possible data available. So an interesting thing to note, though, is that when we looked at how complete a participant who is only donating data for 1 year or less versus a participant that's donating several years of data, we noticed that participants with data available for only 1 year or less had the lowest percentage of completeness, and completeness of participant data increased as duration of Fitbit BYOD data donation increases. So this just goes to show that I think something that we've all noticed, that if you've had a device for more than 1 year, if you wear it regularly, it kind of becomes integrated into your life, and so the chance of having a more complete data set goes up. So before I move into the next section where I talk a little bit about the demographics of the participants in the Fitbit BYOD Fitbit BYOD program versus all of us participants, I want to first just give you a summary of how we think about diversity in the All of Us research program. Diversity is critical to doing precision medicine research, because when you think about, if we want to be able to deliver healthcare that's specifically for, a specific type of person, we need to have research on all of those various types of people to be able to find those differences. So this is how we think about these groups that we call underrepresented in biomedical research and their definitions. So race and ethnicity, participants are identified as Hispanic, Latino, Spanish race, or race identified other than white. Age, participant is under 18. Again, we're not doing that in this program yet. So over 65 is really what we focus on. Sexual and gender minorities, participant sex reported is different from that assigned at birth, or orientation, sexual orientation is something other than straight. The income, the participant lives below the federal poverty level, which is less than $25,000 a year. Education, the participant has less than a high school degree. Geography, you live in a rural zip code. And then access to care, you can't readily access the healthcare system or can't pay for care. And then disability, some type of physical and or mental disability. So just first to start, I wanted to show you that the breakdown of age group in the Fitbit BYOD participants versus all of us core participants. So the Fitbit BYOD are in the dark bars, and all of us are in the lighter bars. So what you can see here is that the distribution of age is fairly similar. You do lose a little bit of the 75 to 85, and this does fall into that EBR category. You do gain a little bit in the mid-20s to mid-30s, but overall, this is pretty comparable. So in the next chart, I tried to highlight some of where we're seeing some of the gaps, and we're not able to capture UBRs in the same percentages with Fitbit participants versus all of us participants. So, you can see that the vast majority of Fitbit participants, over 78%, are white. Whereas with all of us, we only have about 48% are white. And then you have 20% Black or African American, 16% Hispanic or Latino, whereas in Fitbit, all of us, or Fitbit BYOD, you only have 4 to 5% of those two UBR categories. Another feature of the Fitbit participants is that over 36% have an advanced degree. In all of us, only 18% have an advanced degree. In terms of high school only, we've got about 21% in all of us who have high school only degrees. And in Fitbit participants, it's only 6%. In terms of living below the poverty line, not surprisingly, we only have 8% of people donating data from that group, whereas all of us participants, we have 31%. So that, it's just really, I wanted to really drive this point home that even though we're trying so hard, this program is so focused on diversity, we're trying really hard to capture the diversity, we can't do it in this kind of bring your own device model, because this is probably reflecting people that have the devices, right? So we're gonna have to be a little bit creative in order to try to capture the data from other groups. So just to summarize, there are specific diversity gaps in the Fitbit BYOD participants when compared with all of us core participants. And skipping down to the bottom in the two bulleted points that are in bold, that there's a definite bias towards white versus other race categories, and that Fitbit participants are skewed to higher education and income levels. So why is diversity important? Just one more piece of evidence. This is a very popular paper in Nature from 2016, which surveyed the data that have been used to do GWAS, or genome-wide association studies, from 2009 to 2016. And what it shows is that in 2009, 96% of GWAS studies were done using data from, or using samples from people with European ancestry. That is a tremendous bias, right? I mean, this is something to be really, really careful about. Since then, since this paper was published in 2016, it went down to 81%, and it looks like, you know, in particular, people with Asian ancestry are becoming more represented, but we're doing a terrible job at getting diversity in this data set. And my worry, my concern is that if we're not careful in how we do research, you know, using these digital health technologies data, we're going to be in the same situation. And that's certainly not something that we want, because these types of gaps are what lead to disparities in healthcare. So what is the opportunity and some considerations for DHT in the All of Us Research Program? So the All of Us Research Program truly has a unique opportunity to address some of the current challenges in DHT research due to the following core values of the program. First, the size and diversity of the cohort. Again, we're trying to get to 1 million. We've currently got more than 350,000. And the focus on diversity means that we really do have a need to focus on diversity, not just at the level of the participants, but also at the level of the data type. It's also important to the program to capture data from those UBR groups, and the goal to develop an open access, rich and complete biomedical data set that's not biased, and make it available to the research community. So that's really key. So because diversity is of participants and of data is of critical importance to the All of Us Research Program, this information you know, that we've learned from the Fitbit BYOD analysis will be used to plan future digital health technologies efforts, potentially piloting, giving out devices to people, to try to mitigate gaps in the traditionally underrepresented and biomedical research participants. So how can, really the question that I want to get to and that I want you know, people to think about and to hopefully spark some discussion is, how can the All of Us program leverage DHT to provide unique opportunities for our participants and for the research community? So just some other key considerations for All of Us and digital health technologies. Again, diversity is key. I can't say it enough. Even in the All of Us Research Program, where there's a huge focus on diversity, it's a challenge to get that diversity in the digital health technologies data. But it's critical and key for eliminating bias from results. You know, the All of Us Research Program, because we have the opportunity to release one of the richest data sets and largest data sets with the Fitbit release, it's an opportunity to democratize access to this data type. You know, there are a lot of research studies that have just a very few number of participants, or for the larger studies with lots more data, they're mostly in the private sector. So how can we, you know, in this safely enable a larger number of researchers to get familiar with these data types and start to do innovative things with them? The other thing is that, you know, in a lot of cases, these are novel data types. So a lot of what has been built for privacy and security is unknown until proven, right? And so certainly data egress is something that the program guards against and is critical. And then with privacy, re-identification of participants is also another consideration that we need to make sure that, that we are protecting for. So I'm just going to show you slides to let you know that it really does take all of us. These are all of the All of Us consortium members. Beyond the community partners, you may or may not be able to read all of these organizations. It's truly massive. These are the community partner and provider networks. And here's a picture of all of us in there somewhere. And it really is truly a monumental effort. So please feel free to find out more information, shoot me a note, ask a question, discuss, and thank you so much for your time.
There we go. All right, so we are live. Unfortunately, we don't have very much time, so we'll be able to take one question, and then afterwards, Michelle will be in the DEF CON Discord, so if you go to the link that you see down below, you'll be able to ask your question there. But the one question that I will ask before we have to unfortunately end, so a user in Twitch asked, is the data localized to US servers / storage, and can foreign researchers use the data?
So the data is localized to US servers and storage. Yes, foreign researchers can get access if they are in the United States and their institution has signed the institutional agreement and they have an ERA Commons account. So yes.
Okay, well, with that, thank you so much.
Excellent.
If people do want to reach out to you, your Twitter is at the bottom of
Absolutely.
the feed, so please, by all means, go ahead and ask there. But once again, thank you so much. That was a fantastic talk. Our next talk is about to start right now, so hold on tight, everyone.
My name is Chloe Mastagi, and I'm happy to be on the disclosure panel with you for this wonderful Biohacking Village. And so before I get started, I just want to let you know who I am so you have a better idea of basically what the content I'm going to share with you. So I am the VP of Strategy over at Point3 Security, and when I'm not that, I'm an ethical hacker advocate. And if you're wondering what is an ethical hacker advocate, basically I'm trying to fight for rights for hackers and also to change the imagery and the wording that the press tends to use about us in a very negative light. But when I'm not doing that, I also am trying to push for diversity and inclusion within the community. I am the president and co-founder of WOSEC, and when I'm not that, I'm also the founder of We Are Hackers, which used to be formerly called as Women Hackers, but We Are Hackers is a private online community of hackers who are underrepresented genders. And yes, we hack at all different levels, have workshops and all that fun stuff. And yes, I am a parent. If everyone wants a parent, it's basically a parent of any dogs, cats, and hamsters, I guess, and bunnies, or any of those kind of things. Anyway, Shirley and Luna, which are both some sheeps. And also I am the Hacker Book Club organizer. And what we do is one of those things where we read a new book every month written by someone in the hacker community or is written about the hacker community. And the author and the people that are mentioned in the book do attend our weekly meetups on Tuesday at 5 p.m. Pacific time. Anyway, enough about me. If you want to follow me, feel free to. I'm on Twitter and Instagram. Let's go into the good stuff though. So usually when we see the word hacker or when we type in hacker in Google or whatnot, we get like these type of images, this dark hooded figure, but also we see these ones that have hole cut out and, you know, anyway, let's just be honest with each other. This is really annoying at this point because what's happening is that people are seeing us in this way. Something that looks like a criminal. And it's not just that, but even if you type in ethical hacker or criminal hacker, if you see on both sides of this, you get the exact same imagery. So, which is even more annoying because it looks like we're still having this situation ongoing. And it's not the imagery either, it's also the words being used. The media, which is press and marketing organizations, keep using the term hacker in a negative way when they should be saying malicious actors or cyber criminals. But if you're wondering, how does this imagery impact us? I'm glad that you're asking because I'm one of those people that's obsessed with brains. So we're going to talk about them. All right, so first things first that you should know about when it comes to your brain is we're going to have to dive into the amygdala, which is an almond-shaped part of your brain within the temporal lobe. Now, the thing to know about the amygdala, it sorts who's like us, who's not like us. And because of that, it's the fear versus flight mechanism. So if the person somehow has a connection like us or looks like us, we're like, this is a friend, versus if the person doesn't look like us or we have no association, never had any conversation with someone that is that type of person, we see them as an enemy. And because of that, that is how we have these things called socially constructed beliefs. One, in the media, when they share hackers and imagery of this hooded figure or using the term hacker, what is happening? It's socially constructed beliefs are now being implanted in other people's minds that hackers are criminals and that all of us are criminals. We're bad people. And because of that, it has created this fear in the public. Now, to know about is that when the amygdala sees, for example, let's put it this way. You know when we always tell someone that we're a hacker or work in the hacker community, and usually the person takes a step back and kind of goes, or they're like, the mouth drops, or their eyes get a little big. They're like, they're nervous, but they don't want to come off that they are, but they totally are, and you know it. And you're like, dang it, I should have gone with the security researcher term, but you didn't. It's okay. Anyway, what happens is at that point, what's happening is that person knows that now you're a hacker. And they've seen the images, they've heard the words in the press and whatnot of hacker. And when they see you and you tell them you're a hacker, they're taking the step back because they're trying to figure out something, if you are a friend or a foe. Now, the thing to note about the amygdala is that even though it sends that signal, it's completely subconscious. So you don't even know that you have a fear of it. The only time when you know that it's a fear is if it comes in the prefrontal cortex of your brain, which is right here. Anyway, so what it does is that it sends a message there saying, warning, warning, there's a hacker near you. Be careful, it's a criminal. They do bad, terrible things. Now, the thing is that that person now has a choice to react or to ignore it. Now, the only way that you can question socially constructed beliefs and biases is through stories and from meeting people within that community. The thing is, when we're inside our bubble, we're protected from these things. We have our own beliefs, and it's constantly being verified that you are correct always. When we go outside our bubble, that's when we realize you don't know everything. And to be comfortable with the uncomfortable is always a hard thing. So, what the main takeaway, if you're wondering, Chloe, why are we still talking about the brain and the amygdala? The thing you need to understand is that it's not permanent. These socially constructed ideas are never permanent. You have a choice to learn about another perspective, but they have to hear the other perspective. And right now in the press, we're not seeing that yet. And because of that, we're still being seen as criminals. So, and because of this fear and the public perception, we still have a situation where 93% of the Forbes Global 2000 don't have a vulnerability disclosure program. And 60% of hackers do not report vulnerabilities out of fear of being prosecuted. And laws that are preventing like good hacking are such as the CFA and DMCA. And because of this stigma associated with being a hacker and how the public sees us, it also increases the chances of having more malicious attackers, not hackers, attackers. But I try to catch you there in that slide and see if you caught it or not. But overall, what we need to know about is that there are legislation out there that is hurting us still to this day. And what we need right now are some amendments. So, for example, the anti-hacking laws, the Computer Fraud Abuse Act, it was actually created in 1984 because Ronald Reagan watched this movie called War Games and panicked. As you can tell, many of the rules and laws that have been created are usually stem from panic and fear-based and not through empathy. They never really had a conversation with the hacker community to say, hey, is this right or wrong what we're doing here? And the thing is that we need to push more than ever some amendments for this. Yes, we do believe that, malicious actors should have to deal with prosecution. But if we are going, within scope, then we shouldn't be having to worry about being prosecuted. If we go out of scope by accident, we shouldn't have to worry about being prosecuted. However, if we go out of scope and we exploit, okay, yes, we did something bad with a malicious intent. And anti-circumvention laws are the copyright acts. And basically seeing reverse engineering is seen as a breach. Not a breach, but it's just wrong. It's not legal. So these are things to consider and remember of. And of course, we have an acceptable use policy, which is every time that you are on your iPhone or any of those things, it's like, please check this terms and conditions. I know some of us try to read it, but it's really hard to understand because we're not attorneys. So it makes it even harder for us to understand what we're reading. And also, many of us, English is not our first language. And so that's the other issue, is that there's all these things that are set up for hackers ourselves to fall into a situation of being prosecuted, and it's scary. But if you want to start changing things, there is one step that you can do right now, which is if you go to change.org, there is this petition that was created, which basically tries to get all of us to sign it so then we can bring it and push for changes to happen. We need organizations to start trusting us and have bilateral trust that they will not prosecute us if we report a vulnerability and we don't exploit it. We're also asking for politicians to update the laws that we have. Creating amendments is one of those, because it's the laws that they've created are preventing good hacking. And also for the media to let them know that, please, if you're reporting about the hacker community, please keep us in a good light. But if it is someone who did something malicious, don't call them a hacker. Call them a malicious actor or a cyber criminal. And that's one of those important things. But us as a community, we have to try to do our best to stay within scope and not exploit, because when one of us breaks that, it takes us 10 steps backwards. And I'm looking forward to the other panelists sharing more about what on their side and what they're seeing when it comes to disclosure.
So let's start out by kind of getting a little bit more into the weeds here. My focus in this area is going to be more on hospitals and the vulnerabilities involved with hospitals. To start off with, here's a little bit about me. I don't really want to spend too much time on this particular page, other than to say I've got a lot of experience across a lot of different hospitals that gives me a unique perspective to see some interesting patterns. And unfortunately, I'm here to scare the crap out of you a little bit about how insecure hospitals really are. And then hopefully I'll be able to motivate you guys to do something about that. Let's first talk about the most important thing here, and that's inventory. When I'm dealing with hospitals, particularly the ones that come into my environment where we start supporting them for the first time, they never have an inventory. If we're lucky, they've got a spreadsheet, similar to one that St. Ellis here has. If you get a chance, please participate in the CTF. That's actually the inventory list for the CTF that we used just recently. And it's pretty accurate. It covers pretty much the same thing that I see at hospitals. Now, there are some tools that kind of help us figure out inventories. Landsweeper is my favorite, but there's also Case, SECM, Configuration Manager, and then you can get real manual with Nmap, Masscan. Those will kind of get you about 80% of the inventory, but it's still going to be mostly accurate. And the reasons for some of that is because there are things that are getting added and removed to the environment all the time, and the spreadsheets never get updated. And there's always the fun one where there's a grant that comes along and the vendor comes in and installs the devices in the environment and doesn't tell IT or IS, and all of a sudden IT and IS have to support these tools, and it's kind of a mess. So starting out from the very basics, inventories is one of those vulnerabilities that we kind of have to deal with and start figuring out how to get a better inventory for hospitals. The next one we're going to move into is actually discovering vulnerabilities. Now, I like to start out with an external scan to figure out all of the stuff that a hospital has put out on the internet that they use to communicate over the internet. Generally speaking, when those first hospitals come into our support area, they are very, very vulnerable, and we have to start narrowing that down. You can see the little spreadsheet to the left there. That's about a year ago, and I'm proud to say that most of those in the critical areas have at least moved off. But like I said, when a new hospital comes in, they're very, very vulnerable. Nobody knows what they've got out on the internet. It's always a fun little situation. And There are a lot of tools that can be used to do this. I use Tenable.io. In the reference page, you'll get to see a whole bunch of different other ones. But I also like to bring out Shodan.io and Census.io. Shodan is a website that you can go to, shodan.io, and you can search for medical devices on it and see how many are actually published on the internet that you have access to. In the particular case here, I put PACS in there, and there's about 700 plus medical devices published on the internet that you have access to, that you can see about. And if you click on the IP of that particular device, you'll be able to see the CVEs and all the things that are vulnerable for that device. Kind of a scary little thing. Now, as bad as the external scan of all the IPs on the internet, the internals are always much, much worse, because hospitals usually design systems where they have this nice hard firewall that is supposed to protect them from all the different types of things. And then once you get inside, it's not much security whatsoever. So it's like that nice little M&M hard candy shell, soft inside. Nice and scary stuff. So how does this kind of come about? Well, I kind of blame it a lot of it on availability. And then we're talking about the CIA availability, confidentiality, integrity, and then availability. Availability is king when it comes to hospitals. If you've ever seen a physician get upset about not being able to access what they need right then and there, it's quite a terrifying experience. They usually take it out on everybody, and rightfully so, because we're talking about life and death here. So that tends to be one of the challenges that we have to deal with. For Patch Tuesday that comes out, everything getting patched, how do you reboot something when it has to be up for that surgery that's going to take place at 6 o'clock in the morning the next day? We could also talk about maybe N+1 and having server farms, but hospitals are kind of cheap, and that leads to my next one, where fast and cheap is far, far more important than good, or having it built accurate or done with quality. So the fast and cheap is always going to win. Nobody really cares how good it is or the quality of it is. They just want it set up and running, and they don't worry about anything else. Now, of course, that leads to all kinds of fun little problems, because Microsoft is a wonderful company that gets everything to work fairly well. That's kind of one of their goals. Everything's got to work, but they turn on all the services by default. And when you're pushing something out fast and cheap, you push it out with the default settings. So here we are set up with all these services that we don't need that are running, and they're now vulnerable because they haven't been patched in, at least 6 months or so. The next one is kind of a more challenging one, and probably the most important one. Both IT and IS, really, we kind of suck at talking to humans. We're great at talking about technology and working with computers and communicating along those routes. And the medical staff, they don't talk tech at all. They talk human. They're worried about emotions, and they're worried about being able to understand people's needs and wants and desires, and they don't care about the technology. That's just the thing that's there that kind of gets in their way, and hopefully will help them out just a little bit. And then the last one I want to talk about is there's really no accountability. There's also no incentive to do better or to fix all these types of things. So it kind of to Chloe's point earlier there in her talk, she mentions that there's all these different laws out there, but there's no laws about making sure that medical devices or hospital devices are secure and not going to cause us problems. And there's also no incentive. There are a few nice little things. Hopefully Casey will cover some of that stuff in his talk. So next I'm going to talk about my solution for this. And the key word is communication. Now we as IT, information security, IS, we got to do much, much better at communication. We got to figure out how to communicate with our target audience. We got to figure out how to deliver our message to our target audience. We got to be able to read our target audience and get better at understanding when our target audience understands our message. And we may have to modify our message to get that across. Once we're able to effectively communicate, those horrible soft skills that nobody ever wants to work on because it's boring and challenging and difficult. Once those are down, then we can start talking about ensuring that integrity and confidentiality of data is maintained, and it's just as important, if not more important, than the availability of the data. And we'll be able to talk about how quality is just as important, maybe more so, and even cheaper in the long run than in getting something out as fast as possible, as cheap as possible. And then we can also start convincing those politicians to hold people accountable, and people meaning the CEO, boards, all those people that build corporations in order to avoid being accountable to different things. And we'll be able to start building out some incentives to help us have reasons to do things rather than reasons not to do things. Next, I want to talk about something that kind of scares me. Last year at the Biohacking Village, there was a conversation going on, and I believe Bo had said this, and it was about how physicians don't really care because care about security because there's no body count associated with security. There's no direct correlation of a medical device killing people. And to be honest, I think medical devices are being used to kill people. And there's really no way to tell if they have or they haven't been used to kill people because we don't have the technology in place to detect that. There's no SOX, there's no SIMS, there's no IPS, there's no logs, there's none of that good stuff. Not at least at hospitals. At hospitals, they have a firewall and they have antivirus type situations. And at hospitals, technology is very, very far behind everybody else. Pagers are still being used, fax machines in multifunction printers are being used to fax between floors. Just this morning, I had a fun conversation about how a CD was being sent from one hospital to another hospital, and how it's important to verify the data on that CD, how it's important to make sure that there's no viruses on that CD, and if they're going to be communicating through CDs, they should probably encrypt the data, all of which I don't think any of that has been done. Now, kind of to bring it back around, I posted a little image here. It's from 2004 about the arrest rates and percentage of crimes cleared. And as you can see, murders are solved about 62% of the time. So even if a murder is committed, then there's a pretty good chance, 40% chance, that whoever commits the murder is also going to be able to get away with it. And that's just the way it is with all the legal and law enforcement areas. As I mentioned, it was 2004 when this particular one came out. If you do a search and check, that hasn't changed. It's still right around 60%. So we need to do better. We need to start using that communication like I talked about to start holding people accountable and just start providing incentives to ensure that these medical devices aren't actually killing people. We've got to figure it out. Now here's this little scary thought for everybody. If hospitals have to invest in these monitoring site solutions, then the hospitals are also going to have to invest in ways to prevent that from happening. All of this is a huge cost effort, and hospitals don't make very much money. A lot of it is spent on administration, and they would much rather buy an MRI machine than they would spend the money on securing something. So I'm going to drive home that we've got to set up some incentives. All right, let's pull up this last slide because I don't want to end on too scary or sad of a note. Everybody's trying their absolute best in everything that they're kind of doing. Hopefully we'll all keep trying, and hopefully we'll get better and learn more and just kind of do the best we can. I'll also throw this up. Here's the references. I'm sure that at a certain point the slides will become available and you will be able to click on the links and utilize the information in these. Thanks for hearing me. I believe Casey's up next, and we'll hear from him next.
All right, greetings, DEF CON. Thank you for joining this talk, and thanks to Eric and Chloe leading into my section now. Who the heck is this guy? I am the founder, chairman, and CTO of BugCrowd. My name is Casey Ellis. Been in information security for about 20 years. From a BugCrowd standpoint, and especially as it relates to vulnerability disclosure, BugCrowd actually pioneered the crowdsourced security as a service space. So vulnerable disclosure and bug bounty predates us by a long way, which I'll get to in the talk, but we were the first to actually get in the middle and try to make it work better. So, pretty proud of that, but it means we've learned a lot about how that works from a process standpoint. From a journey standpoint, for me, started life as a hacker, got into pen test as a career, moved across into the dark side of security solutions and sales, and then broke bad and became an entrepreneur, which eventually led to starting Bugcrowd in 2012. And yeah, you can see the hack persona and the hustle persona on the side. That pretty much sums up who I am and how I do what I do. So now you know me. That's where to find me as well. So yeah, with respect to the talk, when we started Bugcrowd, it was really all about like, how do we do this well? There's this enormous community of white hats from all around the world, which Eric's talked about, and some of the things that they can do, and this incredible need for security feedback in all sorts of areas of cybersecurity. Like, how do we make this easy to do it well? How can you connect that latent potential with the unmet demands of security itself? On this, like, if you look at it simplistically, it's a fairly easy problem to solve. You just invite a conversation to happen and everything's great. But it turns out there's a lot of devil in the detail, which is, we did anticipate that when we started off, but it's a lot of what we've been continuing to work on over the last 8 years. And Disclose.io, which is what I'm going to talk about today, is a product actually of the policy and really the adoption of vulnerability disclosure component of that. Like, at this point, we're a ways along from where we were even back in 2012. I think nowadays, vulnerability disclosure is becoming this normalized phenomena, and there's starting to become a lot of social pressure around it, which I think is a really good thing. It's still the kind of thing rather that you're a bit special if you do, as opposed to being abnormal or unusual if you don't do it. And really, Disclose.io was about flipping that, but I'll not preempt myself anymore, and we'll get into a bit of backstory. So in 95, Netscape launched the Bugs Bounty program. They've since dropped the S because it's cleaner, and that is a Silicon Valley joke for anyone who missed it. There's like lockpick bounty programs. There's all sorts of other things that go back centuries even around getting security feedback through a reward model. But Netscape's broadly, accepted as the first kind of high-tech bug bounty program. And really with that, kind of almost the instantiation of being proactive around vulnerability disclosure and actually inviting and engaging it as a part of your security process. So bug bounties and vulnerability disclosure, they're not the same thing. Don't let anyone tell you that they are, but they look similar enough in terms of how they operate that, we put that back down to kind of where this whole idea started to really gain momentum. Bugcrowd started in 2012, and in 2013, I've got these flipped around, but you get it. One of the things that we noticed was, legal teams don't seem to really understand how to write a policy that is almost the opposite of everything they've written before it. So you've traditionally gone out saying, hey, if you're a hacker, go away, you're bad. And here's all of the legal stuff to create a legal framework for us to say that to you. Now we're starting to try to get our heads around the idea that, there's locksmiths as well as burglars out there, and we actually want the help of the locksmiths. Legal teams don't know how to do that. It's still, I believe, a net new kind of idea in the space of law. And the challenge is with legal teams, when they're uncertain about what they're doing, they tend to write War and Peace. Like they'll err on the side of verbosity. So you end up with these great big long confusing briefs, and that's the first part of the problem. The second part is that hackers don't read those things in the first place. They should, but it's the Euler problem. I think you get a subset of the community who actually really do dig in, and we're very grateful for them. But you've got to expect the behavior from the internet that people are just going to click through, look for the thing to do next and go, which is certainly true also in this space. And the challenge is that when you talk about, the anti-hacking laws and some of the provisions that have been invoked to chill security research that Chloe was talking about earlier, the CFAA makes screwing this up as a hacker potentially a felony crime. And the same is true for similar laws in other countries. So in 2014, we thought, all right, let's try to untangle this one and solve it. So we released the open source vulnerability disclosure framework in partnership with Jim Denaro and the folk over at Cypher Law out of DC. And that was awesome. It was basically this idea of like, how do we, kind of compress down the really important things that need to be in a brief like this to the point where people can theoretically just copy paste and get it right like 90% of the time. At the same time, Katie, Art, a bunch of others in Disclosure were working on the ISO standards. They got released to paying customers. So there was this kind of convergence on trying to solve this problem of standardization. Fast forward to 2018, what we did was basically take some of the, actually kind of capitalize on some of the attention that was around this concept of legal safe harbor. Thank you to Amit El-Azhari for really pushing that forward and her legal bug bounty initiative. And then Dropbox and a couple of other folks that were going on took the OSVDF and legal bug bounty, merged them and put them all under Disclose.io. Bugcrowd added it as default and off we went from there. So that's the backstory. And I think with respect to CFAA, it's important to keep in mind that it is in active use. I personally believe that there should be laws in place that address computers as a vector to commit a crime. But, as Chloe called out, if it's not clear what side of the law you're on, especially when you're trying to help, then there's a chilling effect that means that security feedback doesn't pass from A to B. And that's always bad. So we're trying to solve that problem. So really what Disclose.io is about is like, how do we make this idea of vuln disclosure, how do we make the adoption of a vulnerability disclosure program go viral? And doing it with best practice. How do we make that into something that is not this huge push from companies like Bugcrowd and people in the researcher community? Not this like reactive, oh crap, I got tweeted at, what do I do now? Experience for folk on the vendor side, something that, the internet collectively is leaning into and doing well. And that really is the mission of Disclose.io. It's a healthy and ubiquitous internet immune system. And props to Karen El-Azhari, Amit's sister, for I think making that concept of hackers operating as the immune system of the internet popular in her TED talk. Feels like a billion years ago at this point, but it was a little while back. I think that's true. I think the healthcare sector and the internet in general's rejection of security input, or its inability to identify that input as important and good, but then its rejection of that input is kind of like an autoimmune deficiency in a lot of ways. And this is what we're trying to solve. Like, how do we get it to the point where hackers are functioning as the T cells of the internet, and the internet as an organism, as a body, is able to cooperate with that and actually have everything grow up and be big and strong as a byproduct. The mission of Disclose.io is to drive vulnerability disclosure adoption, as I probably made clear at this point, but doing that through safety, simplicity, and standardization. So if that's what you remember about this project, that's going to be kind of the key takeaway, because it does involve everyone. It is open source. I'm known for Bugcrowd, sitting in front of a big Bugcrowd logo, and this is kind of the commercial construct for starting this project. But at this point, we have basically spun it out into its own thing. It's very much something that we want everyone to participate in, regardless of whether they're a customer of my company or not. So that's kind of the goal here. So what is it? How are we doing it? How do you unscrew a 30-year-old problem on the internet? Glad you asked. So there's three main components to it. There's the terms. The purpose of the terms is to make it easy. Like, how do we eliminate the friction of understanding and adopting VDP language in a way that benefits hackers and companies? And the overall outcome of that is ideally standardization of what those terms should look like. Eventually, ideally, to the point where things like CFAA, DMCA, and others start to come under the right kind of pressure to be reformed to actually accommodate for good faith in our space. I think that's the utopian goal. We're a ways off from that, and there's a lot of other things for legal folk to be occupying themselves with right now. But in the meantime, we can do our part. The second piece is the list, which is to aggregate adoption. And really to drive adoption as well. The whole idea there is network effect, which is that kind of virality piece I was talking about before. How do we get it all into the one spot in a way that basically creates this critical mass of best practice that people are actually drawn to? And the third piece is the logo, which is really normalization. I'll go into these in a second because I'm kind of getting ahead of it, but how do we promote best practice. I think VDP is a little bit unique in terms of security things that a company can do because a non-technical user can understand it. Like they might not get, blockchain enabled, AI powered, next gen endpoint, something. But the idea of neighborhood watch for the internet, especially when you're talking about a safety critical space like medical, anyone can get that. And we're at a point in time where I think the average human is more concerned about the risk that they have when they're buying a product than ever before. So this becomes something that's actually, a benefit, aside from the security benefit and the fact that it's just the right thing to do. The goal with this is for it to almost become like the green padlock for SSL. And I say that fully mindful that people have started to remove the green padlock because it has been normalized. Like if this whole idea of VDP adoption can go through that same arc, I would be incredibly happy. And I think pretty much everyone in this space would benefit from it, as well as the internet itself. So, all right, the terms. It is a collection of boilerplate vuln disclosure templates. Some folk just copy paste it with the OSVDF, the initial incarnation of this. We noticed the language popping up everywhere. It was getting translated into different languages. That document is grandfathered into policies all over the internet at this point, and that's just a thing that people do. So, okay, you can do that, or you can use it as a foundational framework or a starting point for new versions, which is one of the reasons that it's open source. We've actually taken input from programs who've looked at the policy, said, hang on, here's an edge that a lot of people have that you probably haven't considered that we're going to write in. You should consider it, issued a pull request, and we've actually merged that into the language over time. It's open source, as I keep saying, because I want to really stress that point. It's licensed under CCA 4.0, so anyone can use it. And some of the folk represented in the NASCAR kind of section here are the kind of people that are helping out. This isn't an endorsement from them of the project itself, but it's the kind of folks that are participating on an individual level to making that language better and driving this forward. These are the kind of folks that are actually rocking up and assisting. So that's the other benefit of open source. It's not just, Casey the Bush lawyer from Australia's opinion on how to do this well. It's all sorts of different folk that are actually coming in and making the whole thing more and more effective over time. And honestly, like this is the interesting part I find is that it's actually kind of hard to do. One of the things that's a challenge, frankly, that needs to be overcome because it's a function of how it works is that not every hacker is a lawyer. In fact, most aren't, I would say. And many of them, I would say most, are English as a second language. So you've got to be able to actually articulate what the hell you're trying to do in this brief in a way that if they do read it, they can understand what's okay and what's not. So you've got to balance this readability and brevity with legal completeness. Obviously, you want to provide safety to whatever degree you can without going overboard and having it turn into this 12-page read fest. And the safety that's provided by the clauses in this type of thing need to be bilateral. They need to protect the company that's putting it up on their policy, and it needs to, more importantly, I think in context of this talk, protect the hacker as they're doing research, or even, the concerned citizen who's found a bug, not as a product of security research that just wants to send it across and doesn't know if that'll get them sent to jail or not. So at the moment, it's covering US, Canada, the Netherlands, and Belgium. And we wrote one for the 2020 US presidential elections. That was tough because there's obviously a lot to consider there. But that's the sort of problem sets that we're trying to tackle with these terms and with the goal of making it easy and standardized. The list itself is this true community-powered, vendor-agnostic directory of all known VDPs and bug bounty programs. At the moment, we've got, what kind of legal protections afforded by the program, what kind of rewards does it offer. We're about to integrate support with security.txt. And I think calling out the disclosure models and timelines, if it's a coordinated vulnerability disclosure model, that's going to be different for every organization. So we've accommodated that in there as well. Again, open source, licensed under CCA. So that brings us to the seal. This is like the green padlock part that I was talking about at the front. What we've done at this stage, this will continue to evolve, but where it's up to at this point is dividing out what we're referring to as safe harbor, or is popularly, I think at this point, referred to as safe harbor. What that's really talking about is what kind of legal protections are available to the researcher that have been proactively included by the program owner into the program. And we've broken it into partial safe harbor and partial, like a partial compliance statement and a full safe harbor or a full compliance statement. The difference between those two things, I think, is quite important. For partial, what we're referring to as partial safe harbor, essentially it's a good faith statement. So it's this idea that, hey, we agree not to lawyer up and cause you a hard time if you play by these rules, which is better than there being nothing there, right? Because that's when, you know, I think the risk can be quite high, and there's even recently examples of where that sort of thing's gone wrong. That statement in of itself is a good start. The problem is that you're still potentially technically committing a crime as you conduct security research. And that's the part where there's still, I think, a decent amount of exposure. I liken it to, you know, in California, on the highways, the speed limit's 60 miles an hour, but everyone drives at 80 and you don't get pulled over, right? And that's because there's this sort of social contract. It's not quite, that would be no safe harbor because it's not written down anywhere, but kind of everyone knows. It's sort of the same thing. You could get pulled over for that, but you just don't. Full safe harbor would be the analog to actually increasing the speed limit to what people drive at, and putting it on the speed sign. So at that point, there's no recourse for you to be, you know, issued a speeding ticket in that context. I'm doubling down on this driving metaphor, but I think it's a neat way to explain it. And to basically get full compliance in context of disclosure IO, there needs to be provision against anti-hacking laws. So authorization is typically the hinge term. It certainly is with CFAA, and the same is broadly true around the world. Exemption against any circumvention laws like DMCA, which is very relevant to medical device research. Exemption against acceptable use or TOS violation, because you're breaking the thing, and that shouldn't mean that you're breaking the law if you're doing security research. And a general acknowledgement of good faith as well. And this is the part where, you know, we'll get to how this all works, because ideally, and we've started to see this happen, but this is where everyone can help. An organization initiates a vulnerable disclosure program, it gets added to the list, people see that and look at it, then say, oh, well, where are you at with these safe harbor clauses? Where are you at with, you know, the legal protections that you're giving researchers to actually try to help you out here? The organization's like, oh, I didn't even really think of that, because oftentimes that's true. They go back, look through the boilerplate stuff, you know, work out what they're going to include or how they're going to adapt their policies. It gets updated in the list, and at that point, they're issued with the logo. Should an organization actually take that logo and use it to promote the fact that they've got a VDP or promote the fact that this is part of their cybersecurity process? At that point, hackers see it and they start to help out, which is good. Customers see it and they trust them more, which is good. The part I like best is that their peers, from a vertical standpoint, see it and ask themselves, why aren't I doing that? I should probably do that too. Like if you know, we're in a vertical with 5 players in it, 4 are doing it and 1's left out, that one looks like a schmuck and no one wants to be that company. So it's basically increasing lateral social pressure to adopt vulnerability disclosure and actually do this well. And, you know, it feels too soon to be talking about I was actually talking about this in context of virality and network effect before COVID broke out, but, you know, without disrespecting, I think the pain that's causing a lot of people right now, I think it actually illustrates the idea pretty effectively. Like, how do we take this concept of doing the right thing, making people more secure, doing the right thing by hackers, and just generally improving the security of the internet and actually make that viral? That's really the goal that we've got here. So how does it relate to medical security? What can we achieve in 2020? The first, and this is a call for help, is to adapt the terms to the medical device sector in particular. I think the medical sector in general would be great too. You know, I think the election security revision that we did, it took a lot of work and a lot of thoughtfulness from people that are involved in that space, because there's a lot of edge cases that are specific that needed to be considered and factored in, and then you needed to simplify that. So you can't just add crap on, because that violates the simplicity design goal of the terms. So lawyers that are up for that, please do reach out. As people adopt vulnerability disclosure in medical security, we want to see at least 30% of them with this full authorization statement. ideally higher. Like I'd love to see it get to 100% at some point in the future, but 30% seems like a great place to start. Across the 1,000 odd programs that we're tracking at the moment, compliance is at about 13%. I think last time I checked. So, there's a gap there, but it's a bridgeable gap. So I think that's a good goal. And I think specific to COVID, this is something that we've been pushing on commercially as Bug Crowd, but also just in general at a policy level. How can we use this to basically unscrew the problem of COVID contact tracing, both from a security and privacy standpoint, but then also from an adoption standpoint? One of the things that's preventing people from adopting, rightly or wrongly, or perhaps rightly and wrongly, from adopting contact tracing applications is they don't trust the security implication, they don't trust the privacy implication, they don't trust their government, the folks that wrote it, like whatever the individual excuse or reason might be. It's sort of similar to the conversation before around, like, this is neighborhood watch for the internet. If there's transparency, if there's like this known kind of group of people that are constantly working to help improve this stuff for their own safety as hackers and as members of this community, all of a sudden, we solve all of those problems with really the one shot, obviously providing the issues are getting fixed, which we're not addressing in this. We are just talking about vulnerability intake and policy. That whole vulnerability management piece is very much a separate but adjacent subject. I don't want to confuse the two there, but you can sort of see the model here. If all of a sudden a government or an agency is turning around saying, cool, this is our solution, these are the concerns that we know you have, this is how we're addressing them, and by the way, the transparency should make you more confident. If that drives up adoption rates of safe and privacy conscious contact tracing applications, I think that's part of what that makes that particular model of pandemic management work, which is something we need to be thinking about right now. I personally hate that type of solution in any time other than this. I got asked a lot of questions about it and said, yeah, in any other time I'd run screaming from something like contact tracing. I'd recommend that absolutely everyone else do the same thing. But like, we haven't really dealt with the kind of things that we're dealing with before with technology available as a potential solution. So I think this is a really practical application of it. So help wanted. Lawyers, help us translate the terms. If you want to translate it into a language that you speak in and a jurisdiction where you can be considerate of the particular anti-hacking and anti-circumvention laws that apply, that would be fantastic. We'd appreciate that. We want to see as much of that happen as possible. For hackers, contribute to the list. If there's something missing or if there's a detail that's incorrect, submit a pull request and actually use that list. The idea of it is to help you guys and girls and everyone else who's involved in hacking to be able to look at the target space that's out there that's actually wanting your help and giving you an opportunity to do that. If you want to work on paid programs, go for it. If you want to work on VDPs and verticals that you're passionate about, do it. The goal of the list is to get all of that information in the one spot and make it easy and shareable to everyone. And contributions, power that. For organizations that might be watching, start talking to your security teams, start talking to organizations like BugCrowd, start talking to hackers about what you need to do to take steps towards being proactive about launching a vulnerability disclosure program and actually engaging the feedback of the hacker community. I think a thing to call out here is you're probably going to get it anyway. And I think that's sort of where this is all going. This idea of the internet being a feedback loop is very quickly becoming normalized. So you can either be reactive to this trend or you can be proactive. And I think being proactive is a better bet. And then include safe harbor. And for everyone in the mix, spread the word. Again, this is the reason that we open sourced it. This is the reason that we created this particular brand and this particular logo around the idea. We didn't want this to be purely tied to a commercial initiative. We think this is something that should happen anyway. And I'm speaking as BugCrowd right now. This is the kind of thing where I think the more input we get, the more it gets spread around, the more people get involved and the more people adopt it, the better off we all become. And I think that's something that we can all be a part of. So that is my spiel on disclosure. I really appreciate everyone for attending this talk. Thank you to Chloe and to Eric for their sections in the talk and tying it all together. I think this whole ecosystem of the relationship between, you know, the hacker community and hacker feedback loops and the current and future state of security overall and safety as a byproduct of that in the medical sector. Hopefully we've given you all something to think about today. And now we're going to do some Q&A.
Okay, we are live. So thank you so much, everyone, for your fantastic input. We have JR in the line who will be keeping track of the questions that are being asked on Twitch, YouTube, and Discord. So with that, JR, take it away.
Thanks, everybody. And thank you so much to all the speakers today, especially Casey and Tyre and Chloe. Really appreciate it. So looking at all the channels, and first, I'm just going to take a minute and say,
well, we do have one question that is in chat if you want to ask on Discord. So Bo
yeah, I do. So that's where I'm going to take it. I'm just going to take a minute to sort of fangirl all over the place. This is my first DEF CON. So thank you, everybody.
Welcome.
And thank you to thank you to Sydney and Casey and Tyre for the presentations today. One question that came up in the Discord channel from Bo. How open has the medical device industry or healthcare in general been to disclosure?
Yeah, I'll kick that one off. Slow, but picking up, I think. You know, the medical device manufacturers, you know, Suzanne Schwartz and some of the crew over at FDA started working pretty intently a few years back on, you know, integrating vulnerability disclosure into the post-market cybersecurity guidance for medical devices, and that got through. There's been more iterations of that since. In terms of the actual, you know, manufacturers and vendors themselves, it's interesting because I think healthcare historically hasn't been super proactive or like known for being good at cybersecurity. But, you know, there's been like steady evidence of the fact that that is important, you know, through research and all sorts of other things. And I think, frankly, COVID's given that a huge shot in the arm this year, just with, you know, the change in, you know, threat models, the threat actors, the things that are being attacked. So, yeah, I would say that it's you know, kind of at the upwards ramp point. You know, one thing, you know, as I mentioned in the talk, the crossover between vulnerability disclosure and the adoption of you know, contact tracing applications and different things like that, we're seeing a lot of different governments zone in on that because they recognize they need to do it well, and they need to engender the trust of their citizens. So I would expect that to, you know, land in contact tracing, but then spread out to other aspects of medical security over time.
I'll just add to that a little bit. Casey does a nice job of pointing out some of the hope in the area. I'm still going to be the doom and gloom because I see, you know, just recently I had a visit with a hospital executive, and I was talking to him about medical device security for his hospital, and his comment was basically, well, our plan is basically luck. So hopefully if we get hacked, if our medical devices get hacked, we're just unlucky. And trying to convince that type of mindset that we have to do better than just luck, it is a very large hurdle to overcome. So hopefully we can get there with some of the changes.
Yeah, I'd agree. There is definitely a long way to go. I see the adoption of vulnerability disclosure as almost like, you know, arguing against it ultimately becomes like, you know, arguing against death and taxes. Like, I don't like gravity, but gravity doesn't care. In the sense that, you know, people that can hack stuff and people that can contribute to safety are going to do that whether they're asked to or not. And I think oftentimes they'll do that even if it's legal, like regardless of whether it's legal or not. And we can only expect that to grow as technology becomes more accessible and more people, you know, try to apply this kind of hacker mindset to everything. So, you know, logically, vulnerability disclosures are just going to happen regardless of whether or not the medical sector actually invites it or not. So it's kind of a question of like who's proactive and who ends up having to be reactive and how they deal with that.
And it is
Really
getting
good
better.
point.
We went from, you know, the Hospira PTA pump to now with open telnet and root access on that pump to now there's actually passwords on those things, and they're a little more stable so you can actually scan them. So there's been improvement. It's just agonizingly slow, I guess.
True story. There's a question on Twitch from Ezra. What's the better method for improving security to US government regulations or to wait for healthcare to form its own equivalent to PCI DSS?
Drink.
I was
In
just
the meantime.
And by the way, this is Eric. So if you guys are trying to pronounce that Tearsal name, it may be easier to pronounce my first name. I'm pretty open on what I am and all that kind of stuff. If you assign me, you'll find out way too much information. But
thank you, Eric.
Yeah. I was recently in a conference with some FBI agents, and they were talking about how during the 1920s there were all these bank robberies that were going around. And the FBI was trying to stop them and fix things. And he basically said that the law enforcement was not capable of stopping all the bank robberies, and the banks had to develop vaults and time-sensitive vaults in order to protect themselves. So I have a feeling that it's going to be up to us and up to the medical industry to make these changes. We can't wait for governments and law enforcement to take the initiative on this. Yes, they're going to help us along the way, but for the most part, we're going to have to, inside the industry itself and hopefully pressure from patients, we're going to have to make the changes, not wait for the government and law enforcement agencies. I don't think that'll ever, I mean, it'll help, but it's not going to be ever a driving force.
Chloe, did you have anything to add to that?
I think just overall on that is that we should always make sure that, you know, even though government might be kind of slow and behind on these things, the thing is there's a great number of organizations or a collective of people that are actually trying to help in any sort of way at this time. Like CTI League is definitely one of those. EFF is another one. I mean, Disclose.io. I Am the Cavalry and CERT-CC are all really good organizations to support because they're right now trying to do the best that they can during COVID-19 and when it comes to disclosures.
Very good points, Chloe.
Unfortunately, we are running a little bit low on time, and we got to get ready for the next talk. But thank you so much to our speakers for today. If you do want to reach out to them, by all means, please go ahead and reach out to them on Twitter. Hopefully, they'll also be on Discord later on as well if you do have any questions. But with that, thank you once again. Our next talk will be in about 2 minutes, so we will see you then.
thanks to Nina and everyone at Biohack Village for having me. My name is Anthony DeFranco, and I'm one of the founders of the Open Insulin Project. And I'd like to tell you a little bit about the general problem that we're addressing and how we're approaching it, and how you all can maybe get involved if you're interested. So let me begin. The basic fact is that worldwide, 50% of the people who need insulin to survive don't have access to it. And when we take that figure into account and also look at the population of people worldwide with diabetes and some bounds that we have on the death rate that's directly attributed to it, and we also look at the insulin access statistic here, and we put all of the information we have together to get a rough estimate of what the impact of this situation is, where fully half of people who need insulin to survive can't get it. A very rough order of magnitude estimate is that about 20 million people, 10 to 20 million people a year are dying due to lack of access to insulin worldwide. To put that in perspective, 12 million people per year was the rate that people were dying due to World War II from all causes, which was the deadliest conflict in history. So this situation where half of the people in the world lack access to insulin is really a crisis on a historic level. It's something that it's hard to find anything that compares to this. However, unlike a war or a very kind of complex problem like that, the fundamental technical realities of making insulin and getting it to people are fairly simple. So we're going to look a little bit at why, despite that, there is a problem of this magnitude, and how we can try to approach it, and how we are trying to approach it in the Open Insulin Project. So that's kind of the worldwide situation. Here in America, where the many people in the project are based, we know a little bit more. Now, the worldwide situation is largely due to supply chain issues and the kind of geopolitics around different countries' access to markets. So those issues don't really exist within the U.S. The U.S. has plenty of infrastructure to get insulin to people. The technology to produce is well established here. So it's a little even more puzzling to note that there's still a significant problem in the U.S. So we want to look a little bit at that. So here are some figures on just the prevalence of diabetes in the U.S. Almost half of people have either diabetes or a risk of developing it in fairly short term. Just diagnosed diabetes alone is over $300 billion a year cost for everyone. Having diabetes, it significantly increases overall healthcare costs. And there's a bit more detail on how diabetes is contributing to the global death rate. So this is another kind of data point a little bit more specific about what we were talking about earlier, where we can actually say that the deaths directly attributable to diabetes also quite significant. So, why is this eminently treatable disease still causing so many deaths, and why is lack of treatment even in an industrialized, advanced technologically and infrastructurally country like the U.S.? Why is this disease still causing so much harm and so much clearly preventable death? Well, one of the factors is that the supply of insulin, even though it's very easy to make it, empirically speaking, just has a lot of trouble reaching the people who need it. And the first step in that process is the manufacture of it. And globally, 3 manufacturers control almost the entire supply of insulin. And that is true in the US as well. It's true everywhere. Already we're seeing that at the very first step in the supply, there is a kind of a restriction that may prove significant. As a result, the list prices have risen on a roughly exponential trajectory. This has been part of a pattern of all of the major manufacturers raising their prices at about the same time by about the same increment for decades. And this has resulted in the list price becoming unaffordable for many people. And because of the complexities in the US, for instance, the US kind of has a strange healthcare system where, some aspects of the prices are subsidized in various ways by different parties who negotiate amongst themselves. There's a very complex system involving insurers and manufacturers and pharmacy benefits managers and pharmacies. And there's a set of complex and mostly secret agreements among them as to what people are actually paying. But anyone who doesn't have insurance, which is tied to having a job, largely in the US, they're likely to have to pay that list price and to be unable to afford it. So this is implicated in what the problem may be as we come to understand it more. And then the result of that has been that 1 in 4 people with diabetes in the US have reported rationing their insulin, and not taking as much insulin as you need puts you immediately a much greater risk of the complications of diabetes. In the short term, you can develop diabetic ketoacidosis, which is potentially deadly within hours or days. And in the longer term, if you're not taking as much insulin as you need, you can develop the longer term complications of diabetes, which are many of which are listed here. Blindness, cardiovascular disease, and amputations, for example. So it's a rather grim situation, but it's kind of difficult to understand why this would be the case, since insulin in some form or another has been produced as a medicine for almost a century. And even the state-of-the-art forms of insulin, the most modern forms that we have are largely off patent. So why is it that there's still this access crisis? Why are only you know, 3 manufacturers still controlling almost the entire market and able to price the insulin out of reach of many people. So there have been some investigations into this where people have looked at the price increase patterns and are, you know, finding evidence that there may be collusion. So, you know, some of these cases are still in progress here. But, you know, the fundamental reality is that, you know, whether or not there is explicit collusion here, there is this pattern of price increases, and it has become unaffordable. And at the technical level, there's really not that much of a challenge to making insulin. So that's what we're focusing on now in our project, is how to make insulin. So this is part of a broader problem in how healthcare and the economy around medicine is, you know, thought to, you know, what the kind of dominant philosophy on how to manage it is. There was a kind of economic theory that gained a lot of credibility in policy circles in the mid 20th century that said that you know, making medicine is kind of different from other economic activities, in that subsidies are needed to do all of the research involved, and that a monopoly is an expedient form of subsidy, so that you know, that would be a sensible policy, is to tolerate and even encourage monopolies around medicine. And these claims actually collapse fairly quickly under scrutiny. You know, most of the R&D involved in making medicines is already done with public money in universities, and the companies themselves spend much more of their own budgets on other things like marketing and executive compensation than they do on R&D. And also, this belief that monopolies are essentially harmless has been, you know, roundly debunked since then. But nonetheless, that's the system that we've inherited. So the result of this is that, you know, we've had this complex system of agreements grow up around it, you know, with all of those other, you know, parties like pharmacy benefits managers that we'll look a little bit more at later in the presentation. And, you know, they kind of partition up the market, and it's very difficult to do anything outside of one of these kind of proprietary partitions, or to go between them, you know, even to the point that some people who are allergic or don't tolerate one brand of insulin are unable to get it covered by their insurance, because the insurance only covers one brand at the, you know, preferred tier. So even when there's clear medical necessity, it still doesn't matter in this system. So, you know, it's kind of a it's not much of an economy in the end, because it's so thoroughly you know, shot through with monopolies and monopolistic arrangements. And we see, you know, the problems that are typically associated with this. And you know, one of the most notable is pricing the poor out of the market, but also, you know, you can see that progress that would threaten an existing line of business is discouraged. And, you know, one example of that was that, you know, an analyst here at Goldman Sachs is asking, is curing patients a sustainable business model? The answer in an economy where competition is essentially impossible is no, because the profits are already being maximized by chronically treating things, and so curing them doesn't make any sense if people don't have any alternative. And so that's kind of the unfortunate result of this. And this is something that many have researched this. One of my favorite theorists of this is Mr. Schmitz at Minneapolis Fed. So he has looked at how monopolies actually do cause the harms that we've discussed. And in the case of medicine, the harms aren't just economic; they are directly related to lost lives and really tragic and tragically avoidable health consequences for people. So one of the things that is noted in general that we've seen in insulin is, in the case of insulin in particular, is that we have seen people turning to crowdfunding because the cost of insulin when they lose health insurance or health coverage of some sort is more than many people make in a month. It could be many thousands of dollars a month. So this is really quite egregious example of how people get priced out of the market fairly quickly. And it's not just a subtle effect, it is a really a very large difference in prices that people have to bear, to the point where it'll be exceed everything else that they're paying for in life by quite a bit. So just to make that a little bit more concrete, the cost of manufacture of insulin is about $5 per vial, but the list prices have risen to the point where they're around $300 to $600 per vial in some cases. And these conditions have persisted for decades, and they've only gotten worse. There hasn't been any successful pushback against them yet. So what we are trying to do is kind of invert everything that we've observed in our project. So instead of relying on proprietary development and mechanisms of monopoly, we are sharing everything that we develop in a commons, and we are looking to produce insulin in low overhead distributed networks of small scale manufacturing sites. And instead of having this really strong conflict of interest between the producers who are motivated by profits and to deliver profits to investors, instead we're looking to have the people who use the insulin actually be directly involved in the governance of the organizations that are making the insulin, so that they'll be able to make decisions as to how everything is managed in the interests of themselves and each other and the people using the insulin. And a helpful side effect of this will hopefully be that we'll be able to be a lot more nimble and actually make a lot more improvements and not be incentivized to keep old things around just because they're already profitable, and actually move things forward and hopefully make progress towards a cure that might not be economically feasible otherwise. And in part, we're inspired by other successes in the diabetes community. So although we're the first effort I know of to make insulin itself open source. For about 10 years now, people have been working on artificial pancreas systems, which is essentially a software algorithm that controls an insulin pump to determine the timing and the amount of the dose of insulin automatically, usually based on feedback from a continuous glucose monitor. And this is something that was already possible with technology from the 80s, but the manufacturers just never seemed to be able to bring it to market for whatever reason. But once the technology to do this became more widespread, once embedded computers became cheaper and easier to work with, and knowledge of software and how to write these kinds of algorithms became more widespread, individual diabetics and small groups were able to just pick up this work and bring it to completion within the space of a few years. And now, for almost a decade, there have been DIY artificial pancreas systems that many people have been relying on and trusting with their own lives and the lives of their children, and they're working very well. And this was done without any large R&D budgets or institutional overhead. It was just people collaborating in these horizontal networks to solve their own problems and each other's problems. So we're working on enabling this for the insulin itself, so that we can kind of complete the open source economy for treating diabetes. And it turns out that the same trends that made the DIY artificial pancreas systems possible are also going to help us. The more pervasive and cheap computing technology is going to play some role in letting us automate different aspects of the production and purification, and it also just makes it easier for us to collaborate with each other. And so we're seeing signs that we can reproduce this kind of success. And the result of that will be ideally to move this activity from these proprietary fiefdoms and into the commons. And this is something that is good for people. It's very good for business as well, judging by how it's gone with open source software businesses. But a major difference is that it actually respects and promotes competition and innovation instead of sabotaging it and causing everything to stagnate and people to go on needlessly suffering and dying for no reason. So that's our goal. And we're working on developing both the technology and the organizational forms that are associated with this to create a comprehensive alternative for the status quo. And we're trying to prioritize the people who currently lack insulin and need it most in how we develop things so that we can most directly address the most urgent problems that people in society have. So this is a closer look at the existing supply chain, just so that we can contrast it with what we're setting up. So I mentioned earlier that there are these multiple middlemen who operate in these complex networks in between the manufacturer and the consumer. And so I won't even really try to go through this in any detail, but you can see that there are quite a few complex patterns of interrelationship among them, and most of these are are done in secret, so there's no transparency into how this works in any detail. And you know, it involves kickbacks being passed up and down the chain, and you know, all kinds of things that just are in themselves a great challenge to making any sense of things. And so when the system produces the nonsensical result of you know, denying people insulin that they need to survive that costs very little to make, you know, this is kind of how that is able to grow, and that kind of problem can grow and sustain itself in this environment of artificial complexity. So we're going to address that by making things as simple and as direct as possible. So right now we're working in our community labs to develop the microbes and the technology, and then we're going to publish the information associated with them. And then using that public information about how the technology works, we're looking at setting up a system of cooperatives where the insulin users can participate directly in the ownership and the governance of those organizations. And we may also be partnering with hospitals and local pharmacies that already do work that is similar in some technical aspects to this, and they already have you know, people who would need the insulin. They have relationships with them, and we may also be looking at collaborating with local and state governments. And you know, aside from these fairly small and simple low overhead organizations, it's going to be as direct to the users as possible. So a closer look at some of the technical work that we're doing. And this is, you know, this is just a general look at how protein production and purification works and how this applies to insulin. So right now we've designed some genetic modifications to some microbes. We have actually 3 systems we're working on now. This is 2 of them, but we have 2 yeast-based systems for producing insulin glargine, which is a long-acting insulin, and 1 E. coli-based for producing Lispro, which is a rapid-acting insulin. And so we are have ongoing work with the microbe engineering. Some of it has produced some small yields already, but we're working on getting the production to be reliable and the yields to a practical level. And then once the microbes are engineered, we're going to focus on a small-scale purification system, initially using proprietary equipment, but we're also working on making open source equipment for that. And we've also, excuse me, we've also started to look at the verification and quality assurance questions of making that product suitable for use as a medicine. And so once we've got all of these aspects in place, we've got all of the technical problems for making insulin in a small scale setting solved. So here's a look at a kind of demonstration version of a bioreactor. So it is essentially just a bit of plumbing, and aside from having to keep it sterile, there isn't anything terribly technically complex about it. You're going to have some, you know, some pumps and some valves and temperature sensors, pH sensors, and that sort of thing. And then for the purification, you're going to have, you know, perhaps a column which is just a tube with certain ports filled with some materials that may be a little bit costly, but for the most part, this is something that you can, as these people have for this demonstration unit, they fit everything you need to do it onto a tabletop. So we can work in a similar envelope. The corner of a room could be enough to produce insulin for a small city if we are running at a reasonable efficiency. And as a result, we can bring the cost of insulin back down to what the cost of production already is. So our own projections for what our cost of production would be are in line with what they are for the large scale production that dominates right now. So based on our preliminary model, we could be providing this to people for $7 a vial, which is very close to the $3 to $5 a vial that it's usually produced for. So we're seeing that there isn't really any economy of scale here, and that there isn't any kind of actual technical or economic justification for the limited supply that we see right now. So as I mentioned, we are still working on the microbe engineering, but we have started to work on the open hardware as well. So we're making progress on the technical aspects of this process, and we're looking forward to reaching some of the milestones on that fairly soon. And we've begun working not just on the open hardware, but also on some of the regulatory and organizational research to make that hypothetical system of cooperatively organized production a reality. So, that's going to involve some outside of the box thinking, and we're, getting into looking at a lot of interesting precedents, like ideas from personalized medicine and other forms of cooperative medicine and healthcare, and state level frameworks for things like direct public offerings, financial mechanisms. And so it's really taking us on both a deep and a broad look at a lot of very promising alternative ways of doing things that we hope will apply not just to insulin, but to perhaps medicine in general and business in general in the near future as well. So here's a closer look at the bioreactor design that we have just recently completed the first look at. So as you can see, the bioreactor, when we break it down to the specifics, as I was saying before, it's kind of some pumps and some sensors and an air pump and some heating pads. And this is a design that was based on one that another fellow in the community, Sebastian Kosioba, is working on. So he was kind enough to show us around his design, and we have a group of interns that's working on this right now. So this was made by Paige Hanoka, and it took her just a couple of weeks to come up with this. And the bill of materials for this comes out to $115.80. So this would have a capacity of a few liters and a capacity of a few liters if you run it fairly close to continuously, that can supply insulin for a few thousand people. So, this is still leaving out the purification and the QA aspects, but those don't add an order of magnitude more cost to this. So you can see that the, capital requirements for doing this are negligible. So we've talked a bit about how we're looking to organize the production ultimately, but we are also organizing the R&D work that we're doing right now in a similar way. So we're a fairly horizontal, open source oriented organization. We're taking cues from other open source foundations that are stewards of different kinds of technology. So we have groups working on the wet lab R&D, the hardware, supporting software for our organization, developing the business plans, doing the legal and policy research, and doing communications with our supporters, and touching on fundraising as well. And here are a few folks from the team. We are a loosely organized network of volunteers, so people kind of come in and out. We weren't able to list everyone, but here are a few of the more regularly involved folks. Jan is our chief scientist working on the microbe stuff, and David and Max are also working on that here in our Oakland lab. Alex Hay recently developed an open source glucometer, which we have a blog post up on our blog about, which is very interesting. Nicole has been helping us with the legal work that we're doing. Ife has helped with software. Louise is working on communications and fundraising with the interns. Jessica is also working on the microbe engineering in the wet lab and with an intern group as well. Remy has helped us with some collaborations, and Kadi is actually one of our international collaborators in Senegal, who is getting her lab set up now to join us and perhaps help us look at some new possibilities involving plant-based production. So very interesting potential there. Within our group, we fairly horizontal, as I said. So, we kind of go on the open source credo of, loose consensus and working protocols, we could say, and just take on tasks on our initiative for the most part. So we've had to collaborate remotely. So, we're doing things in online meetings, which anyone is welcome to join. And, if anyone is interested in that, you can go to our website, openinsulin.org. And we have some posts up there that will give you some contact information about the meetings. So, with that, I'd be happy to hear from any of you if you're interested in learning more about what we're doing, or helping with any aspect of this. And the more the merrier, and the more people are helping out, the faster we're going to be able to solve this very urgent problem. So it would be a pleasure to hear from you. And again, thank you for having me here, and thanks to Nina and the Biohacking Village folks. Hello, everyone.
Okay, so we are live. So we have three people from the project that are here to give a little bit of insight into what is happening with it and to answer your questions. So we have Anthony, Louise, and Maria. Like last time, JR will be here to keep track of questions that are being asked. So if you do have questions, please go ahead and ask them in chat. But with that, JR, take it away.
Thanks, everybody. Thanks to Anthony and his team for putting that data together for that presentation. I really appreciate it, and thank you again. I'm going to read this first question because I'm so excited to read this person's name. It is from Snoochie Boochies. Sort of a two-part question. I'm going to read them together. One is, what percentage of healthcare fraud, whether payer or cyber, is related to diabetes? Second question, what have you done any threat modeling? Identify common vectors for intentional or unintentional compromise. What lessons did you learn?
All right. I do not know anything about fraud as it relates to diabetes or anything else, so I'm going to have to defer to one of my colleagues just in the off chance that they might know a little bit about that, or otherwise I'm going to have to pass on that question. Do any of you know? No.
No, I mean, what we know about healthcare is that just over 10% of the folks in the United States have been diagnosed with diabetes. It's one of the most prevalent diseases there is. Healthcare fraud isn't particular to diabetics. We do know more they have trouble negotiating the systems because of particularities with the disease. So it's not fraud so much as there's a lot of issue with getting access to insulin, getting access to enough insulin, having to get new prescriptions for insulin. If you're a type 1 diabetic, your diabetes never goes away. So why you need to see your endocrinologist to get a prescription renewal is, the bigger issue, more than the patient side.
Now, Snoochie Boogie's asked a second question. Have you done any threat modeling, identified common vectors for intentional or unintentional compromise? What lessons did you learn?
Yeah, I can't say that we have, but perhaps if you could provide like a more specific scenario that you have in mind, I could comment on that, or one of my colleagues could.
Yeah. We are currently going through modeling what it looks like to actually go through the FDA regulatory process. So that's the sort of threat modeling we look at.
That's fair. In the interest of time, we'll keep moving. Another question from Danger Kitty. What are the legalities of producing insulin? Is it legal? Did you guys have to fight off a lot of lawsuits and etc.?
Yeah, well, that I can speak to because that's a big aspect of the project is addressing that kind of question. So, just producing insulin is not really regulated in any way. Producing it for other people to use as a medicine is very heavily regulated. So just producing it for research use or for personal use is, as far as we can tell, an unregulated activity. But then in order to actually create the kind of mutual aid network that we want to create, we do have to address those questions. And we're looking at everything from the more typical biosimilars drug approval pathway that is the same sort of a process that a huge factory that's very centralized would use, all the way to looking at models for cooperatives that have been used for health insurance and for making other medicines.
Okay.
Thank you.
Oh, sorry,
One last
Maria.
question.
Maria, last. No, unfortunately, we're almost out of time. But Maria, if you maybe want to have the final word.
I was just going to say, as far as lawsuits, there's been no lawsuits because everything we're doing is off patent.
Well, that makes it easy then.
Yep.
Okay. Well,
yeah, none of that trouble, fortunately.
Well, thank you so much for joining us. We really appreciate you taking the time. It's a fantastic project. I really hope the future success of it. It's definitely something that's needed in the world. So big shout out to you guys. A big round of applause, and thank you for joining us. Our next talk will be in about 1 minute, so we will see you all then.
Thank you.
excited to be presenting at our virtual DEF CON this year in the Biohacking Village. I'll be talking today about cybersecurity-informed consent. A few disclosures before I begin my talk. I previously worked at the Cleveland Clinic, and I have a little bit of equity there. I received salary support from the NIH, for which I am eternally grateful. And I do a lot of volunteer work for the Global Alliance for Genomics and Health, the National Society of Genetic Counselors, and I'm a founding member of the Digital Medicine Society, and I will shamelessly plug them now. You should join too. And also, really importantly, the work that I'm presenting, I have not done by myself. Specifically, I had 3 close collaborators. So last year at DEF CON, Andy Corvos, who's pictured on the left there, introduced me to Jeff and Christian, who are pictured on the right, to merge the minds together, bringing my ethics experience, Andy's engineering experience, and Jeff and Christian's experience as doctors and security researchers all into one pool to create this idea of cybersecurity-informed consent. So today I'm going to talk a little bit about the cybersecurity of medical devices, which is background for the ethics folks that might be watching this talk. Then I'm going to be talking a little bit about informed consent, which will be perhaps some background that's good for the engineering folks. And then we'll bring it all together in the concept of cybersecurity-informed consent. So let's talk about the cybersecurity of medical devices. And for many of you in the Biohacking Village, this will seem very basic, but for people who are new to this space, hopefully this will help you catch on to what's going on here. So it's important to note that medical devices are extremely common in the United States. More than 2% of Americans have some sort of implantable medical device within them, which is truly amazing. The US is the largest medical device market in the world, and it's a lot of money that's involved in this. Another interesting point, though, is that most medical device companies are very small. And I think that that's a really important point as we think about the concept of cybersecurity-informed consent, that many of these groups are really small shops. Medical devices are regulated. So the FDA is responsible for the regulation of medical devices. They have oversight on oodles and oodles of devices, device manufacturers, and device facilities. And it's important to note that the FDA is not the only agency that's involved in cybersecurity. So the FTC and the Department of Homeland Security, among other agencies, each have a piece of the cybersecurity infrastructure pie when it comes to regulation. Oodles of medical devices are also connected devices. So these figures are from this paper on cybersecurity features of medical devices, which was a tremendous paper that was published in 2019. So in 2016, 18% of new devices had software. And that has increased really dramatically over time. And certainly as we think about 2018, 2019, 2020, the percentage of devices which are connected has not decreased over that time. However, the amount of cybersecurity content that's included in those devices, that's disclosed in those devices, is relatively small. So the graph on the top has a different y-axis scale than the graph on the bottom. So you can see increasing number of devices that have software, and then slowly increasing the number that include cybersecurity content. And connected devices have vulnerabilities. So anything that's connected to the internet, whether it's your phone or your watch or your computer or your implanted medical device, any connected device has cybersecurity vulnerability. There is no device that does not have cybersecurity vulnerability that is connected to the internet. This was first highlighted in 2008 and actually influenced Dick Cheney's choice of pacemaker because he was worried about cybersecurity vulnerability. On the right-hand side of the screen, you can see some examples of cybersecurity concerns within the implantable medical device domain. So IMD is implantable medical device. So you can see there are challenges with it, authentication, integrity, confidentiality, authorization. All of these domains each has very specific concerns when applied to implantable medical devices. So there are lots of devices out there on the market. More and more of them are connected. Any connected device has a vulnerability. Now let's talk about informed consent. So it's really important to remember that informed consent is a process, not a thing. So you can't just say, I've signed a paper or I've said yes or no to a question. Informed consent is really a process of conversation between two parties. Planned Parenthood has this fabulous way of remembering the elements of informed consent, FRIES. So consent needs to be freely given. It needs to be reversible. It needs to be informed, meaning you know what you're getting yourself into. In the case of consent in the context of Planned Parenthood, they require enthusiastic. Within the medical context, sometimes the enthusiasm is a little bit muted. That's fine. And it also needs to be specific. So when you're consenting to something, you really need to be informed what it is you're deciding on, and you need to know the specifics of what you're deciding on. And this seems like pretty obvious, but it sometimes gets lost in translation when you get into a medical context, and certainly when you start to think about connected medical devices. So informed consent in medical care and research has those same properties: specific, informed, voluntary, and reversible. It's been described by a lot of very famous statements in the ethics community. For example, the Nuremberg Code and the Declaration of Helsinki and the Belmont Report, all of which were seminal pieces of ethics literature that pointed out the requirements for informed consent within medical care and within research. Informed consent is also mandated by law. So within the United States, here are some of the specific codes and specific agencies that require informed consent within the medical care and medical research setting. The quote on the right is actually from one of the first decisions in the United States around informed consent. In this case, in New York State, there was a case of medical negligence because a surgeon had not properly informed the person that they were operating on about the potential outcomes of what might happen to them when they received treatment. So we have a long precedent, more than 100 years of precedent in the United States legally for informed consent in the medical setting. So this is a really busy slide. What's important to know about it is that we're not good at informed consent. So although we know informed consent is really important in the medical context, we're not really good at it. So if you look at the green box, what the green box is pointing out is the number of studies that have looked at informed consent that have shown that the people in those studies had adequate understanding of key components of informed consent. For example, 6 out of 21 studies showed adequate understanding of the information being given in the informed consent process, which is about 29% of the time. And then you can go over to the yellow box. That's the moderate understanding. And moderate in this study meant that 50% of people to 79% of people got questions right around understanding the information. So most people fall into that bucket. And then you can see a really large percentage of people fall into the inadequate bucket, meaning that they understood less than half of the information that was given to them. So although we know that consent is important, the practice of informed consent in medicine isn't very strong. That's a problem, obviously. One of the reasons is literacy. So informed consent documentation in medicine tends to be written by lawyers. And lawyers, although well-meaning, don't necessarily write in language that everyday people can understand. 1 in 5 Americans read at or below the 5th grade reading level. 1 in 3 Americans has basic or below basic health literacy. And as we all know, stress, anxiety, pain, depression, all of these things can lower our reading comprehension and our reading ability. And that's what we find in the medical context. So if you're going in to see a doctor to get an implanted medical device, highly likely that you're either stressed, anxious, in pain, or depressed about this medical need. And so that will really impact people's ability to understand what it is that they're getting themselves into. So it's important for us to know about the limitations of informed consent as we think about telling people about the cybersecurity vulnerabilities of medical devices. Fortunately, innovation in informed consent is happening right now in research, which is tremendous. So my group at Sage Bionetworks, which is a nonprofit open science organization, has been working on creating electronic informed consent processes, which are visually engaging, which distill the information that's being given, and allow people to navigate through at their own pace. The All of Us research program, which is a massive research initiative, has done some incredible work, innovative work with informed consent. They wanted to enroll a really diverse patient population into their study, and so they really put a lot of the time and attention into their informed consent process. It's written at the 5th grade reading level. It includes little videos to help people understand, and there are get help buttons along the way. So although the state of informed consent hasn't been so good up until now, there's a lot of work that's being done right now to improve informed consent. And what we're finding, and here's some more information about the All of Us research program's informed consent. But what we're finding is that this effort is paying off. So in that study that I showed you with the green, yellow, and red boxes, they said only 1 out of 15 studies showed it adequate understanding that participating in research is not the same as receiving medical care. So one of the questions, a quiz question that's posed to people after they complete the All of Us informed consent process is, what's the purpose of All of Us? And one of the question answers is to give medical advice and treatment. And you can see from this graph, more than 90% of people, regardless of their educational attainment, were able to correctly answer the question that the purpose of All of Us is to help scientists make discoveries about health. So our innovation is working, which is great. So the state of informed consent hasn't been so good. We're working on ways to improve it. It looks like those efforts are really starting to pay dividends. So how does this all come together when we start to think about cybersecurity informed consent? All right, so cybersecurity informed consent is a combination of ethics and engineering in medicine. So you need to take all the ethics folks' knowledge and all the engineering folks' knowledge and put it together. So the cybersecurity of medical devices and informed consent together is this concept of cybersecurity informed consent. It's an informing interaction for patients who are getting a connected implantable medical device. The purpose of cybersecurity informed consent is to tell the patient about the cybersecurity and its implications for their soon to be implanted device. So we're trying to inform people about the device that they're getting. So when we think back to the principles of informed consent, one of the things is that it has to be specific and it has to be informed. So people need to know what it is that's happening to them, and they need to understand some of the specifics of what's going on. Cybersecurity informed consent is not yet federally mandated. So there's no guidelines for how it should fit into workflows or what topics should be covered or how they should be addressed. And for now, we're just focusing cybersecurity informed consent on implantable devices because that seems to be, let's say, one of the areas of most urgent need. So if you're getting something put inside of your body, understanding its limitations and risks is really, really critical. We created a straw man or straw person diagram of how cybersecurity could work within a current clinical workflow. The idea would be that a person comes in for their pre-surgical visit. So when you have a surgery, usually you come in a few days before to have a medical checkup to make sure everything's good before your surgical date. At that visit, patients could be told about cybersecurity, informed consent, and then they could take the time to navigate themselves through a cybersecurity informed consent process. So on the left-hand side, you can see here, a person comes into the clinic some number of days before they're getting their implantable device. They have all of their pre-op activities. And then in the third step, they make sure that they have this cybersecurity informed consent completed. After the pre-op appointment, the idea on the right side here is that the patient would self-navigate through this cybersecurity informed consent. So walk themselves through a digital informed consent, like the ones that we have been using in the All of Us research program and in other innovative research efforts, telling people about cybersecurity and how we keep you safe. And then the patient can ask questions, and then they sign off on it, and then they're ready to go for their implantable device. So Jeff, Andy, and Christian and I put together this straw man document to sort of prompt people to think about, would this actually work in clinic? We thought about this workflow specifically because we wanted to capitalize on each group's strengths. So the people who know the most about the cybersecurity of the devices that are getting implanted into people are actually the manufacturers themselves. And so if we could create an informed consent process that the manufacturers themselves contributed to, then we might have one that has the most accurate information. The time is most limited on the day of surgery, and people are also the most worried on the day of their surgery when they're getting an implanted medical device. And so making sure that that consent happens in advance so that people can ask questions and take the time and not feel the stress was one of the thoughts that we had in designing that straw man document. We also noted that most people get their information online these days, although there is a digital divide. People who are older and in more rural areas tend to be less connected. So an online process might not work for everyone. And also then doing things from home gives people time to think and talk to loved ones and come up with questions. So this was our rationale for designing this original straw man document. We have received a lot of critique on it, which is tremendous, actually. So we've shared this at the Cyber Med Summit in the fall last year, and with a number of different groups of people, including folks from the FDA and a working group that we've convened of doctors, manufacturers, hackers, and ethicists like myself. And so here are some of the critiques. So doctors are used to being the sole source of informed consent for medical devices, for all medical care. And so many of the doctors that we've talked to have felt a little bit nervous about having patients navigating a device manufacturer's information around cybersecurity. Patients are also used to getting or doing informed consent with their doctor. So this would be a different step for them. There's also been the critique of, if there's no federal mandate, why rock the boat? To which I would say there's an ethical mandate for people to be informed. So we're rocking the boat. Another critique is that cybersecurity is moving so fast. How can we make a cybersecurity informed consent process that's still relevant after 3 months or after a year? Any informed consent process for medical care needs to go through an ethics review process and a legal review process at the hospital where it's being used. And that process takes time. So we can't be constantly changing a cybersecurity informed consent process, even though the field of cybersecurity is always evolving. There's concern about cybersecurity informed consent disincentivizing people from getting connected devices. So although we know connected devices, connected medical devices can really truly improve care, people may be nervous about the vulnerabilities and may want not to get connected devices, which physicians, doctors think that would be really bad. People have asked, do patients really want all of this information? There's some empirical evidence that suggests that yes, absolutely they do. And certainly when we look at the informed consent literature, patients want to know what's happening with their bodies. Sometimes implanted medical devices go in emergently, and so consent after the fact. So that plays with our proposed workflow a little bit. And then there's the question of who's the responsible party. So is the doctor responsible for making sure the cybersecurity informed consent happens? Would it be the manufacturer? Would it be the hospital system? Who's responsible for what? So these are all really, really good critiques. And we are so happy to have received them and to be working with them to improve our model to come up with a second version. One last point that's been raised as a critique is the probability of risk. And the probability of risk, I think, is really an important point for us to address here. So usually we think about risk in two dimensions. It's probability and its magnitude. So the probability of harm occurring as a result from participation in a research study or participation in medical care. And federally defined minimal risk is when the magnitude of anticipated harm is not greater than ordinarily encountered in everyday life, right? So it's all about probability of harm and magnitude of harm. But probability and magnitude aren't such good measures when it comes to cybersecurity, right? So if you lived in South Africa, this sign might not prevent you from swimming because sharks are sighted there every day. But if you lived like me on the shores of the Great Lakes of the United States, you might see a sign like this and say, oh my gosh, the apocalypse is nigh. We're not supposed to have sharks here. So Suzanne Schwartz put together this slide and she presented it at the CyberMed Summit last fall. And I thought it was just a spectacular slide, looking at the exploitability of devices and the severity of patient harm if exploited. And so this was her reframing of risk. And I think that this is something that's really salient to cybersecurity informed consent. So we're not really looking at the probability of patient harm, just is the device exploitable and how bad is it if it is exploited? And so when it comes to a implantable medical device like a pacemaker, you can imagine that if the device was exploited, it could have catastrophic impact for the person who had it because their heart wouldn't be receiving the signal to keep it on rhythm. So even if the device is not very exploitable, if it still has it could have catastrophic implications for patients. And so for this reason, we're really thinking that cybersecurity informed consent is important because people should know what cybersecurity is, understand what device manufacturers are doing to control for that risk, and also be reassured that their devices are at the highest standard of security and that they're constantly being looked at by groups like those of the Biohacking Village. So really this sort of brings it all back to the mission of the Biohacking Village, this little ethics side project that we have going. So our next steps are to make a mock-up of cybersecurity informed consent. So what would it look like if a patient was navigating this cybersecurity informed consent? What kinds of information are we going to tell them? How are we going to tell it to them? And then we want to try it out with one or more devices in one or more clinics. And so we've convened a group of people to help us work on this. And I want to thank all of them. We have a huge group of working group members. We also were graced with the free and excellent labor of Duke University capstone students who helped us out. Folks from the FDA have given us comment on our proposals as we've been going along, and we would love for you to join us as well. So if you're interested in joining, please email me. There's my email address, or send me a direct message on Twitter, and I would be happy to include you in our group as we move forward. And with that, I want to thank the Biohacking Village and the Device Lab at the Biohacking Village, and hopefully next summer we'll all be together in Las Vegas again so that we can see beautiful things like the flowers in the Chihuly glass in the Bellagio. Thanks, everyone. Welcome.
Okay, so we are live. Thank you so much, Meg, for that fantastic presentation. Once again, if you do have any questions, please ask them in Twitch or YouTube or Discord. Once again, JR will be taking over to help with the Q&A. So with that, JR, off to you.
Thanks, Sydney. Thanks, Meg, for that really important talk. You actually shook off a lot of questions here in our Twitch. Snoochie Boochies has a couple of really great questions, and the feedback we're already getting is people really enjoyed that presentation. First question, Snoochie Boochies. You mentioned that a lot of medical device firms are small players and perhaps understandably immature from a cybersecurity and privacy principle perspective. Is it fair to say several large medical device manufacturers are also immature? Would you care to speculate, and why?
So I think that we in the Biohacking Village have been so fortunate to have the participation of a number of large medical device manufacturers who I think they're all starting to drink the Kool-Aid and starting to recognize how important cybersecurity is. Which is not to say that anybody has it exactly right yet, but we are on this journey together. By highlighting that there are a number of small players, I think what I wanted to point out is that there's a real diversity of experience from people who have cybersecurity professionals working with them right alongside them as they develop these connected medical devices, to folks who come at it device manufacturing from let's say a more traditional or old school perspective, and are just as surprised as maybe the average bear is about cybersecurity vulnerabilities for connected devices. So there's a diversity of experience, and then these firms may have fewer or greater resources available to them to address cybersecurity or cybersecurity informed consent themselves. So I think really what I'm trying to say is that this really needs to be a collaborative effort between manufacturers and clinicians and the patients that they serve.
We have time for 2 more questions.
Thank you. This question comes from YouTube. The question is from Andy. Meg, you mentioned you're doing more research on CIC. I hear you have a survey you're looking to have people fill out. How can people learn more about your working group and your survey?
So I would encourage people to send me a direct message on Twitter, or to use my email address, or to reach out to me at any point during the con using any of the different platforms that we all are on. And then the survey is something that actually is just gotten approved, which is really trying to understand people's attitudes towards a proposed cybersecurity informed consent. And hopefully we'll be able to share that link out shortly with everybody in within the DEF CON discussion space for the Biohacking Village. So thanks for that, Andy.
One question from our DEF CON Discord from Elix. Has there been any thought or accounting for manufacturer pushback resistance to protect their IP or device sales?
So we've had actually really great participation of device manufacturers in our cybersecurity working group so far. I think that the cybersecurity informed consent will be sufficiently broad that we will not be disclosing any proprietary information because of the time associated with developing an informed consent and getting it through all of the legal and regulatory hoops that it needs to go through. It can't be as granular as perhaps those who are steeped in cybersecurity and engineering might imagine. It will need to be more sort of a general statement about risks and benefits of connected devices. But no, we haven't experienced any pushback so far.
Okay. Well, thank you so much. Unfortunately, we are out of time. So if you do have any additional questions for Meg, please reach out to her on Twitter. Her Twitter is just a little bit below. Otherwise, you can connect with her on the DEF CON Discord, and link is just below. But with that, thank you so much, Meg. Fantastic talk.
Pleasure to be here. Thanks so much.
My name is Bill Doherty. I'm the CISO of Omada Health. Joining me today is Patrick Curry, our Senior Director of Compliance. And today we're going to talk about threat modeling in digital healthcare. Patrick and I are the co-authors of the Includes No Dirt threat model, which we'll be discussing today. If you'd like to follow along with us, you can go to includesnodirt.com and download our white paper on that threat model. We've also got some specific exhibits that we've created just for this discussion. That's at includesnodirt.com/defcon.pdf. And thank you for paying attention and watching our talk here today. Standard disclaimer, we have put together a discussion that is based on some real-world concepts, but this is not a real-world situation. So any information we share today should not be construed as being related to the products or services of our employer, Omada Health, or any of our partners or our customers. Now, if that's out of the way, we can dive into it. A little bit of background on us. Omada Health is a digital healthcare company. And what is digital healthcare really? It is the combination of technology and clinical expertise and humans to deliver better health outcomes. And we've been doing this for about 9 years now, I think. And we really focus on digital care made human. So it's not just a machine that you're interacting with. We do it a little bit differently. What we do is we try to partner up devices, applications with remote monitoring, and specialists who can provide assistance in our specific diseases to help improve health outcomes. And we do that through behavior change, remote monitoring with digital devices, care delivery, lab diagnostics, medication tracking, and a whole bunch of back-end systems that are necessities in healthcare, like outreach to patients, enrollment and eligibility, billing and reporting. That's all of the messy stuff behind the scenes. We have 4 diseases that have been kind of our core, which is type 2 diabetes prevention, type 2 diabetes treatment, hypertension, and last year we added behavioral health, so treating anxiety and depression. Recently, we just bought a company called Physera that does digital physical therapy, so for musculoskeletal or pain treatment. So that's us. We're going to talk today a little bit about Sam. Sam is representative of a real participant in our program. She is not real, but Sam would be a participant who has type 2 diabetes and is using our program to try to better manage her disease state. And she does that through tracking her blood values. That information gets shared with her coach. Her coach is then giving her advice on meals and exercise and potentially talking about her insulin levels, things like that. And ultimately what we're driving towards is behavior change. We're trying to give our participants lifestyle improvements that will help them better manage their chronic diseases. And we're going to come back to Sam and how she's managing her diseases in a little bit in the context of a threat model. But this is what Omada does. We do whole person healthcare. And we do this with connected devices and lesson plans and coaching and all kinds of stuff. And we do a lot of it. We have, since our inception, served more than 350,000 participants. We have over 1,000 satisfied customers, and one of the largest data sets in behavioral health. As of last week, we had over 80 million weigh-ins from our digital connected scales. And our participants really seem to like our program. We have a 92% CSAT. So that's enough about Omada. We shared that with you because we want you to understand who we are and why we came to do this. So why should we do threat models? Patrick and I started this about 2 years ago. In healthcare, we are required to do annual risk assessments. The problem with that is nobody ever tells you how. And we've been doing them for a couple of years, and we decided that we needed to up our game. And the reason we needed to up our game is because we were doing kind of a typical risk assessment process where we'd sit in a room and we'd just think about things that could go wrong, and then we'd assess our risks. And the reality about all things in security and compliance is everybody's got a plan until they step into the ring and the first punch comes. And then your plans go to hell. And we knew we had blind spots. And we wanted to get rid of those blind spots. I love this cartoon, by the way. On the left side, this is typically how we would deal with things in healthcare. We're going to encrypt the laptop because HIPAA says that all the data has to be encrypted at rest. And then what would actually happen is somebody would force us to reveal our password anyway. Every time we give a talk on this, we update this slide, and sadly, I'm never out of companies that have had major breaches in the last 6 months to update. But these are examples of really bad things that have happened. Healthcare is by far the #1 most breached industry, but everybody gets breached. And the underlying factor for all of these companies is they all had really, really good, smart security teams that were working really hard, that had lots of controls and lots of vendors and lots of stuff in place to try to protect their systems, and yet they still had problems. And the reason they had problems is because they had blind spots. And so threat modeling is a way to try to eliminate some of those blind spots. And the fundamental truism in our business is nobody ever says thank you for the work you did to prevent the disaster that never happened. So there's no A for effort here, but doing threat modeling and doing them consistently will over time improve your security and your compliance and your privacy. And it is by far the right thing to do. So let's define it a little bit. In order to really talk about this, we have to have a taxonomy. We have to all be using the same language. Lots of people interchange the word threat with risk. We do that too, accidentally, but we had to come to a common language. And when Patrick and I were working on this model, we were using the same word to mean different things. So we eventually wrote it down. This is our taxonomy. First thing is a system. And a system is anything you want to model. Lots of threat modeling focuses on applications, on software, and that is certainly a system that can be modeled, but so can a business process or a network or a vendor. And the defining characteristic of it is we want to protect it from specific threats. We just did our annual risk assessment and this, just completed it. And this time around, we modeled 26 business processes end to end. So systems typically have defined borders. You know what the entry point into the system is, you know what the exit is, and you can then model it for threats. Those borders are sometimes called trust boundaries, which are areas where principals can interact. Sometimes they're called attack surfaces. The key point is understanding all of the areas that an attack or a risk or a threat can come from. Vulnerability is a weakness in your system. Vulnerabilities are things that can be exploited. So if you have a weak password policy, that is a vulnerability. It can be exploited. If you leave your front door unlocked, that is a vulnerability. That doesn't actually mean that someone will breach your password or open your door, but it is vulnerable for exploitation. A threat is an actor. A threat can be a person, it can be an employee of a third party, it could be its own business process, it could be a piece of code. And threats exploit vulnerabilities, and we call that an attack vector in our taxonomy. Risk in this world then is the bad outcome that results when a threat exploits a vulnerability. And we can then measure risks by measuring the likelihood of it happening, that's the probability, and the impact of it, or the cost if it does happen, that's the impact. And that's typically how people think about risks, is you'll see this often, people trying to measure the impact by putting a dollar amount on it and a probability, and that gets you to an adjusted risk score. And then we talk about inherent risks and residual risks, and that's often how risk assessments are done. In our taxonomy, controls are things we do to reduce the probability or the impact of a risk. So if your door is unlocked, that is a vulnerability. The key and lock is a control, and you can lock your door. That doesn't necessarily mean that nobody will open your front door. It just has lessened the probability of it. It might have increased the impact, by the way. So controls have, there's no panacea to them, but we do need to model what are the risks and then what are the controls, and when we do that, we can then figure out what are the residual risks. Threat modeling is just an analysis. It's a way of systematically going through and looking at vulnerabilities and controls and threats against a defined list of risks. And defined list of risks is really important because we can sit around and talk about every bad outcome under the sun. A meteor may strike the planet, but that really isn't a risk we're going to try to go model as threat modelers. And then lastly, action items. This is the result. This is what we're trying to get out of a threat model, is we've looked at all the bad things that could happen, we've measured the probability impact, we've assessed the controls we have, and then now we've got a whole bunch of work that we want someone to go do to reduce the risk. And we're going to reduce the risk by creating new controls that either reduce the probability or the impact. So that's our taxonomy.
If I can add to that while you change slides on that, one thing that was super critical for us is just exactly that taxonomy. Coming from different disciplines, from IT security and from healthcare compliance, we spoke very different languages when it came to risk and threats, and realizing that reconciling that and making sure that we had a consistent discussion was really important for us to be able to make breakthroughs on this. So if you decide to adopt this model and go forward with it, don't underestimate how important it is to create that taxonomy when you're speaking to your risk organization or your compliance team or your privacy office. Getting on the same page is really important.
Absolutely. I could not agree more. And thank you for jumping in so I could take a drink. We would love to think that we were the inventors of all threat models and the geniuses who wrote this down. The truth is we're not. There are lots of very, very good threat models out there in the ether, and we borrowed heavily from them. And so we wanted to walk you through some of those traditional threat models so that you would have these resources available to you to go do your own research and hopefully take what we've done, take what these other people have done, and apply that into your own business, whether it's in healthcare or any other. So our starting point was this wonderful book here by Adam Shostak. I think he may be talking at Black Hat or DEF CON this week on threat modeling. It is fantastic. If you don't own it, I highly recommend it. He didn't pay me to say that. And we'll talk a little bit more about what's in that. But that's really on the software design standpoint. On the privacy design, there's this model called Linden, and again, it's excellent. So Adam's book largely focuses on the STRIDE threat model. This is something that came out of Microsoft, and this was a way of getting software engineers to assess the major threats to applications, and they had it narrowed down to really 6 areas. So spoofing, so somebody illegally accessing an application; tampering, somebody modifying the data; repudiation, somebody performing an act and we couldn't figure out who it was; elevation of privilege, somebody gaining credentials that they shouldn't have; denial of service, shutting it down; or information disclosure, which is what Patrick and I worry about a lot, which is breaching information. That's the STRIDE model. It's excellent. Please go read about it. If you haven't already done so, get Adam's book. On the privacy side, the Linden model is also excellent. And when we started researching this, what became really apparent to us, and we'll talk more about this as well, is that sometimes privacy and security are polar opposites of each other. So in the STRIDE model, we're worried about repudiation. Can somebody do something and then deny they did it? In privacy, we're worried about non-repudiation. Can I do something anonymously? Okay. And so we borrowed heavily from the Linden model as well. But there's some other models out there that are also good. Bruce Schneier wrote extensively about attack trees. Attack trees is one way of brainstorming where you start with an objective, like I want to open a safe, and then you walk down a tree of all the ways you would do that. So how could I learn to open the safe? Well, I'd have to learn the combo. That'd be one way. Or I could cut it open. And to learn the combo, how would I do that? And you walk down that, and then you start figuring out what is possible, what's not possible. And then once you've done that kind of a model, you can then insert controls in there to break up the attack tree. Kill chains came out of the military. And again, it's a way of modeling what needs to be done for somebody to execute an attack. And if you interrupt any step of the kill chain, you can impact or possibly prevent the attack. Both excellent models. Security scorecards. Security cards. These came out of the University of Washington. This is a way of training threat modelers on how to do threat modeling. It's actually a deck of cards, and I have a deck that's at my office that's under lockdown from COVID. But it talks a lot about motivations and resources and methods, and it's really just a training mechanism, but they're worth checking out. And there are a ton of other models. I found this white paper from Carnegie Mellon on threat modeling. It's excellent. I highly recommend the PASTA model just because I like the name. But there's lots of models out there, but none of them really fit what Patrick and I wanted to do, which was We wanted a single approach that we could look at our software applications and our vendors and our business processes and deal with all of the intersections between compliance and security and privacy, and ultimately reduce the risk of our organization. Lots of people do brainstorming. Brainstorming is the simplest form of threat modeling. It has its place. We do it too. But it also has its limitations. And we said earlier that we don't model everything. We model the things that are applicable to our system. And this is kind of a typical traditional threat model. We talked about SAM earlier. We're going to talk about SAM again later. But this is a situation, a diagram of how a continuous glucometer or a wearable glucometer might work, might interface with our company. And we draw this on a whiteboard and then say, okay, if we were going to attack this, how would we do it? And everybody starts drawing things, and we say, well, I'd do a man in the middle of the application, or I'd do a denial of service on the API, or I'd do a breach of the partner, or I'd figure out some way to hack the device to harm the participant. And that is one way of doing threat modeling, but it ignores lots of things. It ignores the motivations and capabilities of the attacker. It ignores the objectives of the system. It also ignores all of the controls we already have in place, because we've already done things like we've got TLS written up here. That's a control that we encrypt the traffic. So we want something that doesn't ignore all that and is a little more structured than just a couple of smart people and a whiteboard. And threat models done via brainstorming, they're limited by your imagination, and failures of imagination lead to blind spots. So this was the problem we were trying to solve, and now Patrick is going to talk about what we actually did, and specifically the includes no dirt model.
Yeah, exactly. Thanks, Bill. So exactly, that's what we were trying to solve for. There's a lot of dimensions to that. I think the one comment I would make on the brainstorming thing, and I think we've seen this before in prior practices, if your thoughts are limited, or if you don't think of something, you don't actually expose that in your conversation. So what this process actually allows us to do is force us to think of things that may not be top of mind when we're actually doing the work. And that regimentation and that process actually drives us to that one. Okay, next slide. So what we were looking for in coming up with this process, something that was easy for a non-SME to understand, something that we could and something that would be easy for someone to perform. So something that we could give to a non-expert, say someone on my team or on the privacy team, and have them not only understand what we were after and what we were trying to do, but actually something that they could deliver and run through in a fairly short amount of time. We wanted something that was flexible and repeatable, something that we didn't have to shift every single time that we did the questions, and something that we could do over and over and over again. We wanted something that was usable anywhere. We didn't want to have to design something that was great for business process, but really crappy for IT structures or vice versa on that. And of course, since we were putting a lot of effort into this, we wanted it to be memorable, because why not when you're building it? And some creative uses of anagram generators actually got us where we are. So next slide. So what we created with this process, it's a systematized approach to analyzing risks. That pays a couple of different dividends. One is it's systematized and it's easy to execute, like we were just discussing. It's also, interestingly, started to be a key for us to explain how we think about risks. So it structures educational conversations when we have them with staff so that they understand what we're trying to do. It's a repeatable process with objective scoring. So another huge win there. Something we can do over and over again, sometimes on the same system, to see changes or see how things have evolved. And it gives us an objective score with some weights that we're going to see in the example we'll show you that help us compare across risks or across even domains in what we're looking at, how we think about risks and what do we do first. There's never enough time, there's never enough resource. How do you focus your time? We wanted a system-centered approach. So something that isn't really focused on the thing that you're modeling, but something that actually, or is focused is on the thing that you're modeling, but not on the process itself. we tried to kind of bridge the gap between, say, having a Stride and a Linden for different things and create something consistent. Bill mentioned we focused on established controls, and that's really important. If we've tested the control already and we're sure it works, and in our audit practice we know it's actually running, then we don't actually have to include it in the model. And in the example we'll show you, we've gone through a few things and eliminated it because they either don't apply or we know that it works. Lastly, we wanted to have a model that covers all of the domains we think are important: privacy, security, and compliance. So not having 3 different models or 3 different versions, and being able to include different regulatory regimens. Next slide. All right. What we created with Includes No Dirt, the model that we have, your mileage may vary on this one. We designed it for our own uses at Omada Health. And if you're in the healthcare space, it may be directly applicable with the questions that we have. You may have to swap out some of the specific regulatory questions. If you're in an adjacent industry, it may need some questions adapted. Please, by all means, take the questions and modify them to your own use to target exactly what you're trying to get to. Next slide. All right, at long last, the teaser. It is the Includes No Dirt model, and it has been arranged to actually be memorable. So identifiability, non-repudiation, clinical error, linkability, unlicensed activity, denial of service, elevation of privilege, spoofing, non-compliance to policy, overuse. Specifically there, we're thinking of overuse of information and data as really pertains to the HIPAA space that we're in. Data error, information disclosure, repudiation, and tampering. So all those parts play together to make the model that we're using. Next slide. So for every risk, there's a property and a goal, and it comes from a specific place. So if you skip down a couple, clinical error. The risk is clinical error, a clinician making a mistake that may otherwise have been prevented. The property or the goal of that is the application of correct clinical standards. So making sure that the clinician both knows what they're doing and actually can do them at the moment in time where they actually need to do it. That's in the realm of compliance. And we've sorted on this slide the specific things as to what the goal of what we're trying to do is and where it comes from. Next slide. Now, you may have noticed that some of these things overlap, and that's where proper judgment by the risk assessors as you go through this is important. And I don't think I can say that enough strongly in the title slide. The risks that apply depend on the system being modeled. So some of these you'll have to look at what you're trying to do and figure out, does this apply, does this not apply, how does it apply? And some things you may just factor out as you go through it. So these 3 in particular are complicated because they are very related, and Bill alluded to it at the beginning. Security and privacy sometimes are at opposite ends of what they're trying to do, and these tend to reflect it here. So identifiability, the property of a system that allows users to trace to a specific user. So there, the objective or the goal is anonymity, making sure that that's not actually possible. A risk of non-repudiation, the process by which it's proven that a user took an action. The goal there is plausible deniability, so that it isn't clear if someone did something or not. The risk is repudiation, and here what we're trying to get to is non-repudiation, so where someone can actually show that it actually hasn't happened yet. So these of note actually came from different parts, some from Stride, some from Linden, so privacy and security blended together. On the next slide, or the next couple, we'll actually kind of unpack that a little bit. So deconflicting these goals can be kind of complicated on this. Different stakeholders will have different needs for these things. So for example, with anonymity and identifiability, that risk and goal, there are some times where you're building a system where that absolutely is required. We've got a whistle here for a whistleblower. If I'm designing, for example, a software application that holds anonymous reporting for whistleblowers, because that's required under healthcare compliance rules and other codes as well, anonymity is really important. But then for other goals and other people in the system, less important. So a hacker, for example, they're in the middle, really relies on plausible deniability, that for what they're trying to do, either ethically or otherwise, making sure that there's that deniability is part of it. Repudiation and non-repudiation as well. Let's get into a little bit more of a specific example on the next slide, though. So let's say human resources wants to build or wants an employee complaint application that lets employees report sexual harassment. Lots of different goals, lots of different stakeholders, and figuring out how to balance between them gets really important. So employees want to be able to report and if they want to have anonymity, that their anonymity is protected. So if they want to say something anonymous, they can, and no one will know who it is. Well, HR wants to help ensure anonymity, but also wants to make sure that there's less of a possibility of abuse in the system, that like you don't have one person anonymously reporting the same thing over and over again to drive a larger impression. IT needs to provision and deprovision administrative access to this, but they have absolutely no need to see the complaints that are registered. Security runs DLP on every laptop, logs who has access to the application. Important from a security perspective, but then that becomes potentially challenging depending on the level of access and the fact that if they're provisioning it and they log who accesses, they have a proxy for who's actually reporting things. The legal department wants to be able to document complaints and collect evidence to take action, which is somewhat the opposite of anonymity. It's hard to take action and have a cause that comes out if we don't know actually who did something. So you have lots of different people running the system, running in the system with different needs, different roles, and those roles will conflict. So we can't completely make everything anonymous because then security and IT can't do their work. Legal won't be able to document complaints, and the harassment, if in fact it is actually occurring, will keep continuing because there's no way to investigate it. So all of these parts play together and need to be balanced in the work that you're doing when you do the modeling. All right, I think it's back to you.
All right, so let's give it a try. Time to come back to Sam. So Sam is a typical patient with type 2 diabetes, and she's been using for years a blood glucometer, which means she's constantly pricking her finger, taking blood readings. We know that she would benefit from having a continuous glucometer, that she is a wearable and that is automatically sending readings to her coach so that we get greater telemetry so that we can respond quicker. So we want to introduce CGMs into our product set, but we want to do it safely. So what Patrick and I did is we filled out an includes no dirt threat model on the concept of a CGM to try to help us figure out where we need to pay attention. Okay, and again, you can download the one we've filled out at includesnodirt.com/defcon.pdf. Highly encourage you to do so. We talked about brainstorming. The includes no dirt threat model, we've included a structured brainstorming worksheet that allows us to go through a system and kind of helps guide where we go. So again, I'm going to come back to, this is our diagram. In our diagram, we have a wearable glucometer. That glucometer syncs to an application on the patient's cell phone, which then transmits the data to the partner. The partner then sends it to our endpoint, and it gets stored in our database. It then sends information back to our application. It also surfaces that information to the coach. And you'll see here that in addition to the CGM, the participant still has a BGM. So still does the occasional finger sticks, and that information is also being sent to us. So we've got two sources now of blood sugar data. Okay, so this is the diagram we're going to be working off of. In our worksheet that we provided you, it's highly structured. One of the first things we do is we mark which threats we think apply. Who are the actors that are involved here? So certainly the participant is involved in this whole process, and the coach is involved, but we've got a vendor. We've got potentially other partners. We're going to be doing claims on this and billing. We're reporting. So there's business processes, there's people. For this one, we're not so worried about natural disasters. We're not so worried about geopolitical unrest. But other threat models, those might come into play. And we then do some brainstorming on vulnerabilities. So what are areas that could be vulnerable? They get an incorrect reading, or the service becomes unavailable, or the coach misinterprets the data. Now, up in the right-hand corner there, I've got a little diagram where I show the questionnaire and also the structured brainstorming. And this is an iterative process. We sometimes start with the questionnaire, and we sometimes start with the worksheet, but it's typical when we are doing one of these on a complex system, we are going back and forth. So we'll be going through the questionnaire, which is highly structured, and that will trigger us to go, oh, wait, because we've said no on this question, we think that there's a vulnerability there. Let's go write that down on our worksheet on vulnerabilities. Let's go ask somebody to get more information. And we go through this process until we think we've got the questionnaire complete and the worksheet complete. Okay? And so we did that. And when we did that, we were able to take those vulnerabilities that I've listed here. There's 5 of them in our example, and we're mapping those to specific areas in the includes no dirt model. So you'll see like anonymity. We don't want anonymity. It doesn't apply in this one, but clinical error certainly does, and denial of service does, and spoofing does. So in the interest of time in our presentation, we're not going to go through all of our answers for every risk, but we're going to go through the answers we did for the risks that apply and talk about why they apply. And again, you can download our example and see our answers on all of them. So the factors that do apply are clinical error, unlicensed activity, denial of service, spoofing, non-compliance, data error, information disclosure, repudiation, and tampering. These are the things we're worried about in this particular threat model. So, Patrick, let's start with clinical error.
Sure. So what we did in this one to make it a little clearer is for the next few slides, on the left side of the slide is a snapshot of the answers. And all of these answers are in the materials that we put on the Includes No Dirt website under the DEF CON link. On the right side, we've clarified a little bit about what these actually mean in the context of the CGM work that we did for this specific example. It can be a little hard to read through those, so we've pulled out what we think the important answers are. So here for clinical activities, what we're thinking about in the specific example of this continuous glucose monitor is, are we doing something that relates to the treatment of a patient? Well, of course we are in this particular example. So the specific question that we probe into here is, does this system or process, does this combination of things have either inbuilt controls that prevent something from happening in the first place, or other review-based controls that can, if something does happen, we'd be able to find it and correct it as quickly as we can? So answer here, yes. And it's a little complicated because it's both CGM, both a device that is created by a partner of ours and software that we create for our coaches to be able to use that information. Each one of those has specific detective and preventive controls that operate in its own environment. And this is a great example of what Bill just said related to the iterative nature of this. When we hit this question, it's like, okay, wait, that's both the device and the software. How does that work? And we had to fork a little bit, came back, yep, that's exactly right. In questions 3.2 and 3.3, we delved down a little bit into some additional control work. And another thing I would say here is, not all controls are technical. In this particular case, with clinical error, part of preventing clinical errors is ensuring both the proper training of your clinicians. So being able to say, yeah, everybody that has access to this was properly trained, has I almost said licensure, that's coming soon, and that the delivery and the quality of the delivery is important and up to the standards we set in our clinical practice guidelines. So that becomes a review process and a quality check that our clinicians will do on the staff to make sure by reviewing their output that things are going the way we want it to. All right, next slide.
So one thing I want to say before we move to the next slide, you'll see there on the left-hand side on question 3.0, when we answered yes, it gets 1 point for that. If we'd answered no, we can skip the rest of the questions on clinical and move on to question 4. So those two things are really important. At the end of this, we're going to total up all the points, and that will drive a risk score. But being able to skip a whole bank of questions when they don't apply means you can go through the model much faster. So for simple systems that don't involve clinical, don't involve patient activities, we can maybe model them, as we said, very quickly, like 15 minutes. For something that's complicated, and it would be a fairly complicated one, it might take us several hours. But the model fits whichever size and which system, whichever level of complexity we're dealing with.
Oh, definitely. Thanks for pointing that out. That weighting is really important because it helps to also create that apples to apples comparison that we talked about a little bit earlier. Second one, unlicensed activity, and I spilled it a little bit ago just talking about it. Does, in this case, the work that we do require licensure from either a site license or personnel licenses for the people that are delivering care? Just like the last question, yes, it does, and it's complicated because different parts of this thing require different licensure. So the CGM manufacturer requires licensure by various federal and state authorities, and our clinicians internal to us require credentialing to make sure they're able to deliver the coaching that's appropriate for diabetes. So there are national standards for that. Also important here is the fact that we rely on other people in these things. And just like we talked about, if we've tested a control, we know it works, we don't have to bring that into the discussion here. We don't have, we may in diligence and checking acknowledge that yes, our business partners have the appropriate licensure, but we don't have to dig into that to make sure it's as robust as it is. Our contracting processes make sure that those exist. So we use that as effectively a control, and we focus on the things that are important to us, which is our own internal clinicians. I think you're next.
Denial of service. So this is where we start looking about how mission critical the system is that we are modeling. For a connected glucometer, the availability of the entire system is very important. And if any piece of that system is having a problem, the connectivity between the device and the partner and us and the participant isn't working, then it's going to have a significant impact on the effectiveness of getting that telemetry data to the coach, back to the participant, and being able to make decisions on that data. So when we go through our model, we ask, is it a mission critical system? If it is, that raises the point value. And then we look at, have we defined targets, and what are those targets, and how are they enforced? And again, Patrick said not all controls are technical. For the partner, they've got technical controls to ensure their availability. For us, we've got contractual controls where we define an availability target with monitoring and penalties. And that's how we manage the risk on our side. Spoofing. We want to make sure that we are getting the right data, and we want to make sure that only the right people can access that data. And so spoofing as a threat is where we look and model in authentication. And this is a good example of where we can rely on existing controls. So we have defined authentication levels for our participants. We base it on NIST 863B, and they're defined as an AAL level 1. Our coaches are defined as a level 2, which means that they not only have to have a username and password, but a second factor. We test those, we know it works. So as long as the system is going to use those controls we've already defined, we can check those boxes and move on. We don't need to spend a lot of time detailing how authentication for this particular system is going to work, because it's a client of the greater system within our care delivery.
All right. Non-compliance. So Not surprisingly, when we have to address a particular business process or system as a HIPAA-covered entity, there's lots and lots of legal requirements that get attached to something. This is probably, let's call it the worst example of the complexity here, because for this combination of devices and software that we're building, it's everything from HIPAA, privacy policies, the terms of use, both for the device and for our software application. There's a number of healthcare compliance issues. There would be FDA obligations for our business partners, the contracts that Bill just mentioned. So because this is clinical in nature, it relates to a device, there's patient data involved with it. This one's particularly complicated. As I mentioned kind of early on when we were talking about the problems that brainstorming can create, this question is specifically designed to bring up those non-obvious things that you may not have top of mind when you're actually doing it. If you're adapting this questionnaire, certain things that you want to target, definitely adding it to this list is important because, for example, here, terms of use may not have been something I would have thought about, but it has to include what we're trying to include in this specific example. So that was important to kind of drive through that. And this also, if you look down at the very bottom left of the screen, we can also check through the applicability of some of the credentials that we have. We're a SOC 2 and a high trust certified organization. Those apply in this particular case because of the nature of what we're trying to do. Okay, next one I think is mine as well. Data error. So here in this particular example, we're digging heavily into data integrity. And for a medical process and a clinical record keeping process like this would create, so we're essentially creating a part of a medical record on glucose monitoring, glucose management for our participants in the program. It's really important to make sure that this is ingested and maintained in an accurate and viable ways. Again, here, in other includes no dirt models that we've actually done, we've tested some of that. We've tested, for example, the APIs that we do data ingestion with. So we can kind of check that off and go, yeah, it's acting as we intended it to, and move on and focus the mitigation control work that we're trying to do here for other things.
So information disclosure, this is where we're worried about confidentiality of the system. We've got rules within HIPAA, within our customer contracts on how we protect data to make sure that it isn't disclosed where it's not supposed to be. And again, here we're largely consuming controls that we've already tested previously. So HIPAA requires us to encrypt PHI at rest and in transit. So we can ask, are we doing that? And if so, how? And since those are really well-known patterns for us, we can accept them and we can move on. It doesn't actually require a ton of discussion. Down at 12.6, data locality. This is a really good reminder for us. We have obligations to keep all of our data within the United States, processed, stored, and accessed. And so, especially when we're talking about a third-party vendor, this is a good reminder to, hey, let's make sure we know where their data centers are and where the data goes as it traverses its way to us. Repudiation, we've talked a lot about repudiation already. Does it require non-repudiation? Yes. What are those mechanisms? And again, in question 13.3, there's lots of mechanisms that we have in place, but we want to make sure we address them. How are user activities being logged? Do we have accurate timestamps? How long are logs retained? Things like that. That lets us know that this particular system is going to fit into our overall framework. And tampering. We don't want anyone to mess with the data. So again, what are all the mechanisms in place to prevent tampering? Now, for this particular system, there's some interesting tampering things we need to deal with, like the chain of custody of the device between the manufacturer and the DME, and the DME shipping it to the participant. And also, how do we make sure that the device that gets shipped gets assigned to the appropriate patient in our data model? And that's a fulfillment question, because we have to make sure that every device that gets shipped, that serial number comes to us assigned to the correct person. And if we don't, that then makes its way back up to not just tampering, but to data integrity and who has access to it. So again, the model is iterative. It lets us go through it, and it reminds us to check how are all these things being addressed for this. It is a very structured way of brainstorming. And we get to the end, we get a score. Patrick, you want to talk about this?
Oh, sure. Yeah, so as Bill said, as we get to the end and we get a score. So the product of all the numbers that you saw on the side. So for example, when we've weighted the first element as 1, when we're talking about clinical controls in place or not, all of those add up together. And in the particular governance, risk, and compliance system that we use, we can weight the scores. So some are stronger than others. But essentially, the product of that turns into a total score. We can rank that total score as a low, medium, or high, again, to be able to focus our efforts and make sure that we know kind of, is this something we need to address immediately? In the grand scheme of things, is this something we can actually wait on for a while because it's not as critical as other things that we're looking at? On the right side, you actually see the list of action items. You saw that in a prior slide as far as how those work. Here's the specific action items for this one. So for example, for this particular model. So for example, creating clear instructions for participants on device calibration can help with data integrity issues because it's not clear if someone enters data incorrectly, the treatment would apply correctly. So this addresses the clinical vulnerability issue. Backups to BGM and CGM also touches on some of the same issues. Sometimes that's required just because of the nature of the CGM and so forth with all of these. Each one of those action items is designed to address one or more vulnerabilities. And that's part of the process of this is everything that you've identified should have an action item at the end of it to make sure you're hitting everything you need to from a control perspective.
And we've done a lot of these. I mentioned earlier that we launched a behavioral health application, and when we did that, Patrick and I did a threat model, and I think we came up with 19 action items. And those were okay. And those were specific things that we wanted to ingest into the system before we went live. So we did that at the very early stages as we were just planning, which was 6 months before the launch, which meant that we had, as risk assessors, the ability to have a meaningful impact on the security and privacy and compliance of that application before it ever launched. And everybody involved also understood, because they went through the process with us, why. They knew why we had those action items and what was the specific vulnerability we were trying to address.
That latter is very important. You may have groups that, let's just say, are not necessarily as inclined to be helpful when working with the risk assessing organizations. We had, in this particular case, this behavioral health example, some of our developers come back to us and say, oh, we get it now, why this is important, after they'd executed through the process. So it becomes educational as well as helpful, just as a reminder as to why we're doing it.
So a couple of points to wrap this up. Vendor management. The threats you aren't seeing can also kill you. I use this example. This was a letter that Quest Diagnostics sent out about a year ago on a breach. And the important thing about this is not that Quest sent it out, but that they sent it out because one of their vendors had a problem. And that vendor was acting as Quest BAA, but Quest ultimately got sued for this breach. So when you're doing threat modeling and risk assessments, it's important not only to look at your own systems, but your third parties as well. And we use this same methodology, these same checklists, to assess all of our vendors. Now, we have lots of vendors. We are a SaaS first company. We've got SaaS all over the place. When somebody comes to us with a new vendor, and let's say it's a project management tool, we can go through this checklist pretty darn quickly because it doesn't have clinical error and it doesn't require licensure. But when somebody comes to us with a new device vendor, we're going to go through this same model very, very carefully. And so when we use threat models to assess vendors, it's the same basic questionnaire. We're doing our that checklist. We may or may not also do a brainstorming, but we then use that to influence our legal terms. So if we define the vendor is going to be mission critical, well, that means we have to tell the legal department to make sure we have an SLA in the contract. And if we're worried about encryption of data at rest, then we have to include that term in the contract. And we have to assess that vendor to make sure that they are doing things we want. We put legal terms in that say they have to keep our data in the United States, but we then also verify where their data centers are. So this model works for assessing vendors, and it works very, very well.
All right, so when do you actually use this? We've talked a lot about different possibilities for it, and we've got a chart here that addresses a little bit of when to use it. As you can kind of tell from our examples, we use it all over the place. Initiations of significant projects, the behavioral health example that Bill just did, vendor acquisition for the first time, and then annual assessments, both from a risk assessment perspective and from a vendor assessment perspective. Bill mentioned earlier that we did it for 26 material business processes on the risk assessment we just completed. I can't overstate how interesting and helpful that was this year, because traditionally from a compliance and a privacy perspective, risk assessments are really brainstormy in nature. This forced more rigor than I think we'd even seen last year when we did it a little bit closer to this way. And it took out the potential for missing things because you're not asking the questions in a regimented way. And that was a huge win. Resulted in a lot more action items for us to do, but that's a good thing in the grand scheme of things. There's a lot more, because we're aware of it, for us to look at. On demand too, there are times when sometimes from an audit perspective, things just crop up and you think, maybe we should take a look at that in more detail. There's the regimented way to actually look through it. All right. It does exist in a continuum of activity from a risk assessing perspective, and we've got a little bit of the dimensions that we think about it here. So threat model in the upper right, really its best practice seems to be when it's a new process or something that we're encountering for the first time and we have no idea about the dimension of risk on it. So risk unknown in a new process. On the left side, there are things that we have an idea about, like processes that we're actually doing, and either how much we know about it or how much we don't know about it. So on an annual basis, for the last few years, what our risks are as a company are pretty stable. We kind of know the general categories of risk. So we may not necessarily know with an existing product how it shifted over time. Take a look at that from an audit perspective, and these overlap. A threat model, in general, when you're talking about a threat model designs a control, we'll have to retest that control at some point. So that in our world still stays in my universe. That may get handed off to an internal audit group for them to be able to test that control eventually. But it's all related. It does create a completely virtuous circle, I guess you could say, from a control to management perspective.
So final thoughts on all of this. When you are in security or compliance, you're a risk assessing organization, your job is actually to say yes. We security practitioners, we get a bad rap because people think we always say no. Our job is actually to figure out how to enable and empower the business. And so really, Patrick and I firmly believe that it's our job to say yes safely. And one of the ways we can say yes safely is to go through a regimented process of assessing risks and then coming up with action items and say, yes, it's fine to bring this new vendor on, it's fine to do this new process, but here are our recommendations for the ways to harden it, to improve the security and compliance and privacy of that system. And with that, thank you for listening to us. It's been our pleasure to talk to you, and we look forward to the Q&A portion here at DEF CON Biohacking Village. Hello.
Okay, so we are live. So thank you so much, Patrick and Bill, for that fantastic talk. Same format as before. JR will be keeping track of what is being said in Twitch, YouTube, and Discord. So with that, JR, the mic is yours.
Thank you. And thanks to Patrick and Bill for their presentation today. Our first question comes from Snoochie Boochies. Real quick, Snoochie Boochies wins Friday. He gets, or they get, the JR award for today. Really means nothing other than they're awesome. So their question that comes in is, this is the device part you chatted about earlier. The question is, how does your model apply to the data supply chain? For example, the Fitbit aggregation discussed earlier as part of the AOUS. I just need to download the PDFs and try it.
So yes, I encourage everyone to download the PDFs and try it. We talked towards the end there a little bit about using this model on third parties, on your vendors and on your supply chain. So again, it depends on the system you're trying to model. In our example here, we're modeling a system as a device, but that device includes the vendor who is supplying it. It includes the vendor who is shipping it and doing fulfillment. It includes the data stream back to us. In our Fitbit example, we have a third party that sits in between us and the Fitbit that a participant would have to enable that. So we're going to go do a vendor assessment on that portion of the system, but then we're going to try and model the entire thing.
Thank you for that. We also have a couple of questions from our Discord server from NIMS. One inevitable question, do you use any tooling or automation to capture your threat modeling information? And if so, how is it ultimately consumed by other teams?
Do you want to take the first part of that? I'll take the second part of consumption.
Yeah, sure. So we have a GRC platform called ZenGRC, and we have turned all of these documents that we're using into structured questionnaires on there. And when you fill those out, it auto scores them and records them. And so we can do these and track them over time. We can do the same model on the same system multiple times. Like we may, for key vendors, do a new one every year and look at how the risk score changes.
And then from a consumption across the organization perspective, the output of all of those scores actually gets digested, if you will, by everyone else. So we just, as we mentioned in that, finished the risk assessment for this year. The risk assessment presentation goes out to our senior leadership team. It's a structured set of data that tells them year on year what their risks are from that perspective. So it's maybe not consumed from an IT perspective, but from an understanding and a constant language across the organization. It's used by everybody.
So as an example, the risk assessment we did, we said we modeled, what was it, 26 processes. We came up with about 80 action items that we were then able to prioritize and feed that back to the owners of the various systems. And that then helps drive budgets and OKRs and stories for future requests, so that a year from now, when we come back and assess it again, we expect to have gotten better.
Yep. One more comment on that one. It tends to be the case that people like the snazzy new things as opposed to fixing things that are just the way they've been for a long time. Having this as a structured process also lets us say, okay, that thing that we were looking at 2 years ago versus this new snazzy thing, they both have weights. So we actually have a way to compare those two. And maybe the sexy thing doesn't actually win in that case because we've let that one sit for a while.
Good point. Adam Showstack on our Discord server asked a question. What do you mean by brainstorming? I think we're using the term differently. For example, I wouldn't say Stride brainstorming. I see that as a set of structured activity from Stride as a checklist across the whole system through Stride per element or interaction. What say you?
I agree with what he's saying. I would never, ever contradict anything Adam Showstack has to say. However, what we tried to do is make room for a very structured approach and also a somewhat unstructured approach where smart people get together in a room physically or virtually and think about the things that can go wrong. And the biggest impact of that is as we go through our brainstorming worksheet, we're able to better understand what are the goals of the system. And then once we understand the goals of the system, we can take the very structured includes no dirt questionnaire and answer those questions based on what the goals of the system are and the features and the controls of the system as we understand it.
Quiet Mike asks a really good question too. Have you explored bridging from these threat modeling processes into financial risk quantification such as FAIR, which is more aligned with a C-suite level ERP assessment need?
That's a fantastic question. I mean, I think, so in Omada, I am the compliance and our internal audit organization. This aligns with my internal audit practice. It doesn't necessarily feed into the financial side of things, but we start to get closer and closer to being able to have a regimented language. That's actually a fantastic point. I think it's worth exploring. It's Quiet Mike, right? That's a great point.
It is Quiet Mike.
All right.
One last question. This is from Ice Night Vapor, also in Discord. Does the process also include a step to verify the security controls that are implemented and provide the mitigation expected and implemented correctly? For example, the level of TLS.
It can. It depends on the system. So remember that this doesn't exist in a vacuum. This is one set of activities that we do within a continuum. So as an example, we talked about consuming existing controls like authentication. And if the system is going to use the authentication mechanism we already have set up, we can move on from that. Well, separate from this threat model, we're also auditing and assessing the effectiveness of those controls. However, if there's a specific control that is in place for this particular system, either during the threat model process or soon after, we want to verify that. So if we are concerned with, in your example, Ice Knight, the level of TLS that's being used, we may check it during the threat model process, or we may make that something to go audit later on. But either way, yes, we want to know if the model is dependent on TLS 1.3 being the only TLS acceptable, we then want to go check it to make sure that that's the only one that's working.
Yep. That's definitely something that's easy in our organization because there's not that many people that would actually be doing the control audit in this particular case. The point we made about talking across your organization and making sure that there's alignment for that. If you're in a large organization, that control test may be done by somebody like an IT risk organization. So plugging into them, making sure that you actually have all of these pieces together is sort of a multiplier effect, really, for the effectiveness of the whole process.
And we talked about the result of the model being action items. And sometimes the tests you're referencing are actually action items of the model. So, yep. And that is especially true when we're dealing with vendors, where we say, okay, one of the action items is to go negotiate a contract term around something like data locality. And it may also be to verify that they're compliant with that contract term. Pretty common, we'll have a contract term that says that a vendor must maintain a SOC 2 or a high trust for the length of the contract. We then are also going to go grab that SOC 2 or high trust report, and we're going to analyze it as well, looking to see if there's any gotchas hidden deep inside it.
I think that answered all of the questions that we have. I'm double checking our feeds. I'm getting a lot of great presentation. Agreed. Thank you so much. And you know what? All the thoughtful questions during these presentations, everybody gets JR awards today. Again, they're not redeemable for anything.
Well, thank you so much, Patrick and Bill, for your presentation and hanging around for the Q&A. And thank you so much, JR, for guiding us through this Q&A. So this wraps us up for day one. If you liked what you saw, all of our videos will be up on YouTube. Pretty much they already are or will be in a couple of minutes. So please go and subscribe. You can also follow our Twitter and you can also follow our Twitch. We will be live tomorrow at around 10 a.m. PSD. So we will see you then. Thank you so much.
Thank you all.
Thank you, JR.